Check sound check.
Good morning, everybody. After having yesterday a very good dinner and good songs, I think we'll start today today's program and we'll request speakers also to stick to the time, please, so that we should not get delayed. So herewith I will invite Dr. Jitin Bajaj and he'll be talking on rocker technique for reducing AAD. Dr. Jitin Bajaj, please.
Thank you, respected chairpersons. Thank you, Ashish sir, for giving me the opportunity. I'll be speaking on yet another technique to reduce and realign the atlantoaxial joints and reduce the anterior atlantoaxial interval, whether or not the pathology is associated with baseline vagination. So we all deal with the atlantoaxial dislocation, and it has become one of the very common surgery now. There are various techniques ranging from wiring, transarticular screws, anterior odontectomy, and fixation. Gold standard now being C1, C2 fixation. Then the TCR technique, which requires occipital cervical fixation. The anterior facetal realignment introduced by Professor Salunke, and also lately Yadav sir described endoscopic anterior release and fixation. The opening of C1, C2 joints has and then fixation has become the workhorse for most of the cases. And this has shown to be biomechanically very strong, even in the long term. However, in certain cases, like you can see in these left and right pictures, even after the opening of joints and fixing them, although the basilar invagination has reduced, but AAD has in fact increased. So this problem everyone must have seen in their lifetime, that somehow some cases become weird, and it's difficult to reduce the atlantoaxial dislocation on table. Sometimes we need to bend the rod. Sometimes we need to put a longer C1 screw to deal with difficult situations. So as I said, there are many techniques. Although all these techniques are excellent, but I thought of some simplifying the technique and having some simple instrument without need of any additional implants or fancy things. So our aim was to simplify instrumentation. They reduce the complexity of the surgery, enhance the atlantoaxial reduction, anti-atlantodental interval reduction, without applying any additional implants apart from the usual C1, C2 screws. So this rocker instrument is commonly available in all spine sets. This is again commonly used in the lumbosacral region, however, very infrequently used in the CV junction area. So if we see, this is very biomechanically and physically very aptly made. This has a short, even to this has a short anterior arm and a long posterior arm. And in the anterior arm, there are knobs which can be applied on the C1 screw. This posterior bend thing can be put over the rod or the C2 screw. And with the lever action, the C1 screw can be pulled back and C2 screw can be pushed ahead, like in this manner. This was the normal scenario in any C1, C2 dislocation. So after applying through this instrument, we can pull the C1 screw, C1 back and push C2 screw ahead, and thereby reducing the translation. Yes, I'll be doing the video also. So, and as with the Archimedes principle, this long lever arm, this helps in reducing the force application. Keep in mind, this is a very powerful technique, and we may in fact push the C2 ahead also. And so, so we did a prospective study in 55 patients, and few had BI also. We determined all the preoperative assessments in usual manner with usual investigations, and we had a post of follow-up of 6 to 12 months. So the surgical procedure was skull traction, then joint preparation by opening the C1, C2 joint. If the OC1 is fused, then also the surgery can be done. In these type of joints, this is pseudo joint and this is true joint. So we need to drill out the dorsal aspect of C2 facet and then reach to the joint. The skull traction also helps in making realigning the joint. And once we reach to the joint, we open the joint with the chisel in by a rotating maneuver. We insert the C1, C2 screws normally, C1 par, C2 pedicle screw. We can put C2 par screw also. And then we apply the rocker followed by rods. Please keep in mind that in congenital cases, the posterior rim of C1 can press over the cord. So we need to be liberal in doing foramen magnum decompression and C1 arch removal before realignment. The neuromonitoring was also used in few complex cases, SCCP and MEPs. So once we, this is a short video. So this is after the putting of C1, C2 screws. Normally C1 screw is ahead, ventral, and C2 is dorsal. So we loosely put the rod, loosely tighten the C2 screw head, any, and then we apply the rocker. We catch hold the C1 screw, and then if needed, we can realign that also. And then slowly push the C2 ahead, pull the C1 back, and then we can apply the any, which was difficult initially. And slowly you see the joints being getting parallel. After that, we need to compress it because fusion happens better in compression. And also the retroflexion of dents that also reduces with the compression. So what Professor Chandra has described the DCR with occipital cervical, we did the same steps in C1, C2. So this is the same pictorial. So in 53 out of 55 cases, we could apply this technique. In two of the cases, the vertebral artery was bilateral, very anomalous, and we could not reach to these C1, C2 joints. So in those cases, we did occipital cervical. And in one case, we required odontoectomy also. The mean age was 40 years. There were 30 irreducible and 25 reducible cases. 32 were baseline vagination. Most of the pathologies were traumatic and congenital. There was significant improvement in AAD and BI was successfully reduced in all cases. There was also functional improvement on modified Ranawat grading. I'll be going through a few cases from simple to complex. This was a simple case, bilateral horizontal joints, minimal AAD. So it was reduced with the technique. This was the same example I showed initially. One side oblique joint, bilateral oblique joint with the baseline vagination and AAD. So this is intraoperative picture showing initially C1, C2 screws. There is still presence of AAD. And after the rocker instrument application and tightening the rods, you can see nice reduction of AAD, which we can perceive in the postoperative picture also. So we did a FMD with the C1 arch hole dissipation. And the joint transmission, we can note this is now through the joint. And the patients are in follow-up. And the hypothesis is since the weight transmission is through the joints and not through the pseudo joints, there will be enhanced fusion. And there will not be cranial settling, which we often see in mal-aligned fixations. Another patient, congenital AD, one side vertical joint, one side oblique joint, baseline vagination, atlantoaxial dislocation. This is before application of rocker, and this is after application of rocker. And you can see nicely reduced BI and AD. And this is again one side C1, C2 fixation and one side laminar screw fixation. So this was because the artery was very high riding. It was not allowing to put a C2 screw in this particular. So this technique is can be applied in different scenarios. Another patient, bilateral vertical joints, difficult congenital AAD, very high this atlantoaxial dislocation, severely compromised cord. So again, C1, C2 fixation. And this is after application of rocker. And you can see the AD also reduced. So the complication of this technique, we found a few surgical infections, occipital ulcers. However, as we have utilized liberally FMD and C1 arch removal with the neuromonitoring, there was fortunately, no mortality or neurological deterioration. In one of the cases, we did one-sided occipital cervical and one-sided C1, C2. And in that case also, we could reduce with sole C1, C2 application of rocker in sole C1, C2. So the technique has advantages of being a simple technique. It's a versatile technique and cost effective, no additional need of implants. However, we should note that the joints have to be opened, and that is the basic thing for the CV junction surgery. The joints have to be opened and drilled up to the anterior margin to make them free and glide over each other. It is not a panacea. In the rotational anomalies and in bony anomalies, which are like orthodontodium, we still need to do odontodectomy. We haven't tested it for rotational anomalies, and we have also not compared this technique with the existing established techniques. So to conclude, this technique is a safe and effective alternative for managing AD with or without basilar invagination. It offers a promising solution for both simple and complex cases with challenging joint orientations. However, it warrants further investigation to solidify its role. And this technique has also been accepted in operating. Thank you.
It's wonderful. Simple case that you showed as an example.
Yes, sir, maybe.
That is how one should go.
Sir,
You do a angio pre-operatively.
in all cases, we do CT angio. And in assimilated cases, we need not to differentiate whether we are putting in C1 little mass or in condyle, because they are in the same bone. So we need to have a rigid fixation. So whether we put in C1 little mass or that is continuing with the condyle, we can put it there also.
Very similar technique, but only a different way, is the use of screws.
Yes.
So what happens is so as you are tightening the screw, sort of gradually pulls it up.
Yes.
So that is another way of doing the same thing. And uh, for the audience here, we just requested the implant fellow to get that manufactured. So they are simple lateral mass screws, only like as we have in lumbar spine reduction screws. We have similar. So it gives you that height.
Yes.
So when you're tightening, it sort of
Yes.
jacks it up.
Yes.
So that is one. The other was what was the need of going to the occiput on one side in one of your cases?
Because we could not put, because of the vertebral artery, dominant vertebral artery going right across the joints, we thought it was not safe to mobilize the artery and get into the seam. So that's why we went to the occiput in one side.
Well, the minute you go to the occiput, your implant is in danger of failure.
Yes.
So I think we need to try to do more and more of just C1, C2 rather
Right.
than crossing the junction. Also, there was one observation that in one of your cases, if you see the C1, C2 screw is fine, but the rod is extending up to almost C3 to C4.
Yeah, that's a long route.
Yeah, it's a wrong. So that also again acts almost like a OC3 fixation.
But we didn't put a screw in the C3 or C.
Yeah, but the facet gets locked when the patient is moving, and there is extra pressure on the existing C1, C2 screw. So there's a very beautiful article by Momaneni in 2009 Neurosurgery, where they have compared the results of OC3 with C1, C2 and just C1, C2. So, and there's a drastic difference between the failure rates.
In all cases, we put both. Yes.
And how much force you apply for that, when holding the screw and pushing over the C2?
That is variable, sir. When the joints are free, then a lot of force is not needed. If the joints are free, I mean, when we drill up to the anterior margin, and we just put that sort of force that the joints become realigned. So if we put some extra force can in fact lead to anterior pushing of C2 in fracture
Can
cases.
go, yeah.
So
I'm telling how much,
yes,
you have to be
this is
careful
a
applying the-
caveat for this.
Yeah.
No, sir. No biomechanism.
Must be, the C-arm you must be seeing
Yes.
when applying gradually.
Yes, sir. Intraoperative fluoroscopy
At a
is
time,
needed.
gradual applying and then just watching how much it is applied.
In general, the screws become parallel. C1, C2 screws become parallel.
Okay.
That's one intraoperative thing, and definitely intraoperative fluoroscopy helps. Thank you, sir.
Move to the next speaker, Dr. Anil Sharma. He is the professor and head of the department neurosurgery, AIMS Raipur. And he will be talking on vertebral artery mobilization in C1, C2 fixation.
My greetings and thanks Ashish Tandon sir for inviting me. I'll talk about mobilization of anomalous vertebral artery and CV junction surgeries. So we may encounter these kind of cases where bilateral vertebral artery is below C1 joint. So what we do? So as we all know that trained in cerebrovascular CV junction surgery, there is paradigm shift over past 2 decades and recent trend is toward posterior fixation. And dealing with C1, C2 joint in most important aspect, because over period of time, the strength of implant will fail and the strength of fusion will increase over period of time. So dealing with C1, C2 joint is the most important aspect. So this is the normal course of, but this is the normal course of vertebral artery, where vertebral artery lies at superior aspect of C1. This is normal course, B3 segment. And this is the normal course. You can appreciate here. So there can be various representative anomalies, and vertebral injury to vertebral artery is one of the most dreaded complications of CV junction surgery, and it can lead to catastrophic consequences depending on amount of area vertebral artery supplies. So there can be various representative anomalies. There can be persistent first intersegmental artery, fenestrated vertebral artery, anomalous origin of pica, and anomalies in occipitalized atlas. Vertebral artery anomaly can be associated with quoted range at 4 to 20% of cases, and particularly in congenital AAD. So this is a young boy presented with history of trauma and quadriparesis. Can appreciate preoperative and postoperative imaging with the preoperative and postoperative MRI, and can appreciate axial C1 and C2 screw, C1 lateral mass and C2. And then over long term, that fusion we need to look for. We can appreciate here fusion between C1 and C2 joint. This is fenestrated vertebral artery. Fenestrated means there are two branches. One branch lies normally at superior aspect of C1, and one branch courses beneath posterior to C1 C2 joint, right at the entry point of C1 lateral mass screw. This is another patient where vertebral artery is anomalous on the left side. It can be appreciated in reformatted computed tomogram scan, and these are the below are the postoperative scans. So here in this vertebral artery was anomalous and bilateral both side. So, but presence of vertebral artery below C1 and posterior to C1, C2 joint should no longer be viewed as a hindrance, because even if we are not putting a screw in C1, the dealing with joint, decortication of joint, that is the most important aspect. So subperiosteal dissection is the key, and frequent use of Doppler. It will help in uncovering the vertebral artery, and as we progress in the surgery, it will help in identify of vertebral artery. So here dissection is being done. It's mix of blunt and sharp dissection. So vertebral artery lies usually anterior to C2 nerve root. So first we will encounter C2 nerve root, and cutting of C2 nerve root provide panoramic view and wide exposure of C1 lateral mass. And anterior to this will be vertebral artery. So now C2 nerve root is being dissected, and anteriorly we can appreciate the vertebral artery. So C2 nerve root is being cut sharply after coagulation, and frequent use of Doppler is very, very paramount. So while putting a screw, but vertebral artery can be mobilized inferiorly while identifying entry point, and while dealing with joint, decortication of joint, vertebral artery can be mobilized superiorly. Now joint is being drilled, joint is being prepared, and graft is being placed. Now C1 lateral mass, screw entry point. The same maneuver is being repeated on the another side. So here we can appreciate the vertebral artery. Now joint is being prepared, sharp cutting with knife and drilling. Joint is being decorticated. And here we can appreciate after putting bilateral C1 lateral mass and C2. So we need to take care that vertebral artery is not compromised by screw head. There should be enough space between screw head and vertebral artery. And that can be confirmed with Doppler also. This is another case. So this is, see, first we need to identify C2 nerve root ganglion, then anterior to this will be vertebral artery. So with blunt hook, it's very easier to dissect the vertebral artery. Vertebral artery is being coagulated and sharp is being incised sharply. C2 nerve root. So we can appreciate anterior to this lies vertebral artery. This is C1, C2 joint. The C1 lateral mass is being dissected. Vertebral artery is being mobilized inferiorly for putting C1 lateral mass screw. Now C1, C2 joint is being prepared and being decorticated. The same maneuver is being repeated on the another side. So this is the view we get after exposure, but now graft is being placed. Here again, on left side, there was anomalous vertebral artery. So we can appreciate C2 nerve root that is being dissected sharply. And it's being dissected with blunt hook. It can be separated easily from vertebral artery. And we need to take care of venous plexus, which sometimes bleeding from venous plexus can be very troublesome. Now C2 nerve root is being cut with scissor after coagulation. And here after cutting, it provides panoramic view of the vertebral artery. And now C1 lateral mass and joint is being decorticated. So this is the view we get after cutting of the C2 nerve root. Here we can appreciate vertebral artery, C2 nerve root and C1, C2. And this is the view we get after putting a screw. Need to take care that vertebral artery is not compromised and there is enough room to accommodate the vertebral artery and it's not getting compressed between a screw head and fascial surface of the vertebral artery. This is on the another side. So there are some images. There we can appreciate in the CT there is severe cervicomedullary compression. And these are the postoperative images where vertebral artery was dissected. So that in this we could not put a screw in the C1 but joint could be dissected, could be decorticated, and occipital and C2 screw was placed. This is the another patient where bilateral vertebral artery is lying below C1. Here we can appreciate it bilaterally. Vertebral artery is below C1 and just posterior to C1, C2 joint. And these are the images. Another patient where vertebral artery lying on right side, vertebral artery lying below C1. There's severe cervicomedullary compression. We can appreciate preoperative and postoperative CT. AD and BI has been reduced. This 7-year-old girl presented, she was operated previously elsewhere and wiring was done that we can appreciate in the first image. And she presented with progressive weakness and deterioration in power. And this is severe cervicomedullary compression. And we can see overhanging of C1 and C2. And this we can appreciate post-operative images and fusion. This one 16-year-old female, though she was able to walk, but presented with myelopathy and mild weakness. There is AD with orthodontoid. And this is preoperative and postoperative MRI. And bicortical purchase is recommended in C1 lateral mass. This one 9-year-old girl presented with quadriparesis. Vertebral artery is abnormal, lying below C1 and posterior to C1, C2 joint. And posterior arc is deficient on the left side. And there is severe compression and serings. This preoperative and postoperative image. Again, screw was put in occipital, could not be placed due to anatomical constraint in the C1 lateral mass. This one 50-year-old gentleman who presented with quadriparesis, and this was chondrosarcoma. Here we can appreciate the vertebral artery. There is a bony lesion with soft tissue lesion, and vertebral artery is normal on left side, but it's abnormal on the right side and lying below the C1 and posterior to the C1, C2 joint. These are the preoperative images. We can appreciate the bony overgrowth and compression. This is the MRI. So in this, vertebral artery was not dissected because only C2 pedicle was destroyed by the bony overgrowth. So screw was placed on C1 and C3 and C4. C1 lateral mass and C3, C4 lateral mass. So C2 was destroyed. This 20-year-old gentleman presented weakness of all 4 limbs, multiple. This preoperative and postoperative images. This again, 14-year-old girl presented with weakness of all 4 limbs. We can appreciate the preoperative and postoperative images. There is complete reduction of the AD and basilar invasions. So take-home message is dealing with C1, C2 joint. That is the single most important aspect. I said earlier, even though sometimes due to anatomical constraint, we may not be able to put the screw in C1, but that C1, C2 joint should be decorticated. And that's how we will be able to reduce the AD and basilar invagination. And C1 lateral mass construct is superior as compared to other construct. And first screws should be put on the most easily approachable, safest side and normal side. If non-dominant side, normal side, and easily approachable side. Because it will help in reduction of AD and manipulation of the joint on the another side also. And presence of vertebral artery should no longer be identified as a hindrance to approach the atlantoaxial joint. And identification is the most important. CT angiogram is must in all congenital AAD cases. And preoperative morphometric assessment of vertebral artery for its size, anatomical course, relationships to the adjacent bony landmark is very crucial and very paramount for surgical safety. And Doppler can be an important tool during identification of vertebral artery and uncovering during, as we progress during surgery in uncovering of the vertebral artery. Thank you. Thank you.
Yes, please.
Like temporary clip in future ready before mobilization or
Yeah.
any incidents of.
Yeah, yeah, it's, if it's like we are planning to dissect the vertebral artery, we keep ready that.
Any
But I
incidents
have,
of.
I have not encountered.
One more question from my side is, Dr. Sharma, when you fix up the condyle, occipital condyle, do you have a restriction of the movement post-operatively of
Yeah,
the head?
post-operative restriction will be there. Usual post-operative, because that normal mobility that will be lost.
Yeah.
Thank you, sir.
Thank you.
So now I'll call Dr. Umesh Srikanta, sir, for his presentation on minimally invasive technique for reduction of difficult spondylolisthesis.
Morning, everyone. Wonderful to be here at the outset. I would like to thank Dr. Ashish for inviting me to this wonderful city and this conference. My topic. Sorry. So I think MIS TLIF is no longer unknown entity for us. I think we have seen that a lot of MIS TLIF examples being shown in different conferences. It's being adopted in multiple centers across the country, and MIS TLIF is coming up in a very, very big way. And you would have seen a lot of examples of these simple listheses that have been reduced and distracted by using minimally invasive technique. It's not a big deal. Half of these reduced by just positioning an interbody distraction. Even if they don't reduce by just a distraction, many times what you can simply do is put your percutaneous screws on the other side, use the screws to reduce and do your interbody valve fastectomy from the other side as it is shown here. But these are not routine situations that I'm going to discuss today. So what about in high grade listhesis? So how do we tackle these? What about the severely collapsed disc space with a grade 2 or a grade 3 listhesis? What if there is a severe facetal hypertrophy and a severe canal stenosis associated with the listhesis? Will we be able to achieve a good or a similar amount of decompression and reduction and interbody fusion while maintaining a lordosis and while maintaining spinopelvic harmony? So that is the big question that we are going to discuss. Now, before we go into the case examples, I just want to reinforce that there are several basic principles in listhesis surgery. One is you need to have a good anchorage, that is percutaneous pedicle fixation. Now, I'll come into these topics one by one. So we know that with the present era, with the present CM images, we will be able to put in good amount of percutaneous pedicle screw fixations with regular CMs. And even in these cases, MIS is beneficial because you will be able to achieve the triangulation because you have a much more lateral entry point, which helps in a better screw anchorage than putting in a straight forward screw. As most often happens during an open surgery because of limited exposure sometimes. So again, with the presence of navigation, even in difficult cases, partial vertical body instructions, even in severe cases, dysplastic listhesis, dysplastic pedicles, small pedicles, we'll be able to put in a very good screw purchase using navigation techniques. So anchorage is not a problem. MIS will be able to achieve good anchorage as effective as in an open surgery. What about adequate decompression? Will we be able to achieve the amount of decompression that we can achieve in open surgery? Because that is the primary objective of our surgery, that is neural canal decompression and relieving the patient symptoms of claudications or radical abdomen. And especially in these kind of joints where there is a severe calcified facets associated with listhesis. Of course, it is possible you need to just change our attitude. You don't have to just do an unilateral interbody approach like we do in a regular case of an MIS TLIF. We do usually in these cases bilateral ports. You can come in with the tube sequentially one side, followed then by the other side, and you can do a good bilateral amount of decompression, bilateral canal decompression with this kind of thing. But in some cases, it is not always necessary to do over the top, or necessary to do a bilateral ports, even though there is a severe listhesis and bilateral compression and bilateral patient symptoms. So you just can angulate the tube to the contralateral side and do an over-the-top decompression, just like we do in a lumbar canal stenosis. And that is how these things can be achieved. So this is a pre-op as well as a post-op image of a case where over-the-top decompression has been achieved. So decompression also is not a problem for MIS as far as listhesis is concerned. So how about release? We know that adequate release has to be done in order to reduce the listhesis. So adequate release effectively means a good decompression. That means that you have to do a bilateral facetectomy. You will be able to do a bilateral posterior annular release, of course, with MIS techniques. You can do a bilateral discectomy, intradiscal bilateral manipulations. You can even release the lateral annulus in the extraforaminal area just by angulating the tube to the lateral side, which is possible. The only issue remains is an anterior release, which may be sometimes required in difficult cases, which possibly is more risky with a posterior approach, and that applies even for an open surgery. Now, so release also is not a problem. These are some examples where you can do bilateral manipulations. As you can see here, there is a screw on one side, already decompression has been done. And you can do, or sometimes you can even do bilateral intradiscal manipulations by sequentially putting tubes on both the sides. You can use one side to distract using an interbody distractor and do an interbody work from the other side, because sometimes in a collapsed disc space, you will not be able to enter the disc. So you achieve a distraction from one side, do your interbody work and end-plate preparation from the other side. Change the side. You come this side, you do an interbody distraction from the other side, and then achieve and do a good interbody work from the other side. So you can alternate and do a bilateral simultaneous or a sequential interbody distraction and disc space preparation. Now, we know that in many cases, in all these MIS screws that we use, and the reduction mechanism is inbuilt. So these are extender towers or reduction towers, as we call them. So usually, an reduction mechanism is not the problem in MIS at all. And as I've already discussed in MIS, the main problems will be decompression, bilateral release, of course, a good screw purchase. And good screw purchase can be done by, as I mentioned, good triangulation. You can use a dual-threaded screw. You can use a bicortical purchase, though it is difficult in MIS, it is sometimes possible. And of course, you can even do an augmented, cement augmented fixation, even with MIS techniques, as we are going to see later. So this is one of the cases, as you can see. So this is the technique that we use for reduction. You see, we anchor one screw here and put the INI there, anchor this, and then you can observe the gap between the screw and the rod there. And by sequentially tightening that tower that is there, different MIS mechanisms have different reduction techniques, and you can just tighten them and in order to do a good reduction mechanism that is there. How to deal with hypertrophic facets? So obviously in these cases, if you dock your tube is nowhere sitting on the lamina, it's sitting on the facet and it's very far at the level of the spinous process. So in these cases, what you can do is you can just drill off, or you can use a bone punch, in order to remove that hypertrophic facet joint or overhanging hypertrophy of the facet joint. And then you can actually advance the tube. It is called a redocking. You put in your redocking, you advance the tube, use a longer size tube, and then you will be able to do that. So this is a small video demonstrating that. So this is the facet joint that is there. We are not seeing the lamina at all. This is all muscle that is there. So you just sequentially remove the facet joint piecemeal. You can even use a drill. This is an osteoporotic patient, so we have just used a bone punch. It can be easily removed. Sometimes if the facets are calcified, you may have to use a drill in order to remove the hypertrophic portion of the facet joint. So you sequentially remove the facet joint, and then until you identify the facet joint line. You see that the facet joint line is there. You're not causing any harm to the muscle at this stage. You can identify the lamina there. Now, once this is done, you can see the lamina there. So we have removed the facet tangential to the lamina there. And once that is done, you can use a redocking. You just dock your tube onto that area where you have done that and insert your dilators again. And that in that way, you will be able to go into the on the plane. So this is the second redocking. This is how it looks. So this looks like a normal facet joint, and now this sustained sequential test steps can be continued. So what is the sequence of events that we follow? So I have told you multiple techniques that we use. What is the sequence of events that we follow in these cases where there is a tough or a immobile listhesis that is there? So obviously, augmentation can be done. This is a different example. I'm just put it here to show that cement augmentation can be done through MIS techniques as well. So the first step is ipsilateral facetectomy and ipsilateral. You dock in your tube on one side, do an ipsilateral facetectomy, decompress the ligamentum flavum, identify the disc space, go into the disc, do an ipsilateral discectomy and ipsilateral interbody distraction, remove the tube, put in your screws on the same side. You put in your screws, if required, you can use an augmented screws, and then put in your tube from the other side. So you come to the other side, you put in your tube on the other side there. And once that is there, from the other side, you again use that sequential distraction in order to achieve that interbody distraction that is required. At the same time, while maintaining distraction, because it is very difficult, if you have observed in listhesis, once you reduce the listhesis, it's very difficult to distract it because your screws are tight, your rod is tightly holding the screws are tightly holding the rod. Once you reduce, it will be difficult to distract. So while maintaining the distraction, we need to do a sequential reduction. You can just do a sequential distraction, reduce a bit, release, distract, reduce. So it should be just alternating steps, and then you can achieve a good amount of distraction in these cases as well. And as I showed, even in difficult cases of grade 2, grade 3 listhesis, good amount of decompression and distraction can be achieved. We have published this paper way back in 2018. Now we have a series of more than 40 patients of grade 2, grade 3 listhesis with augmented fixations. Every time augmented fixation is not required, similar principles as I told, nowadays expandable cages are available, and they are also help us a lot in achieving that interbody distraction that is required. And usually whenever we use expandable screws, we always put in expandable cages, sorry. Whenever we use expandable cages, we always put in an extra cage, because you know that expandable cages do not hold any bone. Even though we put some bone around the expandable cage, we always try to put a second cage. As you can see, there are 2 cages going in from the same side. That is also possible in MIS. But one thing that I have forgot to mention is spinopelvic harmony. How many of you believe that this is a very difficult case? You believe that it's a difficult case to treat? It's a simple grade 1 listhesis, flexion, and it is completely reducing. These are the type of cases that we say ideally for the first case, reducible listhesis. But you look at the disc angle, an L5S1 disc angle here in this case is 25 degrees. So with a posterior approach, we don't have any cage that is there in the posterior approach that is going to match this lordotic angle of the disc face. So invariably in these cases, if we do a fusion from a posterior approach, we will end up in losing the lordosis at the segmental disc angle. And obviously this compensation goes on to the next disc level, resulting in a hyperlordotic L4-5 or an L4-5 retrolisthesis or an SSH appendicis. So in these cases, it is always better to do an anterior approach, which we are going to discuss again in my next talk in the evening. So to summarize, even in difficult cases, MIS can achieve adequate decompression, release, reduction, fixation, and interbody fusion. You will be able to fulfill all the basic principles of spondylolisthesis surgery. Choosing the right approach and the right technique is important, but more important is to not compromise the primary objective. We have to still achieve a good decompression. Just because the disc space is collapsed, we can't do an half job in interbody preparation and end plate preparation. And we can't, leave the joint, we leave the disc space, the end plate there, and to put in bone graft, because anyways, it's not going to use in those spaces. Of course, there is a learning curve associated with this, and it's better to start these kind of difficult cases in the later stage of care. Thank you so much.
Thank you, sir. Any questions from the audience?
Yes, please.
How do you manage the spondylosis or grade 4 listhesis? Is it possible for?
It is possible. So we have done some 1 or 2 cases, not shown the examples here. Spondyloptosis, no, but grade 4, yes, it is possible. So the grade 4 listhesis starts from the time of positioning, of course, like you do your open cases, you position with the hip extended, you see how much of a opening of the joint happens when you extend your hip joints. And in case if you are able to find some amount of space there, then it makes it worthwhile to do an MIS in those cases. But if it is not opening at all, there is no amount of movement there at all. In these cases, it's always better to go back to an open surgery. In the spondylolisthesis also, in the grade 4 listhesis also, it is a similar technique. We do unilateral first, you do bilateral. Dr. Arvind Kulkarni believes that he reduces every grade 4 listhesis with a unilateral approach, but somehow I have found it slightly difficult to reduce this more than grade 3, borderline grade 3, grade 4 listhesis by just a unilateral approach.
Yeah, by hyperextension the thighs can reduce grade 4 listhesis become grade 3 or
Yeah,
grade 4.
that itself is
that,
enough. So
uh,
if that much movement is happening
Yeah.
in positioning, then you can go ahead with an MIS procedure because you know that you will be able to pull it back.
Yeah, any tips for the bicortical MIS screw?
Yeah, so when you do a bicortical MIS screw, usually, what we do in those cases is you put in your Jamshedi. You make your anterior cortical hole with a Jamshedi. But then you withdraw the Jamshedi to just beyond the pedicle and then put in your guide wire. So most often what happens is the marrow, sometimes the marrow, the spicules that are there, they will prevent the guide wire from going further because Jamshedi is a very small needle. So most of the times we have observed that the guide wire doesn't easily go through the anterior part unless you push it through. So you just put it there, avoid any kind of a inward pressure on the guide wire. And as you are putting in your tap, you just tap beyond the pedicle. You don't have to use the tap beyond the anterior cortex because most of these cases where you are planning to achieve bicortical fracture, you are osteoporotic. So you don't need to go all the way with your tap. You just stop your tap just beyond the pedicle. And then when you are putting the screw, once you are beyond the pedicle, beyond the pedicle, you can remove the guide wire. And these, because you have already made an anterior cortical hole, these screws can achieve a bicortical purchase.
But if there is slight angulation of the screw, it will miss the hole again.
It's of course that is something that you need to take care. You need to go in the same trajectory, but it is possible. Means we have not we have used bicortical screw not so often, but we have used augmented fixation more often than bicortical screws.
Yeah.
But if it is possible, so far we have not had any major issues. And most of the times these are osteoporotic patients. It's easier to reach the anterior cortex. Yes, please.
High grade, but at times the distraction happens on the extenders which are not that strong. So which is your favorite system?
So I never use the screws. In fact, if you saw there, I was never using the screws or the towers to distract the interbody. It's always an intradiscal distraction. So we have different techniques. So sometimes I had a video, but because of time, I didn't show. So if the disc space is too much collapsed, the smallest distractor, usually we don't use a shaver in these cases, the sharp shavers. We use a hookah, that is a distractor, blunt edge distractor. So the smallest size that we have in our setup is 6. And sometimes even that doesn't go in. Even horizontally, that doesn't go in. So we use an osteotome. We have an osteotome. The osteotome creates that gap. We don't turn the osteotome fully. We just wiggle it a little in order to just disengage those two bones to create enough space for our first distractor to go in. And that is our first. Once we do a little bit of distraction, once we achieve a small amount of distraction, we can pass an upcut just next to this and remove the posterior annulus on either side of the small window that we have created. And that gives us more amount of space. And then we move the distractor from one, if we have inserted at one point, we move it laterally and medially and then use the same distraction technique. So sagittal imbalance is an important thing. So usually in these cases, that is where I'm telling now the expandable cages. Nowadays we have expandable cages that go up to 15 degrees. So with those kind of expandable cages, we have lordotic expansion cages. That is the posterior edge. The posterior height of the cage remains the same. Only the anterior one expands. So we have those cages available. So that will be important. And nowadays it is a routine in our institute to calculate PI, PT and SS for all these cases, LL, in all these cases to see what is the pelvic relations. And if there is a gross PI-LL mismatch, obviously we resort to using, though at an extra cost, to the patient, we convince them and we tell them that it is important that we use those expandable cages to maintain or restore that lordosis at that particular segment. So far, even in grade 3, grade 4, we have never gone. So the solution to correcting pelvic instability is not increasing your fusion levels. As you know, the segmental correction has to happen at that segment. The more loss you have in one segment, you will have to overcorrect at the next segment. So usually it is not advisable to extend. It is better to go anterior, do an anterior ALIF or an OLIF procedure and restore that anterior, the lordotic angle by doing a good anterior relief rather than trying to undercorrect and doing that at 2 levels. Because ultimately that is again going to lead to further loss of lordosis. So a good decompression, the solution to preventing post-operative L5 stretch injury or stretch palsy or stretch radicalitis is good decompression. You have to angulate your tube because most of the time in MIS, again, that is something that point I forgot to mention. You're coming from lateral to medial. So you are going into the canal, you are going into the disc space. And most often it is natural tendency to forget the extraforaminal component of the L5 or when you're doing L5 as well, the extraforaminal component. So it is always important to angulate the tube slightly straight rather than from a lateral to medial angulation, make your tube a little straight, release that extraforaminal segment of the nerve root.
I think we had lots of questions. Thank you, Dr. Umesh Kumar. We'll proceed for the next lecture is by Dr. Rajnish Kachra. Dr. Rajnish is a Director Neuroscience, Medanta Super Specialty Hospital, Indore. We welcome you, sir. And he'll be talking on CV junction interstice cases he will be showing.
Thank you, Chairperson. Thank you, Dr. Ashish, for including me in this program. And I will show some cases of C2 fractures and with instability. How we have managed, and I would prefer that it should be an interactive. You can correct me if we have done something wrong with these cases. Our experience is very limited. Actually, I have been trained from the Chitra, and we never used to get any trauma there. Our trauma training is in the NIMANS, and that is too limited. So during our training time, we used to get only the congenital AD and long back. The procedures used to be wiring fixation, then road, and the newer trend now, the C1 C2 fixation is now the current trend for the fixation of this kind of cases. So we are still learning, and we'll try to show you some of the cases. So as has been discussed earlier also, the C2, the common fractures is odontoid, and there are 3 types of fractures. And again, the other fracture is the hangman fracture, which is through the pars. So I will show you some of the cases here. This is a gentleman, 62-year-old fellow, who has come following the road traffic accident. And he was in a respiratory difficulty, he had a anesthesia and immediately we had to put him on a ventilator and we investigated, we have found the frontal fracture, which is displaced posteriorly in the severe canal compartment. So after putting him on the traction, on ventilator, we had put him on traction, see if it reduces. So this is the image after putting on traction. So it is nicely reduced, and then we went ahead with the surgery. Uh, we did the anterior and posterior, anterior ornamental screw fixation, and followed by the posterior C1 lateral mass and C2 translaminar fixation. Whatever cases I have done is to the translaminar, and it gives a very good strength, very good fixation. C1 lateral mass and C2 translaminar. So this is case managed with the anterior screw fixation and posterior C1 lateral mass, C2 translaminar. He had a very good recovery, and this is the follow-up. His deficit, everything resolved, and is completely and very good neurological status. This another patient, he has come with a massive polytrauma. Massive polytrauma means everywhere he had an injury, and he was admitted in some another hospital for 3-4 days on the ventilator, and he was shifted. On investigation, we have found the sleep fracture, ligament fracture. He had a fracture of sacrum, pelvis. He had a multiple rib fractures. So this patient, and he had this small impact. He also had a injury. So he came on ventilator. The first issue was his chest. He had a kind of ARDS picture. We improved his chest, and then initially we planned to put stabilize this C1, C2, C3. So there is a C2, C3 location, and you can see the axial. There is a clear like radical fracture, and there are inside dislocation. So we had put C1, C2, C3 screw, and then he continued on the ventilator. Then we thought, let us fix this pelvis. He remained stabilized for 3-4 days. Then we asked our orthopedician to fix this pelvic fracture. Then after that, we did CT scan. We found there is a angulation here. So there is a, again, kind of the space when the anterior and posterior segment. This. So we thought we should do a posterior fixation also. So, but the posterior fixation, the one side pedicle or the parts will completely shattered. We are able to make out on the left side that we can put any screw. So here, what we did is we stabilized with the T1 lateral mass. T2 on one side we could put the screw. This is on the left side. We somehow could formulate it with the pedicle. The one side is the C3 lateral mass. So, and then patient did extremely well. Actually, he is recovering. He had lower limb weakness, from which he is recovering now, and he is very much improved in his neurological development. So this is anything, any other idea from the audience? I just want to know what better nobody else would have done for this patient. I don't know what we have done is in the present circumstances. What we have done is good. So these are the post of the CT scan. So This another patient is a young boy with 20 years old, football player. I think he must have had a cardiac trauma he had. And he had a posterior circulation stroke. Sometimes this patient can have this kind of we presented in this with this kind of picture. And one interesting thing he was not to have planted sepsis. And then we had operated this patient. I will just show you the small video. Again, this is the C1 lateral mark. And I don't sacrifice the C2 roads. I just look at the interior. One of the cases I have so far I have operated 50% with the C1 that's not C2. This is we bring the margin of C1 to create the base there. Have to know the margin and the margin of the margin and the margin from this side and the left side to the left side. This is another patient with again the posterior dislocation. It's not so much there. Again, post-traumatic case. Put the one that you have and this is the patient again, hangman fracture. He is a young boy without any deficit he has presented. And this patient I had operated and managed very long back, almost 20 years now. And this patient was just managing the hello brace. And he had a good fusion. This is the CT scan. This fused well, and he remained perfectly fine. So sometimes these patients can be managed with the conservative hello brace. You can even maybe for 3 months to have joined this fracture heals. Another case of frontal fracture with the atlantocerebral dislocation, we have put this reduced and fixed with this cervical board. Now this technique is, I think, no longer being used, but still sometimes the poor patient can do this. This is another patient with post-traumatic atlantocerebral dislocation with fracture, and we have managed with the growth. Thank you. These are the any comments on that patient C2 fracture, that hangman fracture, the second case which I wrote with anterior the C2 was completely, anything better would have been done for the patient. Other side was not possible to cannulate. There's a lot of gap between the fractured body and the pedicle was not seen. Parts is not seen. Yes. So on the one side with difficulty we could manage about 1:1 C2. So this is recommended actually. If it's not able to put in the C2, You can fix with the C1 and so completely fix it.
Yeah, in many cases of these hangments where the C2 is completely shattered, where the C2 bars and there is no purchase or a direct bar screw is not possible. It's always better to go to C1.
Yeah. Thank you.
So in the same case, I would have also thought of vertebral artery dissection because the CT that you showed, there was an infarct. So few of our patients in the past we have got where there has been a vertebral dissection and there is a thrombosis and an infarct. In that situation, we got interventional specialist involved because there was a risk of
It was quite sick actually. He remained for a long time. Then gradually went step by step. 3 4 days interval. First we stabilized the chest. And he's a polytrauma patient. He had a massive bruises and hematoma in this one posterior. Because of the fracture pelvis. Pelvis is opened up like this. There's a sacral fracture, multiple big fracture. Patient positioning in the prone is a bit difficult for this patient. So we can do in steps, where patient improves and yeah, vertebral rehabilitation, doing this, but he neurosurgery is very good. This small infarct is not causing any problem. But fully
the-
conscious,
now that he's conscious, it would be a good idea to get one vertebral artery.
we have done angiography. We have done before doing this posterior fixation, we have done. We have done. Only thing he had a swollen difficulty. I don't know what is the reason for that. How to explain that this scenario, clinical scenario. Still, he is on rise to peace. And he had a hoarseness of voice. His voice was quite hoarse, but it is improving. He had a bilateral lower limb weakness, which is improving. It is almost grade 3 plus 4. So he is up and about. We are about to, he's still in the ward. We are about to discharge him. But he had all these problems. So he managed. Yeah. Yeah.
Good morning, sir. Nice to see you. I have any experience of CVJ tuberculosis where significant anterior compression. And how do you manage deficit? Because we have in medical college lot of cases comes. Though we started the ATT, they improve also, but the impending compression and deficit is always in dilemma. So how to go posterior
It
fixation
is
or
recommended is go anterior when and posterior fixation. It is still holds true for infection.
Yeah.
That's what I have heard in some of the meetings also. And when is anterior compression disease is there, I think better to remove that. If it is causing severe compression,
Yeah.
if you will go on posteriorly fix it. So that gives fixation.
right? Thank you.
Thank you so much.
Thank you very much. Thank you, sir.
So for the last talk of this session, I would like to invite Dr. Nidhi Patel for his talk on starting endoscopic spine surgery into practice for beginners.
Good morning, all, and I thanks once again Dr. Ashish Tandon sir and his team for having me, giving me this opportunity. Without time, starting endoscopic spine surgery into practice for beginners. I am myself not very experienced, but probably learning from my struggles and my complications. It will be, I think, I will be able to put some insight into this topic. So. Our anatomical targets for any spine surgeries are around our thecal sac and nerve roots. That is either majority of the cases are either disc or the stenosis. And all the morbidities related to these surgeries are majority of the time due to the access alone. And that's the reason that we should have the alternatives which can avoid the or minimize the access related morbidities with access to the targets without disturbing or minimal normal tissue disruption, and with equally good or even better outcome with laser opening. So if we get answer to these three questions, yes, we can very well adopt to this technology. And another advantage is that beautiful high resolution of axis visualization, which endoscope can offer, and no other technology of current era can give this visualization. So what is first endoscopic spine surgery? When we hear a lot of techniques, different systems, though the full endoscopic surgery is the one which is done with the instrument passed through the working channel of an endoscope. Rest all the techniques are called endoscope assisted. The common names which we hear are do and QB and micro endoscopic and etc. So basically, there are two basic techniques for full endoscopic system, either transforaminal and interlaminar. One should be good at both the techniques because both have certain indications which are not possible or can be done as efficiently through other alternative. So my initial challenge is I will just go through at first question that how to get trained, how to get the instruments and scopes, starting the case. And as we do, or as we start, we have to improvise our own performance through the self introspection. So yesterday we saw that for learning endoscopic spine surgery, majority of us don't know. We just look at countries abroad, Korea, Japan, Germany, but we have doyens and giants in endoscopic spine surgery who are probably better than any other surgeons from other parts, like Dr. Satish Chandra Gore sir, Dr. Girish Datar, Dr. Sukumar sir, and they conduct short-term courses here in Jabalpur, also at medical college. Yearly twice endoscopic spine surgery courses are being conducted. We can also go to the one of the high volume centers for short-term observership, attending live operative workshops and cadaveric workshop also enhance our learning. And most important thing is to have a mentor, good mentor. We have, I think, in NSSA that one mentorship program also started. I think Assistant sir has one such program here. So how I started in 2022 when I went for a residential course by Dr. Gore sir, and I learned about transforaminal approach and his spine philosophy, which I had probably never heard. And I learned a lot of spine concept after attending this residential course. And afterwards, I attended few cadaveric and live workshops at different places. But most of the learning which I got was from the YouTube. Actually, there are very good live recordings of the whole conferences where live surgeries are there. Some of them, just I will name TSS Yula, Revo Spine Channel, Dr. Mahesha, Dr. Sukumar, and Dr. Ankit Madaria. These are the just name if you somebody wants to look for the ready reference. This lot of learning material is available on YouTube. So the next question comes with system to buy, whether you go for, you need all imported or Indian instruments can do. What are the essential instruments? What are the optional instruments? Cheaper alternative. All this is actually a separate big topic, but I got very good guidance from Dr. Ashish Tandon sir and Dr. Janmejay. And after speaking to them, I went for an Indian system with Chinese scope because I couldn't afford very expensive imported stuffs, and some jugaad which I did for the drill. Recently, I upgraded to the drill, but with a simple micromotor marathon drill, this kind of adapter will work fine. And this 2 megahertz RF battery I bought off late, but otherwise I started with just regular normal battery machine for endoscopic surgery. And I took almost 4 months to start the case after learning the endoscopic spine surgery. Since I learned only transforaminal approach initially, I took up this case, difficult case actually, with stenosis, but patient had only one unilateral left lower limb pain. So I attempted and I did transforaminal under local anesthesia, got able to get the good decompression, but patient was happy for almost 8-9 months, but came back with the recurrent pain, not as intense, but this time patient was not ready for a second scan, but pain probably was not that intense and managed conservatively. If this patient comes to me today, when I am now able to do interlaminar work, probably I will not attempt transforaminal this kind of case. So it's important to learn. Then another case when it was just sixth case in my beginning, and I attempted this Koda equina case with extruded fragment. Dr. Janmejay can do, but I could not do. Just fragment was in front of me, but I was not able to get the grab of that fragment, and I had a disappointment at the end and had to convert it to open. The real first complications which I encountered was in my 11th case. Till then, I was just doing all transforaminal, whatever comes. I was just trying to think how I can do transforaminal. So this was a patient with a relatively acute onset lower limb pain in left side, and MRI had shown L4-5 and L3-4 two-level disc, but pain was relating to only L5 dermatome. So I attempted transforaminal, and uh, just yesterday, Dr. Yadav sir pointed out we need to see the tip of our instrument at all the time, and I ended up with this pulling out of the or injuring the thecal sac and the nerve root. So uh, for 4 or 5 days, patient was under local anesthesia. I tried, but I could not push it back, and I had to abandon the surgery with lot of disc fragment left. Uh, on fifth day, patient called up having severe pain, not able to get any relief. I got the MRI scan, lot of remnant disc was there. So spoke to assistant Benson once again and decided to explore. He guided that probably a lot of CSF should be there, and a lot of CSF with large dilated engorged veins were there. So did decompression for 2 levels, and CSF dural tear was found in what situation of location under surface, could not suture, so just put the muscle. Luckily, patient recovered, and I also had a good recovery from this nightmare. So this was the 11th case for transforaminal, and then I realized that one approach cannot give solution to all. Subsequent to that, probably I never had any complication in transforaminal so far. But there are good indications for transforaminal approach, like when there is contained disc, like this large disc, when you don't, it's just disc, so we can do the good work. But for the transforaminal approach, the most important step is the placement of the cannula. If you put it correctly, then only you can grab the fragment. Otherwise, you will just struggle and nothing will work. So the good positioning of the cannula is of utmost importance, and you can get the fragment out in no time. This is after removal of the fragment, you can see the thecal sac pulsating well. Even we can see this repair structure, that deepest furthest structure is the near the opposite side pedicle, and uh, that's how we can remove the fragment. For higher lumbar level, yesterday we had some discussion about it by not interlaminar, because transforaminal is so versatile and it can just do the job in a very short, quick time, and with quite efficiently we can grab the fragment. Here I am removing the fragment, and at the end of fragment removal, we are able to see the nice thecal pulsations. And this whole thing can be done just in a small, two tiny step wounds. So that's the reason that for higher lumbar level, when intervertebral foraminal height is very good, we can do the job very quickly and very easily. This is another case for transforaminal indication, that foraminal level disc. This patient had come from my first complicated case, and I was quite afraid to put the transforaminal because of the patient's known. But this was the right thing. I had little more experience and uh, again, here the entry or docking the cannula is very important. Position varies. It is transforamen is a very targeted surgery. Getting the perfect entry and docking cannula is very important. So here we don't enter inside the canal. We just stay in near the foramen and do the work. So this is the view at the end of surgery. We see the pre-pulsation of epidural fat and uh, even exit this patient. Another reason for choosing the transforaminal approach for this patient was she had symptoms related both L4 and L5, and but the pathology look around the foramen and in the lateral recess. That's the reason I choose transforaminal for this patient. Another indication is the cases where spondylodiscitis. These are very easily done by the transforaminal approach. Just a few things we keep in mind is we don't need to target the posterior annulus. We just have to reach center of the disc. Initially, we don't connect fluid irrigation, and we can just grab as much material as possible for culture, and then we can do the subsequent debridement. And the chances of getting positive cultures are high when you have good amount of tissue. This was spontaneous infection, and patient recovered well. So my current indications for doing transforaminal surgeries are at any level except L5S1. Now I don't attempt L5S1. I just go interlaminar because that is easy. But any paracentral disc herniation, foraminal and extraforaminal disc, even lateral recess and foraminal stenosis infection, and even transcambin fusion. We'll just show. I'll skip this slide which I presented yesterday, interlaminar discectomy. But there are instances when you have multi-level pathologies, when different approaches we need to plan, like L1, L2, central, paracentral disc and foraminal disc with 4-5 stenosis. These cases we tackle by combination of approach. At L1, L2, we did a right side transforaminal approach and remove the fragment. And in the same sitting, we did this interlaminar decompression, and patient we can save the long big incision when there is intermittent normal levels. So another case for multiple level stenosis for 5S1. This case was done through the same port, because at L4-5 we don't have to angulate a lot. Just with 5 to 10 degree angles, you can just easily reach the next level. And once your experience grows, you can go to the dorsal and cervical level. For cervical level, for level confirmation, it was lucky that there was old wedging, and that helped me in improper localization. And just another challenging case for
Yadi, you please conclude. We are shooting out the time.
sorry, sir. Yeah. So even advanced level endoscopic fusion can be done. This was done through transcambin approach when there was no posterior listhesis, but significant degeneration with 2-level listhesis. We did transcambin fusion under epidural analgesia. And so there is no limit of endoscopy. We can, as our experience grows, we can do any level of advanced challenging cases. And that's what I want to say, that when a beginner or when a less experienced surgeon like me can do the endoscopic work, there is a lot to offer. So we'll just indications of interlaminar approach is lumbar canal stenosis and endoscopic fusion. So some of the tips for the initial cases. In interlaminar case, when we initially we waste a lot of time in identifying the ligament flavum and laminar edges. So we need to pass the dilator till you feel the bone edge, and then so you can do the soft tissue clearance faster. And better to avoid advanced level multi-level
Dr. Nidhi,
cases,
please
initial
conclude.
cases. Yeah. So yes, sir. Last slide. So for transforaminal approach, the 3D anatomy knowledge of intervertebral foramen is must before attempting transforaminal approach, and it is very target target specific surgery. Perfect entry is the only key. Otherwise, you will not be able to do the work in transforaminal. And invest wisely in your instruments. Good quality instruments will make your work and life easy. So that's all from my side. And thank you for patient watching. I once again take this opportunity to invite you all for NSSA 2025. Next year, we are organizing at Rajkot. Now, may I take a question?
No questions. We'll deal with the question later on. We are ending the session, number one, and
Thank you to all the speakers. I would request the chairpersons to felicitate our speakers for the session. Firstly, Dr. Jitin Bajaj. We'll request Dr. Prashant Kushwaha to felicitate Dr. Anil Sharma. I will request the chairpersons to felicitate Dr. Umesh Srikanta. I will request the chairpersons to felicitate Dr. Rajnish Kachal. Thank you to the chairpersons.
okay.
For the next session, I would like to invite the chairperson for the next session, Professor Dr. Vinu Gopal. He is a professor in the Government Medical College, Kottayam. And Dr. Vijay Parihar, he is Professor Neurosurgery in NSCP Medical College, Jabalpur. Welcome, sir. Over to you, sir.
Good morning, all. Go to the next session. Actually, Dr. Sukumar Surya is not able to attend this function. He is currently online. I think we will go with his presentation first. Over to you, sir. Can you hear us?
Yeah. Can you hear me?
We can't hear you.
Can you hear us? Can you hear me? Hello,
Yeah, we can hear you, sir.
can you hear me?
You can continue with your
yes.
presentation.
Yeah. Just I'm connecting my presentation. Okay, am I audible now? Hello.
Sukumar,
Yes.
you are very well audible.
Yeah. Good morning, everyone. So today I'll just go through the what all endoscopy has advanced in fusion perspective. So we all been doing fusions both open and MIS and also endoscopy. So thanks to this professor, where he conceptualized the interbody fusion and did work on cadavers, and he did the endoscopic assisted fusion way back in 98 and published in 2003. and he called it as a lean lift. So the concept was going through the trans-Cambrian approach where the safety triangle is there between the traversing and exiting route. So if we can enter the space and clear the disc pathology, and we can very well place a graft and interbody cage and do a good interbody fusion, which becomes the least invasive approach. So we call it as posterolateral approach or trans-Cambrian approach. The other method is the posterior approach, where you go through the lamina and facet, removing the lamina facet, what we do in a typical MIS or open surgery, where we do a pedicle to pedicle clearance of the bone and do the interbody fusion. So today we'll just look at the both techniques, advantages and disadvantages of this technique. I was fortunate enough, and myself and Mahesh visited the professor in way back in 2018-19. So we came back and we devised our own cages and started endofusion in 2018. The advantage of trans-Cambrian fusion is the main thing. Foraminal work can be done easily. It can be done either in the local or epidural. That's the biggest advantage in a morbid patient. And the best part was we were seeing the end plate preparation, doing a thorough end plate preparation, and patient was discharged within 24 to 48 hours. So I started doing this under the local with sedation. Then we thought it was a little bit more painful. The journey of anesthesia was not good. The surgery was not good. So we converted it into epidural analgesia. Nowadays, I do under complete general anesthesia because we know where we are. And most of the time, we do foraminotomy, increasing the volume of the foramen so that there is no risk of paresthesia post-op. So, same thing as we do a transforaminal surgery and endoscopic discectomy. Here, the only difference is we enter a little bit medially. So, we want to go more ventral to clear the disc and place the case. So that's the only difference between a discectomy and a fusion. Same thing like this, we put a needle there. So the difference is, as previous speaker was telling, that needle should be more posterior here. The needle placement should be more anterior because the case has to be placed more anteriorly. Once you are there, put the dilator, same again, prepare the disc, remove the disc, prepare the end plates with the special curettes and other instruments. Once your end plates are prepared, you can see the beauty of this is the end plate visualization. You can see the end plate visualization very nicely, both upper and lower end plates, and that's how it is done. So the curettes, once it is done, then you pack the graft. The drawback of this transforaminal technique is you have to use the synthetic graft or allograft. So you can't use the autograft, you end up in giving one more incision, taking a iliac crest graft. So we were having good results with the allograft and synthetic graft, but still there were some problems. So these are few examples how it is done. Once a graft is packed, a K-wire is placed over the K-wire, the cage is inserted into the so it is like this, and then fusion is done in a similar fashion. Then so next is the few examples. I will just show you the few examples. These are the few examples. You can see this grade 1 listhesis and with stenosis. So previously such cases, we used to do interlaminar decompression first, then do endoscopic transforaminal cage placement and fusion. So this was a little bit time consuming. Then such examples like a redo surgery where there is a foraminal stenosis, in such cases, transforaminal approach is very good, where the height of the disc space is collapsed, foramen is narrow. Such case, the transforaminal approach is very good, where you can restore the height at the same time, restore the foramen volume. So this is a previous scar and what we have done. So this is a minimalist invasion of the posterior elements. And cases like this where there is a two-level listhesis which is reduced on extension can be done easily transforaminally when there is no central canal stenosis. You can do it very well. and see the end plate preparation, then place the cage. The cage is placed. That's how you prepare the end plates and go inside. Take the bone marrow and mix it with the synthetic graft and pack it and close the cages. So this is the outcome. You can do a very good surgery, and even difficult cases like this where you have extreme stenosis. So we can do a interlaminar decompression first and go through. So that time we didn't have the armamentarium to go interlaminar case placement. So we were had to develop some instruments. So we were doing transforaminal case insertion. So this is how the interlaminar decompression followed by cage insertion. So revolution, within last 3 years, a lot of things have changed. Most of the cases we do now posterior approach. This is a case where traumatic bilateral pars fracture, patient had a severe pain, and when he came to the our center, he has a severe back pain with bilateral radiation. So the heavy metal had fallen his back. This was done under epidural, and you can see complete reduction of the listhesis, and we have placed the cage transforaminally, and this is a CT post-op, and this we published in JMIST in 2022. So the complications in transforaminal approach is you can have an end plate fracture if you are not parallel to the end plates. Suboptimal cage positioning is the key. When your needle placement is not correct, your cage placement is not right, and you might end up in problems. Post-operative dysesthesias are common because you have to go grazing the exiting nerve. So sometimes using a bigger cage like 10 to 12 cage can have a post-operative dysesthesia. This is one extreme case where grade 3, almost 2 to 3K dysthesis. It's just to show that it also can be done transforaminally. You can see there when you put a opposite side screws, reduce the segment there, stabilize the segment, and put the transforaminal operation in cage insertion. It can be attained, but the drawbacks, definitely the expandable cages can also be used. We introduced this tubular transforaminal cage in last year by Globus Medical, where we can put through the tube, we can pass the cage and expand. So 8 cage can expand to 12, and the 9 cage can expand to 14 So good lordosis can be attained with this expandable cage. All this said and done, transforaminal approach has some limitations. As I said, if there is a stenosis bilateral like this, it is difficult. So we have to go interlaminar approach, decompress, then put a transforaminal cage. The graft was issued because we are using a synthetic graft, and radiation was the paramount important, because when you are doing a transforaminal surgery, you tend to take a lot of shoots. So then we started adopting this technique, posterior approach, where you remove the lamina, pars, and facet as a en bloc. When we started this technique, and we termed it as ASER technique, where it's called Asian spine endoscopic resection of facet. The entire block of in one en bloc, removal of the entire facet, lamina, and the pars is removed, as we do in. So this is not removed in piecemeal. We remove it entire one block. As a result of which we get a good graft, autograft for the fusion. So here, after removing the inferior facet, pars, and lamina, we also remove the tip of SAP and getting a graft as much as 7 to 8 cc, where it is adequate to pack the space. So how it is done, the landing here, it is a cranial landing as the conventional interlaminar surgery. We land little bit cranially at the junction of pars, lamina, and facet junction. That is at the more cranially and more laterally than conventional surgery. And then once we go inside, it's a short video. So just I remove the soft tissue, identify the bony elements there. The moment we reach there, I have landed here on the lamina. as I said, we land more cranially and laterally. Once we land there, I start drilling a part of spinal laminar junction and make a crevice there. You can see I'm just decorticating there the bone so that I can chisel it better. Here, idea is to remove the entire bone as one block. So I am just preparing the lamina here. This is upper end of lamina, that is L4 lamina. Now I am just drilling the upper end of L4 lamina. So just trying to make a corridor, the crevice there, so that I can easily chisel. Once this is done, then here, this is the pars. I am drilling on the pars now. Pars is a more compact bone. So we need to disconnect the pars, only then entire bone comes out as one piece. So I am drilling the pars. Here you can see the compact bone. Once it is done, then I use a chisel, which is a specially made chisel designed by Dr. Mahesha. So we use this chisel to first make a crevice at the spinolaminar junction. Then I hit the same, continue on the lamina, the upper end of lamina. You can see I'm just making a small cuts there so that I can use this elevate the bone in toto as one piece. So then now I'm chiseling out the pars now. So I'm using a chisel on the pars. Here we take a shoot with the C-arm shoot so that we should not violate the upper pedicle. So flush to the upper pedicle, we just use a chisel here. Chiseling, so you can see now the bone starts moving and I go deeper. Now that's the detachment of the pars and lamina, and you can see the fecal sac there, fecal elements. Now I use a curette to just lift off the bone from the underlying structures. So now I just coagulate for the sake of our better vision. Once this is done, you can see the entire bone is lifted and I come to the joint. That's the facet joint. I'm lifting the bone from the facet joint. An entire facet, lamina and pars are in now floating. There will be some ligament phloem additions which we need to remove that so that we can remove the bone easily. So I am just detaching the ligamentous additions. Once this is done, grab with a tooth forceps or a tooth punch and entirely remove the bone at one piece. So you can just remove the bone. You can see here the bone is now floating now. Entire bone is floating, and we just grab it and pull it out, not through the cannula. You come out along with the cannula. So you come out along with the cannula. You just park it there in the subcutaneous space and remove with the artery forceps. You can see the big graft, and once it is done, then you just rotate the cannula, push the traversing root away, and remove the disc, and use a conventional shaver. And once it is done, the end plate cartilage is just shaved off from the end plate, and excellent end plate preparation is made. This is the biggest advantage of posterior approach. You are using the patient's own graft, 7 to 8 cc. Once it is done, our technique here, after this removal, I use the screw placement portal as my cage insertion. So I'm here visualized cage insertion. Once it is done, use the serial dilators to dilate the muscle, use a retractor or a dissector and insert the cage. Any conventional cage available in the market can be used. The cage that my assistant holds the root, and here everything is visualized, and we tap the, and you see the excellent cage position there anteriorly after packing the graft, and fecal sac is well decompressed, root is well decompressed. So these are the few examples of interlaminar approach or posterior approach rather. So you can see the collapsed grade 1, grade 2 listhesis with seabed stenosis. Biggest advantage, you decompress the entire stenosis, the interlaminar approach, then put a cage, and you have an excellent outcome. Again, one more case, again, severe stenosis you can place. This is what I was showing, entire graft This is our technique where we remove the entire bone in one piece as end block. We call it as ESF technique. We can even use expandable cages and that is the grade 2, grade 3 listhesis also can be done. The moment we we do the disc decompression and put a shaver and start moving it, it reduces nicely and you can have an excellent decompression. So 2-level, we are started doing even 3-level now with interlaminar approach. The biggest advantage is the graft. In fact, the good graft, and we have started seeing the fusions as early as 6 months now. Biggest advantage, as I said, is stenosis decompression, and we are doing a visualized decompression, and autograph is the key. And any size of cage can be used from ranging from 13 to 15 cage can be easily used without any neuropraxia post-op, which we commonly see in transforaminal approach. Thank you.
Okay, as always, if any questions. Okay, then thank you.
Thank you. Thank you, Vijay. Thank you. Thank you.
Hello.
Yeah, thank you.
Yeah, Dr. Sukumar, a few questions.
Yeah. Go ahead.
The first one may not be directly related to the itself, but the question is, how do you or what do you do to prevent damage to your endoscope and your instruments?
That's a very, very good question. Whenever you are doing the common mistake we do is if we are using articulated instruments, especially the curette or hook, when we are coming out, it should be straight. If it is still in articulated fashion, we will injure the scope. Second thing, my own experience in early days is when you are holding a tissue or a hard fragment with a punch and you are coming out through the scope, then you might injure the lens. So this is a commonest mistake. I damaged my 2 or 3 scopes like that because I was trying to force out the fragment through the scope. So whenever your fragment is big, always come out with the scope and ask your sister to take out the fragment, then remove the punch out. So this is one common mistake. Second mistake is commonest damage to the scope is by the person who is washing it. Most of the time they wash and they damage. Hello. Hello. Hello.
Hello.
Yeah, most of the time the person who is washing it damages the scope. When he's washing in the sink, he drops the scope down, or a person who is packing the scope for ETO or plasma, he mishandles it and it causes damage. So these are the 2-3 common things where your scope get damaged. Third thing is the too much of RF or the plasma or monopolar if you are using the scope too near and burning the tissues. This burning tissues create some oily like material which just smears the end of the scope lens, and this damages the lens and it is not repairable. So I always tell youngsters whenever you are using a plasma especially or monopolar, stay away from the area you are cauterizing. So these are the few tips not to damage the instrument, damage the scope. Regarding instruments again, in initial period of your endoscopic career, you always break because you don't know how much force to be used. So nowadays, as you grow, become a senior, you know where it will break, so how much force need to be used. and use more cutting instruments to cut the tough tissues rather than using a punch to remove the tough tissue. So these few small tips might help a beginner not to break the scope and instruments in early part of his career.
Do I have time for one more question?
Yes, yes.
The other question was, in one of your videos, you were showing use of unipolar.
Yeah.
Are you still using the unipolar? And if yes, then what are the settings on a routine uh, bipolar machine?
So this is a monopolar hook which laparoscopic surgeons, especially pediatric laparoscopic surgeons use. So this probe we use in endoscopy nowadays. I'm using past 1.5 year now. More than 50 to 60 cases I have used, especially for stenosis and most of the fusion. I use this now. So the advantage of this monopolar is it creates a good tissue clearance faster and prevents our punch or cutter damage. The settings we use are around 50 uh, and I use a Medtronic Covidian machine. The same bipolar monopolar we use for open surgeries. For that it just fits in and we use it as any other monopolar probe. Because we are using under the saline irrigation, 50 or 60 setting would be the effect would be like a 20-30 on the tissue because we are using under saline irrigation. And I didn't have any problem. Some people complain of that the probe is not working in their machine. So I think Valilab and any standard machine like Covidian Valilab machines, it works very well with the setting of around 40 to 60.
Dr. Rajkumar being with us. Now I invite my co-chair, Professor Vinu V. Gopal. He will be speaking on interlaminar fenestration for spine pathology and novel approach. So.
So good morning all. Fortunate to be the speaker and chair for the same session. I take this opportunity to thank Dr. Ashish Tandon for giving me this opportunity. Congratulate for this wonderful workshop and conference. It is just a technical note on an alternative approach to multi-segmental intraspinal space of brain lesion, unilateral multi-level interlaminar fenestration. As you all know, conventional laminectomy for large segment tumors result in instability of the vertebral column, leading to progressive spinal deformities. And lesser invasive procedures like hemilaminectomies and osteoplastic laminotomies also interfere with spine instabilities to a certain extent. As you all know, vertebral column instability rests mostly on the posterior tension band, the intervertebral articular joints, paraspinal muscles, and the ligaments. And surgical approaches that remove the bone and ligaments of the vertebral column at multiple levels carry the risk of early or late spinal instability and eventual spinal deformities. So we thought of doing this interlaminar fenestration. Here the bone removal is only very minimal, and we have preserved the part of the lamina and the portion of the articular facet and the pedicle regions, and we have made multiple windows to reach the tumor. So by sparing the vertebral arches, ligaments, the forces will act in the normal way and the original form of the spine can be preserved. That is the concept. And while reviewing the literature, this approach was used extensively in the past for lumbar canal stenosis. And it was also used for evacuation of spinal epidural hematomas also. Its importance in intraspinal tumor excision is recently being explored. So I will go to a representative case. A 44-year-old manual laborer presented with gradual onset of low backache with pain radiating the right lower limb and a tingling sensation of the right thigh for the last 2 years. On examination, he showed element findings of the right lower limb with intact sensation and bowel and bladder functions. This is a huge tumor from L1 to L5 with intense enhancement. And X-ray showed posterior vertebral body scalloping also. This was the procedure that we have done. Sorry, I don't have any videos with me. This was the only case that was done. These are the multiple fenestrated windows through which you can see the dura. And you can see that the articular facet along with the upper part of the lamina was preserved. And the dura was opened, multiple stab incisions and dissected out using a microscope. The microscope can be angulated superiorly and inferiorly to see the sublaminar region. And with thorough dissection, he was able to manage remove the tumor in piecemeal and was able to achieve a complete resection. And the dura I was not able to close the dura, it was left open and it was passed with the fat and a vibrant sealant. Postoperatively, there was some deterioration in his power in the right lower limb, which gradually improved. And the patient was discharged on post-op day 5 and reviewed after 2 weeks with a dynamic X-ray of the lumbar spine. And this was a CT picture. You can see that the midline structures were preserved with the preservation of the facetal joints. And dynamic X-ray showed no instability. So this was only a technical note. We need to do more and more cases. And nowadays it is the era of endoscopy. You can do all this through endoscopes. Still, multi-level interlaminar fenestration can be a useful neurosurgeon's armamentarium in removal of long segment intraspinal tumors. And it is really cost effective. It eliminates the need of fixation and decreases of hospital stay. So by the use of, but with the aid of operating microscope also, multiple fenestrations can be used for removal of long segment intraspinal tumors. I published this in Journal of Spinal Surgery. If time permits, please go through the article. Thank you. Thank you.
Thank you, sir, for showing a different technique in a common tumor. We have a time to take few questions. Sir, Yadav, sir.
Yes, sir.
Excellent talk. This was described in cervical spine and they name it as crystectomy. So what, I mean, it's not a comment, but advice. Normally, lamina is like this. The superior part of the lamina is more closer to the cord. So what I advise you, I think you should remove more of the cranial lamina, which has more compression on the cord, and leave the caudal one. Although in lumbar spine, there is a ligamentum flavum, so you remove the ligamentum flavum also. So rather than removing the, no, it is hemilamina, it is all right, but the superior lamina should be removed and leave the inferior part, which will give you more space, intrathecal space.
If you want, we can undercut also.
Yeah.
Thank you for the comment. Yeah, that's one case okay. Just want to introduce. That's all.
The dural closure was okay with that putting fat.
There was no leak. I put flat, multiple flat and multiple windows.
Or one or two stitches was also
No,
not,
I was not able to take it.
because the space
Very
considered
limited
there,
space only.
because the needle also can't
Yeah,
maneuver
you can
that
maneuver the
area.
switches.
But
Otherwise, you can use a Liga clip, I think. I tried, but I'm not able to.
but the tumor you could access well, and you could maneuver and you
I was not
manipulate.
able to access well
then
by repeated dissection and removal piecemeal. I was able to dissect it out. with the aid of microscope. As we do more and more cases.
Yeah, I think so, because basically, window has to be, quite, adequate.
Yeah.
So you can, ideally, you can extend by drilling the under surface of the spine and all this, and laterally up to the maximal part of the probably facet, so that you can get a bigger window. You can try, but I think tumor removal may be difficult. So you have,
And also,
think it
the
is-
microscope, we can't so much angle it.
yeah,
That is the good thing with an endoscope, we get the panoramic vision, big vision.
Sir, preserve the posterior elements. If you can cut the lamina bilaterally with a bone scalpel or CUSA, bone cut CUSA. Again, you manipulate and
But here I thought the posterior junction band is fully preserved. The midline structures are preserved and the parasmanic muscles on the other side is also preserved. But so why can't we go through the unilateral to the other side?
But
That was
primary,
the idea.
yeah, but the main thing is to remove the tumor totally.
Yeah.
And closure should be appropriate also.
Tumor removal is difficult. Dural torture, I think, since we have multiple windows, we have not, we have put the fibrin sealant also. And there was no pressure difference because the dura is fully open and that will adequately give a decompression in the immediate post-op period also. So in this case, there was no leak or swelling or stentosis like that.
If small gap also, the cord may herniate or maybe a small rootlet also herniates through that root, and that will cause necrosis of the cord.
No, it was sufficiently open so that even if there is a protrusion, that will give a decompression also. That was my idea. But
To remove the tumor under the lamina with the microscope. So it's difficult. Did you just remove piecemeal and were you satisfied?
by small decompression, easily.
Okay.
I'm not able to dissect it.
Okay.
I am not happy.
Okay.
Thank
Thank
There's a extensive drilling, so it took a lot of time also. No, not just. By after I was able to complete. Thank you. Thanks.
Okay, thank you, Professor Venu. Now I invite Dr. Rakesh Lohana. He will be speaking on interlaminar endoscopic discectomy. Dr. Rakesh Lohana is a senior neurosurgeon and spine and pain specialist in Ekota, Vadodara. Welcome again.
Thank you. Good morning, everyone. My talk is full endoscopic interlaminar, or it's called translaminar lumbar discectomy. As we have seen, full endoscopic interlaminar or translaminar lumbar discectomy. So there was an era of microendoscopic discectomy. Till now it's biportal and full endoscopy, which is the least invasive in a current era. The setup you need a radio frequency ablation device, you need drill, you need a good monitor and a good quality camera. This is the setup we have. I use revoscopes. It has got a smaller channel scope for decompression and larger one for stenosis. You need specific instruments, sheath, dilator, probes, the specific punches, various kinds of drill. This is the cutting drill with the protection, cutting drill or diamond bar. It has got an annulus cutter, straight and angled, various kinds of dissector and various kinds of disc forceps. Indication is same as conventional. This is very important point that however minimal invasive procedure you are doing, the indication has to be strong and robust. I will discuss few cases. This is a 41-year-old lady with a right lumbar radiculopathy. As always, you should try physio, small period of rest, medical management, and root block. With all failed, she had SLR on positive, and lumbar movements were painful at S1 hypoesthesia. It was basically a classical S1 radiculopathy. This was MRI. It showed a L5 S1 disc herniation with a traversing root compression. You can see the disc herniation, some sequestered fragment, and L5 S1 disc herniation. So in interlaminar endoscopy, it is important to see AP X-ray as well to see interlaminar window. That will tell you how much drilling needs to be done. Positioning and setup. Under general anesthesia, you identify where you want to get in. This is the marker, and then you place the stab incision and place a dilator, followed by a sheath. The docking has to be over interlaminar window as near to the spinal process as possible. And then you begin. So first step is interlaminar window dissection. So this is a plasma, which is plasma basically used above the ligamentum fluor for preparation of interlaminar window. You can see that's the ligamentum fluor. So identify ligamentum fluor all around and identify superior lamina, lateral aspect as well as superior lamina. And then you use RF for a finer preparation. And once you have made sufficient interlaminar window preparation, this is the superior aspect of inferior lamina. The next step is drilling. So you identify the bony landmark, the inferior aspect of the superior lamina. This I am using protection bar. One can use cutting bar as well. And to reduce the amount of bleeding, one can use a diamond drill. So you drill inferior aspect of the superior lamina as well as medial aspect. The next step is the phlebotomy. So this is the ligamentum fluor. The scope and the pressure of it, you scratch, and then use annulus cutter. So you make a window into the ligamentum fluor and dissect it laterally. From medial to lateral, you extend your interlaminar window. You dissect with a ball point probe to make sure that your annulus cutter doesn't get your root or a fecal sac into. And once you are sufficient lateral to it, next step is a sheath rotation. So there is one sufficient window has been created. And when you rotate the sheath, you can go either cranial caudal or caudal to cranial. You can, there is a sequestered disc, so disc is already into. So you dissect the root, the dissector, and then you rotate the cannula. So while rotating the sheath, make sure that your root is free and it's not being trapped. And then next step is the dissector. So if it's a content disc, you need to cut the annulus and then the fragment would come out. You can identify annulus tear, then you go through it, otherwise you can create like this. And this. In case of sequestered disc herniation, you can fish out the fragment with a blunt hook as Maya or open procedure. With the large fragment being coming out. You can see this is at the end. You derotate and you can see that now root is free and And then it's basically you take out the scope after ensuring hemostasis. It's basically a stitchless surgery. Post-operative protocol is ablution on the same day, next day discharge. You can do it for a higher level discarnation as well. This is the L3 discarnation, the post of MRI. You can see excellent decompression with a targeted fragmentic emitter. We used it in a kind of patient where this patient had a huge discarnation with a caudate vena syndrome, and very next day MRI is showing excellent decompression with a minimal footprint. That's the advantage. This surgery has been known for a patient who was obese. This was a lady came all the way from Dubai with more than 100 kg weight and with a big disc herniation. This is where you can do it with a small tiny incision again. It is useful for a recurrent disc herniation as well. This is our own case. Last year we operated for L5 disc herniation with a post of excellent recovery. 1 year back, we should came back with a recurrent disc herniation. A lot of fibrosis, and then separated it. This recurrent disc herniation are easier, probably hydrodissection and better visualization make it easier to dissect. Okay, this fragment comes out, comes to release. And very next day MRI. This is the approach. It can be used for a L paralateral disc herniation as well, like a Wills approach. It's a para PSLD. You go lateral to the facet joint and you dock lateral to facet near the inferior aspect of the facet junction. Then you take this there. Can be used for disc herniation with canal stenosis. This patient had a L4-5 disc herniation with a ipsilateral lateral stenosis. Post of MRI, excellent decompression. You can see this has been become a complication avoidance is important. So your diagnosis has to be right. Your indication has to be robust. The surgical option has to be right based on surgeon competence. So there is a definite learning curve involved. So you have to see pre-op MRI and decide what you are competent in. So for me, I see whether I can do it interlaminar endo. I would do it. Yes. No. Can I do it with tubular MIS? No. If yes, we'll choose it. No, then maybe transmural endo. I have a limited indication for me. Otherwise, very rarely we need to do open case as well. But you have to have all things in your armamentarium to use a perfect option. To conclude, it is an ultra minimally invasive procedure. It is useful in all types of disc herniation. And yes, there is a learning curve, but it's going to be a new gold standard. Like conclude with a good code few jobs. Learn continually. There is always one more thing to learn. And I think this is the thing to learn for a current generation. Your surgeons and spine specialists. Thank you.
Thank you so much for the excellent talk. We'll have few questions. Topic is open for discussion.
Yes.
The recurrent one.
Yes, sir. Yes, sir.
This was
There were additions, but you could, the window you need is very small. And first surgery was also done interlaminar. So there is not much of bone dissection. Yeah, so we had to just go little lateral to the previous window, separate the traversing route, and we could get there. I would say for interlaminar, the recurrence rate would be same. Maybe in early learning curve it may be higher, but because you do the same procedure as in open MIS or interlaminar. Your annular window is same. You try to identify natural annular rate and you try to go through. You make sure that you get sufficient or adequate discectomy as you get in MIS or open. I think conventional is to be as equal as conventional. Yeah, 5 to 7. It is.
Excellent talk. Is there an indication is that all surgery, everything is done with one channel? So we all know that if you have problem, then you need bimanual dissection. If there is adhesion, there is a bleeding and so many things. So did you find any problem with this setup?
Yes, sir. So
And is there any limitation
yes,
or it
no,
is?
there is all new modalities would have certain limitations. So one of the case with paralateral disc herniation paraplegia, I was confused whether it's a root or annulus. It was my first case doing para-PSLD. I was very close to it. So I switched over to MIS tube extending incision. It's the same incision. I just extended it about 0.5 centimeter and I used the tube and I could do it. So yes, I think MIS is, for me, MIS is my second kind of plan. Basically, if I fail, I may switch over to MIS. Yes. Yeah.
Like what should be the sequence of learning the modalities?
Yeah, this is
To learn all of these, or we should go for the transforaminal MIS and laminar? Maybe one we should pick it. Like it's a very layman
Yeah.
sort of a question.
Yes, yes, no, very important
In your
question.
point of view.
So I think we'll have to, two things I will have to learn. I would say MIS tube is must for all the neurosurgeon or spine specialist. One, it's because it's just an extension to your open surgery, just going through a tube. And tubes has an advantage. You may begin with a larger diameter tube and gradually you shrink the size of the tube. It's very versatile. You can do from basic disc to T-lips or even intradural tumors. So MIS tubes is must. Second thing, between transforaminal and interlaminar, majority of indications can be covered with the interlaminar. So interlaminar is must, transforaminal has limited indication and a sharper learning curve, higher complications rate. Interlaminar, you may begin with a L5 S1 simple disc, then you can gradually go to the higher level. Then you add canal ipsilateral lateral stenosis, and then you add over the top for a mild stenosis. Then you progress to a severe stenosis, endofusion, and it's a beautiful indication for a posterior cervical foraminotomy as well. Yes, sir. It is interlaminar approach is exactly the same.
Can we go ahead?
Yeah,
with the
sir,
remote?
it is exactly the same
Yeah.
as you do open, but you just
Reduce
reduce the morbidity of the approach.
Yeah.
Basically. Yeah.
So what is the incidence of post-operative radicular pain coming back to you in your practice? Maybe a month later or 6 months later?
So in initial practice, I was drilling less laterally. Like at L5, so it's okay, but when you go higher, L4, 5 or L3, 4, I was drilling going little less lateral to the traversing route. Those patients initially I had few patients I had problem with post-op paresthesia, but in recent cases, touch wood, majority of patients are doing well. So it's all initial learning curve. Once you cross that learning curve, then probably you get comfortable. You realize that how much pressure you need to push, how much retraction patient can tolerate, how quicker you can do it. So quicker you can do it. If you are retracting, you can release in between. You go little more lateral, you go little more superior, do a proper foraminotomy and then retract. So you learn with time, basically.
Yeah, definitely the rate initially would be a little higher, be it transforaminal or interlaminar. But the common mistake that we all, as we learn, we make is under drilling of the inferior articular facet. And that is where we tend to injure the root more. That is one. Second, in this technique, if there is a large disc, try not to rotate the sheath in first go. Try to retract the root with your dissector. And if there is a large disc fragment which is coming out, first let it come out. Then you'll have a little more space to manipulate your root. And obviously, when we are doing tubular and micro, when we are setting our microscope or endoscope, or when our assistant is giving the instrument, our assistant in a tubular automatically releases the root. There is a tendency of our assistant to release the root. Here, we have to make a conscientious effort that we release the root time enough.
Okay, thank you so much.
So I think the basic principle is never ever retract the stressed root. If the root is compressed, and if there is a disc herniation, especially too much prolapse and anterior place, do not retract the root in the beginning. First, take out the disc fragment and then you retract it. If you retract, the root may retract, but it will retract with either paresthesia or the palsy. So first, take out the fragment, make it slightly loose, and then you can manipulate your seat and everything.
Excellent. Thank you for the advice, sir. Thank you. Thank you so much. Because of lack of time, we'll do all the three other presentations and we will do the discussion at the end, I think. So may I call upon Dr. Jinil Kornani. He is a consultant neurosurgeon at Surat Hospital for transforaminal endoscopy for young generation. Over to you.
Good morning, all. A big thank you to Dr. Ashish and team for inviting me to this event. My talk is based on transforaminal endoscopy for beginners, lessons learned, and my experiences is in TFE. As Dr. Rakesh pointed out, I graduated from open to tubulars. From tubulars, I graduated to transforaminal. And after realizing the limitations, now most of my work is either posteriorly by UBE or tubes. Transforaminal is still 30% of my practice because it is a very essential tool in a surgeon's armamentarium. These are my disclosures. Till date, I have done about 77 endoscopic cases. Out of that, 30% has been transforaminal. The aim of this presentation is to educate the young surgeons like me and my colleagues to start endoscopy. And I have myself just started endoscopy and am still struggling with fewer issues and graduating through each issues day by day. And younger surgeons can learn from my mistakes and to give a beginner's perspective. Thanks. The most important in deciding transforaminal endoscopy is the foramen. The foramen's anatomy need to be very carefully evaluated. You need to understand the foramen, the exiting route. As neurosurgeons doing posteriorly, we are more focused on the traversing route. But for doing transforaminal, we should be more focused on knowing the exiting route's position. The Campbell's triangle has to be the anatomical orientation from a 30-degree scope of a Campbell's triangle needs to be perfect. The Campbell's triangle is made from and the base of the Campbell's triangle is made by the lower vertebra inflate. The perpendicular area is the SAP tip and the hypotenuse is from the exiting route. So transforaminal endoscopy is done through this transcampbell corridor. For transforaminal, the case selection needs to be very perfect for getting a good result. I myself still do only for acute soft disc herniations. In initial cases, only limited to foraminal and extraforaminal and paracentral discs. Discs with a good central component with a bilateral annular bulge, I'm still avoiding by transforaminal and I prefer to do it posteriorly. Infection, transforaminal has been a boon for infections, especially at a higher level. You can get good amount of tissue component and the success rate of getting a positive yield is more than a CT guided biopsy. Migrated disc and foraminal stenosis, I am still not doing, I'm doing it posteriorly. Contraindications. Duplicated nerve root, a low-lying root in the foramen, which is lying much below the pedicle in the foramen. So transforaminal should not be done in such cases. A high iliac crest up till the mid pedicle of L4 will make it difficult to target the L5 S1 disc lesions, however oblique you come. Canal stenosis, facetal disc, and migrated calcified disc are all related to contraindications. What may be a contraindication for me might be an indication for people doing it for a very long time. Pre-op. The pre-op preparation needs to be done with MRI with DICOM images. if you're planning a foraminoplasty, a CT with a dedicated foraminal cuts, thin foraminal cuts are must, standing flexion extension X-ray and an AP X-ray to see the iliac crest. Anesthesia. We do it under local infiltration at the site plus the novel ESPN block. I'll demonstrate what a ESPN block is, which my anesthetist team use. We use 20 ml of bupivacaine, 5 ml lignocaine, 5 ml distilled water and infiltrate at various sites like skin, subcutaneous tissue, fascias, annulus till while docking the dilator. And erector spiny root paraspinal block, I'll demonstrate here. It is a novel erector spiny block which gives sensory anesthesia to the dorsal and the ventral ramus. It has been described in 2015 and has excellent analgesia, and I use it even for my tube and my open cases. Skin marking. There are various ways of skin marking. You can do it either by getting a CT scan pre-op and measuring the level of the entry point of the needle. But as Dr. Sukumar had described, I put a dilator here, first horizontal dilator parallel to the disc space after you have squared the end plates, and then the dilator or the needle like this where the skin curves. The junction point of these two lines is the entry of your needle. Like Arjun, we must also put as Arjun put the arrow in the fish, we have to put the needle in the foramen using the X-ray. Difference in docking targets. As transforaminal is a very targeted approach, if you don't dock it at the proper location, you might fail to irrigate the problem. If you see here, my dilator is almost at the central paracentral location, and in lateral image, it is at the posterior annular line. That means I am anteriorly at the central region. If you see the difference, here I am at the posterior annular line, and in the lateral image, I am laterally at the foraminal extraforaminal location. The docking target is extremely important, else you will end up just inside the disc space and fail to eradicate the problem. There was this lady who was against fusion. She was about 180 kgs. So there was the disc space is also collapsed. So we put a guide wire in the disc space and then we dilated it using sequential dilators. As there was low iliac crest, I could attempt this oblique trajectory. But had it been a high iliac crest, I would not be able to get into the disc space. Stains. Yes, stains are very important in your initial days. I use personally, I use methylene blue with 2 ml of dye and some amount of local and inject it through the needle before putting in the dilator. Sheath. There are 3 types of sheath available. I personally use this sheath, which is a beveled sheath and can be used both for interlaminar and transforaminal areas. This sheath with a longer bevel is used for foraminal drilling. Outside in versus inside out approach. Inside out approach as popularized by Dr. Gore. First, you enter into the disc space, then come outside after decompression the central part, and then you go into the foramen. No foraminoplasty is generally required. The advantages are good, visualized and minimal bleeding. But the disadvantage is you cause an unnecessary annulotomy in some cases. I personally have one case of recurrent disc herniation where I did a central paracentral disc with a inside out technique. After few months when the patient traveled, he had a disc herniation through the entry point of the scope. Outside in technique, you can keep the sheath floating in the foraminal space. The advantages is no annular fenestration is required. Foraminoplasty can either be visualized under the endoscope guidance or you can use the Maximo reamers that are available. It has got a steeper learning curve, but the epidural bleeding is very troublesome. So for beginners, I will suggest do the inside out technique. Foraminoplasty. Foraminoplasty is an important part of doing a transforaminal endoscopy. It helps in relieving the pressure over the exiting route. You can do foraminoplasty in certain indications like in foraminal disc where there is impingement of the root by the tip of the SAP, osteophytes, where there is decreased disc height, and in cases where there is foraminal stenosis by the phlebum. You can see this is the exiting route, and it can be trapped by multiple levels. It can be trapped by the facet, it can be trapped by the disc, scarring and multiple vessels, or a osteophyte. So releasing the foraminal trap is very essential. Foraminoplasty, as I said, it is visualized foraminoplasty is safer. You can see and drill slowly with a diamond curve. Drill it slowly like a paintbrush. Don't plunge with the drill into the epidural space. Reamers, some people do use reamers, but those are totally radiology dependent and they can cause exiting route paresthesia. Whenever you use a larger reamer and dilate it sequentially, it is all blind and you can cause an exiting route paresthesia. This is the endpoint of the surgery. You can see this is the traversing route, freely pulsating epidural fat. And you can see that this adequate amount of disc material has been removed. This is the cranial side, this is the caudal side. Post-op scans. This 40-year female had a large left-sided disc herniation here, and this is the post-op scan. An adequate decompression has been done. Even in cases where there is end plate changes, where there are modic changes, such changes remodeling happens in post-op. This patient has a left-sided L4, L5 PID, has been done by a transforaminal approach, and remodeling has already started. You can see changes have started disappearing in the post-op 6-month MRI. Complications, exiting route dysesthesia is the most important complication. The cannula that goes in acts like a tourniquet on the exiting route. So in your initial cases where you take a lot of time to relieve the tourniquet of the cannula after every 45 or 60 minutes. And inadequate decompression is also an important complication. You have to assess the disc volume or a fragment in a post-op period as compared to your pre-op MRI. Fluid complications, neck pain, back pain, vision complaints. I myself don't use a pump. I only use a gravity-based fluid system. And be proactive in getting your radiology. Don't shy away from your complication. Don't close your eyes and be an ostrich for your complication initial days. And redo. I myself, if there is a redo case, I still prefer tubular. I don't do a transforaminal or interlaminar approach. In all my cases, I got 3 cases, didn't get relief in about 20 to 25 cases of transforaminal surgeries. One patient had a small amount of canal stenosis, got relieved by radiculopathy, but claudication started having after she started walking after a few days. Wrong trajectory. I'll show you the scan. And as I mentioned earlier, this patient did squats and reherniation happened through the port side. The central disc was removed, but there was a reherniation through the port side. One patient had dural tear and one fluid-related complication. The patient had interlaminar L5S1 and transforaminal at 3-4. The surgery time was more, so he started having neck pain associated with lower limb clonus and weakness. It improved after a few hours on stopping the irrigation. Fortunately, the patient was in local and could complain of these symptoms. As I said, wrong trajectory. If you see, the disc is here at L4, L5 level. I have used this trajectory and I have gone inside the disc space. My ideal trajectory should be here. So the central part and the paracentral part decompression remained inadequate. So patient had inadequate use. Yes. This patient, as we see, the herniated part has been removed adequately, but opposite side symptoms still remain. I myself now do these cases by interlaminar technique. Tips to young colleagues: build a team, get good anesthetists, don't worry about other people judging you. Invest in equipment. A good quality equipment will always make your headache less. Good quality RF, and record, share and learn with your colleagues. Thank you.
Thank you, Dr. Gurmani. Now I'll invite Dr. Sumit Pawar. He will be speaking on ESLD, a beginner's guide. Dr. Sumit is a neurosurgeon, endoscopic spine surgeon in Zen Medical Center, Mumbai. Welcome, Dr. Sumit.
Thank you so much, respected chairpersons, Dr. Venugopal, for inviting me. Thank you, Dr. Ashish Tanan, sir, for this opportunity. Most of my talk has been covered by Dr. Nidhi very, very well. I did not know that we are overlapping the topic. So otherwise we could have done separately so that more points could be covered. But still, I think I'll add on to your points what you have made. They were really excellent points. Percutaneous endoscopic lumbar disc decompression, a beginner's guide. What all we need to know about this technique, a really beautiful technique. Multiple names are given for the same technique: ESLT, endoscopic technique, interlaminar technique, uniportal technique, all mean essentially the same. If it is approaches interlaminar, we are speaking about the same. So endoscopic spine surgery is an offshoot of MISS. It is equivalent or superior to conventional or open techniques. It has distinctive advantage of minimal muscle loss and bone loss, less pain, early rehab, reduced stay in the hospital, and early return to work. Earlier, they were used only for discectomies, but now with better technology, not with skill, but better technology, we are able to widen the indications for the surgeries. So this is the standard history that we know. Canberra and Hijikata, who had defined and started endoscopic discectomy. I would not go into that, but just that there are two. The evolution is very important for you to know the future direction. The evolution of endoscope significantly defines your evolution as a spine endoscopic surgeon. So that's why I feel it is important for you to know that. There are two ways that you can use endoscopes. If you have a separate trajectory for endoscope and separate for the working channel, separate for the instruments, it's a different way of using endoscope. And if the working channel goes through the endoscope itself, like simple example, like an arthroscope or a pituitary surgery that all of us neurosurgeons are used to doing a surgery through the endonasal approach. The endoscope is separate, it's just for visualization and light source, and your instruments are going separately. That is the endoscopy assisted system. If your working channel is through the endoscope itself, like we do in ETP, then it becomes a fully endoscopic system. UBE is a bit in the middle of both these because it uses water-based medium, defining as full endoscopic, but the trajectory is separate. These are the generations of endoscopes as we have developed. So you can see that even we have to evolve in similar way. Initially, we were only doing discectomies with different techniques. It could be only a percutaneous discectomy procedure, the yes system, and only discectomy could be done. Like I mentioned in the previous slide, a lumbar canal stenosis was a contraindication for doing endoscopic surgery. Now it is the absolute indication for doing it. The second generation came in which we have the interlaminar approaches were popularized. It could be a uniportal technique or a biportal technique, a Destano technique, multiple techniques are easy go technique. The third generation is where we are starting the decompression and the foraminotomy. And the fourth generation is, of course, the interbody endofusion, endoscopic fusion. So, Dr. Young has developed this technique of yes system 1999. It's an inside-out technique, what Dr. Jenny was just speaking about. We only go in the disc, remove the discectomy, and there's a direct or indirect decompression that we were expecting with that. Outside in technique was described by Hubert and Hugler in 2005. We are not too late in evolving in endoscopy. Everything is very, very recent. Remember that. That's why these years are very important. And the TF approach for equitable approach was started, the half and half technique was described in 2007. The problem with TF is that there are some zones that are very difficult to access. The nerve root is over here, and this zone is very, very far away behind the pedicle. They are very difficult to access via your endoscopy. This is a standard endoscopic surgery. I'm not going to go through details of it because Dr. Jamil has covered it, a lot of it nicely. This is a standard discectomy that is done. The two big limitations of TFR bony and neural. The nerve root and the bones don't allow you to go everywhere. So they limit your problem. With the drills, you can overcome the problem to a certain extent. But that is where the second generation came. The Descendo system. Descendo system is good. It goes interlaminar approach. It has a fixed angle. It is basically a tubular system with a fixed angle between the endoscope and the working channel of 8 millimeters. And you can do any standard extradural surgery with your expertise. You can also do some intradural surgery with that. Just compare the field. You can see over here. It's very good with some limitations. This is the interlaminar window that I'm just opening. The inferior edge of the superior lamina is removing, and this is the end of the decompression. Good, but not really good. We always feel we can improve upon it. EasyGo tubular endoscopic system or tubular microscopic system is the workhorse of most MIS surgeons. It should remain the same. I'll come to that later on. We all know how to do it. We all know it's a new standard technique. It is a fallback option for all of us. Initially, the incidents are pretty big. Later on, like Dr. Lohana said, your incidents in tube size become smaller. And here is where the third generation came, the endoscopic decompression. From discectomies, we came to decompression. This is how your evolution also should be in doing this surgery. A very standard set of instruments that is required for interlaminar approach, like Dr. Lohan has already mentioned, 2-3 punches, graspers, tactile hooks, and that's it, nothing else. The tube and the endoscope, the tube is all that we require, dilator and the sheath. From open opiate decompression, to do the same thing. We are doing from very, very small opening, which becomes very, very efficient and very good for the patient. You need to know your instrument inside out, every single parameter of it, every single aspect of it, the angulation, the working channel, ID, OD, everything to know of your instrument. To an extent, initially we all have gone and washed instruments on our own. So we didn't trust the nurse to handle our expensive instrument. I think all of us must have done it at one point or the other. Very simple. Your patient is in position, you have special water, special drape so that the water do not fall on your leg and you don't get a leak in the opening. You have a dilator that you have put at, of course, you are checking on the CR at the same time the position, and you put the working channel. That's it. You remove the dilator and you put the inside. You are through. You just have to start the surgery now. You do the white balancing and everything and put it inside. This video we have seen many times. We see the muscle that is bleeding. You start with your radio frequency growth. Control the bleeding, identify the lamina. The end purpose of the surgery remains the same from microlumbar till interlaminar technique. Everything is same. You do microlumbar, open, you do tubular or you EasyGo, Descendo. You have to essentially de-roof the bone that is covering the ligamentum flavum. Create a fenestration. If the end point is not same, if the end point of any surgical technique is not good, surgery was wrong, technique was not wrong. This is something we try to achieve in every surgery, what was shown in multiple videos by retracting, using a cannula to retract for doing a discectomy. We face a lot of issues with this technique because when you are retracting by tube, it's about 8.5 millimeter. In a spinal canal, imagine putting a 8.5 millimeter, almost a centimeter tube in the canal, retracting the dural sac to that extent. So this leads us to develop new instruments. Now we have a retractor through the channel itself, which obviates the need for us to rotate the working channel to get the retraction. You don't see any neural structure over here. There's a pure fragment. At the end of the fragmentectomy, you can see the nerve root very happy, very closely. So you know the advantages of the review. Now, these are the few points I would like to make for me to remember. Choice of instruments. Always invest well in instruments. That is investing in yourself. Believe in yourself and invest in yourself. Preferably buy instruments yourself and not to the hospital. This is very, very subjective. Different locations have different thought processes and we have different contacts with the hospital. So you need to adjust to your suitability. I always advise people to buy the better optics. This was the advice given to me, not my advice. This is just handed over. Knowledge is not first hand, it's always second hand knowledge. Prefer to buy the best optics in the beginning. If you see properly in the beginning, you will learn and you will actually fall in love with the technique. If you stop seeing properly in the beginning itself, you feel no, it's not a technique for me. And you might miss out on a very, very good technique. Buy the endoscope director working channel together because they marry each other. You can't have an old working channel and new endoscope. They are married. You cannot separate them. Instruments, try by the original set in the beginning. Whenever one of the instruments, because they have a very high wear and tear, very thinner instruments, they break down much easily than your other instruments. You can replace them from a local instrument vendor. But the initial part, you need to get a feel of what the original sounds like and looks like, how it feels like. RF drill are the most expensive equipment. They can go up to 16 lakh rupees, the good drill set, and RF can go up to 8 to 10 lakh rupees. I strictly use Indian vendors. They come to about 1.5 lakh rupees. You can, if kharab ho gaya, we can buy a new one. It's that easy and that much efficient. This sequence I would like to for everyone to remember. Initial start with the lower lumbar level. Typically, usually a left side pathology because we are left right-handed surgeons. Unilateral symptoms, single level. Lateral disc herniation, not a single disc herniation. We start with a single level, single-sided discectomy. Then go to a single level decompression. Then maybe a two-level decompression. Then go for a multi-level, you can take 2 incisions for multi-level decompression. Now start the redo cases. Then posterior cervical decompression, you can start doing it, and then the endofusion. You will define your own, this is the evolution of an endoscopic surgery. You may shift it 1 or 2 places here and there as per everyone's expertise here, or as per the cases that are referred to you. The learning curve is steep. Initially, do all cases strictly under G. Patient cannot lie down in this position for 3-4 hours. You're going to take 3-4 hours in the beginning. Start at the smaller center. These are all nuske. These are not advices. They are nuske. Start at the smaller center. Book the case for 3-4 hours. Experience is very rewarding. Just quickly lal karna chalu karo. So lengthy procedure, but really amazing. Prep your anesthetist. They are going to be your visiting cards everywhere. I insist the incision initially should be a vertical pyramidal incision, which can be converted to open very easily. Cosmetically, transverse is much better. I now take only transverse, but initially has to be vertical so that we can convert to open easily. That's these few advices, and you are good to go with the PSLD technique. We have developed special endoscopic models on which you can learn and practice this endoscopic surgery on by yourself. You don't need cadavers, you can keep on doing live operative workshop. So these are the better in-betweens. Thank you so much.
Thank you, Dr. Sumit. We will go to the last talk. May I invite Dr. Jagesh Lohana to talk on complications of minimally invasive spine surgery.
It's one of the most painful topics to go through again those complications and painful days. But while learning newer stuff, I think we're all able to go through these complications. So minimally invasive surgery, this is my setup. I do all of the microscopic and tubular system. I started with X-tube, then got a matrix and quadrant as well. Now my majority of cases are done through a matrix tube. In quadrant, I use 4 infrared. This is what I do, routine discectomy of 40 millimeter matrix tube. Multi-level decompression is a 3-level decompression done through MIS. MIS truly is one of the most routinely done cases in my practice. This is facet sinus cyst done through a frontal-lateral approach. This is radical tumors. This is pre-op, complete excision, and then you can see post-op. This is the beauty of MIS. As you start doing complex cases, you realize that none of the open or microscopic surgery then match this complete excision and very minimal footprint. You can see post-op MRI showing preserve, facet plus paraspinal musculature with absence of the tumor. But yes, complications are bound to happen along the journey. The complications can be planning. The patient has to be right, surgery has to be right to a good successful outcome, but you can fail there. You can fail in your execution. While docking, you may fail. You can fail while decompression, fixation, or there may be host of complication which may be early or late. I'll share few complications that occurred during my journey. This was a first case, 38-year-old gentleman with a cervical radiculopathy of 1.5 months duration, which was not resolved, and patient had a severe sleepless nights pain, and the patient had a right wrist prosecutor weakness. So his MRI, which showed C5-6 columnar disc herniation. I decided to go through a posterior MIS, and under 3A prone lesion level was localized, and the first dilator went directly, and it should have stopped here, but went straight to the posterior vertical margin, and that scared me. I pulled it back, came the serial dilator and placed a scope. And when I brought a scope in, I realized that the patient had a wider interlaminar window. Usually the interlaminar window is pretty narrow. The first dilator block on this bone. The patient had a congenital anomaly with a wider interlaminar window, and probably my dilator went straight through this interlaminar window. So I completed the discectomy, realized the problem. The post-operatively his pain relieved. He had a grip weakness, which fortunately improved in 48 hours. He had hypoesthesia in perineal region, and bladder boil was continent, but he had sexual dysfunction, which lasted for 6 months. And this was his MRI, which showed probably my dilator went through this and hit the cord and had a problem. So lesson we learned was we have to beware of this wider interlaminar window. The first dilator must be under CM guidance, and we have to be vigilant at every step. Move on to next case. 66 years old lady. This is a very recent complication. Last month it happened. Patient had a neurogenic claudication. My plan was to do a L4-5 left side plus bilateral L5 S1 decompression. Surgery went well. Post-operative because of spine, but 48 hours later, patient complained of urinary retention and a left to drop. We got an MRI which showed there was a hematoma going forward at 4-5 level. There was a hematoma there. We had to re-explore, and fortunately patients urinary complaints recovered. This was another case, 43-year-old lady with overweight lady with a right lower limb pain for 3 months. They went right 4-5 microdiscectomy. The good post-op outcome. Later complaint, 1 year later complaint of excruciating right leg pain, which didn't got relieved the medical management, and she didn't want another issue. So we decided to do a MIS for a recurrent disc. So I have to say that we had a previous generation CM and it was overweight, so the landmass was not properly visible, and the patient woke up with a severe right leg pain with a right foot drop. And my CT scan showed that my both right sided screws were medial. It has to go through this window. There is a medial branch. S1 the medial bridge. And we had to revise it. Fortunately, her foot drop recovered, pain recovered. We learned the lesson that while in a C-arm, you have to see midline, you have to move the pedicles lateral, your end plate should be parallel. And initially, I was planning that when you begin from lateral and by this margin, you should reach medial, but now little bit switch over your technique and try to stay away from the medial margin till you reach the posterior vertical. Next case, 65-year-old lady with back pain, difficulty in movement, history of trivial trauma was there, no tenderness, neurological impact, and that patient had a fracture. This was the initial scan. The patient came back to us with a PAT scan, PAT scan showed like wide uptake there. So we thought maybe, but there was no other lesion. Maybe a cancerous lesion we thought of. We took a biopsy from there and we 2 segment about 2 below fixation MIS. It was fine initially, pain reduced, hemohistopath came as negative, treated as an osteoporotic fracture, and 2 months later it came back with severe back pain. And you can see there was an implant failure, and we realized our mistake. There was a failure of planning. We have to reconstruct the anterior column. So we placed did a vertebroplasty there and extended the fixation above and below. So anterior column reconstruction is must. Retrospectively, we realized that just vertebroplasty would have sufficed, or vertebroplasty with single level hybrid may be the most needed, but we failed in planning and resulted into 6 segments. Next case was a It's a 60-year-old lady, gentleman with a severe canal stenosis, severe canal stenosis. We did MIS unilateral approach with a bilateral decompression. We had a dural tear, we just placed. I heard people talking that in MIS, dural tear is not that important. Just manage with the actual and glue and place the subfacial drain. He came back 2 weeks later with a high-grade fever, WC count was 24,000 and number of ruptures suggested pyogenic meningitis. MRI did confirm good decompression. We needed 3 weeks of IV antibiotics and CSF confirmed cure. So, lesson we learned is try to prevent dural tear. And if it occurs, try to repair primarily if possible. If not, you can use Duragen or in a glue. You can get away in most of the cases, but not always. You may fail miserable. Was another case, 60-year-old gentleman with a dynamic severe canal stenosis at 2 level with a disc herniation, 3-4 stenosis with a disc, 4-5 very severe stenosis. You plan 2-level decompression, but while initially only while docking him, try to in early punches there was a bad dural tear with a perforated roots outside. I tried to put the roots back in, but they were not budging. As the canal was tight, it's difficult to put now roots back in. So I changed the plan, let the root there and change the direction. The ipsilaterally completed decompression first, ipsilateral and contralateral decompression completed. See the decompression being done. Once sufficient decompression is achieved, it was easier to put the nodules back in. We can manage this kind of complex dural tear MIS now. So once the decompression is achieved, I could put the nodules back in and then covered with a Duragen. So in a large dural tear, you do use try to put nodules back in. You can use low volume ventilation or transient apnea, cover with Abgel or patty. You can continue surgery away from the site and make sure you don't pull out the nodule. You can use Duragen or a glue. If it's struggle, you can change to larger or expandable retractor and then don't hesitate to convert to open. In a minor dural tear, it's easier, like this kind of puncture. What we use it, we use muscle patch. We use instrument called graft press, and this convert this muscle into a beautiful patch, and you can cover the dural defect. This is instrument we got it from ENT guy. They use it for the tympanoplasty repair. I add glue over it. Next case, 40-year-old gentleman with a severe right cervical radiculopathy not responding. And this was MRI showing C564 disc herniation. We went there. There was extensive bleeding. The MIS posterior at times you would see a lot of bleeding. So you have to use Abgel, Surgicel, low seal, hypotensive anesthesia. This took almost 2 hours. Now I will switch to posterior endoscopic foraminotomy, and I must say that their incidence of bleeding is predominantly not existent because it's usually, I guess, it's a low flow bleed, and because of irrigation, probably you don't see that. This took a long time and a lot of panic. Next case, a 75-year-old lady with a low back pain and bilateral leg pain with severe stenosis. Patient had a full file listhesis with a dynamic stability and osteoporosis. Single plan L4-5 MIS. If everything was going well, placed opposite side screws, ipsilateral K-wire, disc prepared, and while putting a cage, the cage migrated like this. So then it was no way we could retrieve it. We consulted a vascular surgeon, kept arranged PCV, completed posterior fixation, turned out supine. Fortunately, vitals remained stable. The next day, CT angiogram showed that the cage was sitting between aorta and brain by good luck. And then We retroperitoneal approach was achieved, done with a vascular surgeon. We retrieved the cage, put the cage back, and she was okay post-op. So cage placement was kind of CM, and be careful while it's preparation of cage placement, especially in hospital. Next case, 68-year-old gentleman with acute lumbar radiculopathy, MRI showing 4-5 parallel discectomy, uneventful surgery, post-operative, woke up with a right left lower limb monoparesis with paresthesia. And you could see post-op MRI showing a good decompression. So I was not sure what's going on. Got a whole spine MRI. Nothing was in cervical spine. We got a brain screening with angio, small hit, but it was not, should not cause this kind of deficit. So again, had a look at CT there, and it showed a small hematoma there. And then we got CT angio, which showed atherosclerosed. There was no bleeding there, but you could see acute cutoff there. And you can see that the tract instrument probably passed there. We explored laparoscopy with a vascular surgeon. Distal thromboembolectomy was done. Iliofemoral bypass was done. We did a fasciotomy for a compartment syndrome. Unfortunately, patient had renal failure and died. So you have to keep in mind vascular complication, probably early detection and early intervention could have saved this patient. So the take-home message is MIS is a long learning curve, and one will have to progress gradually. Try to prevent complication by all means. Better patient selection, detailed planning, and perfect execution of the key. If complication occur, identify early, tackle as far as possible, and try to prevent others' mistake. And nothing worthwhile is ever without complications.
Thank you, Dr. Rakesh. And so because of the lack of time, we are already 35 minutes late. We decided to conclude the session. Thank you all the speakers, and thank you my co-chair, Professor Venu.
Thank you to all the speakers and chairpersons. Now I will request to the chairpersons to facilitate all the speakers. First, I would like to ask Dr. Vijay Parihar to felicitate Dr. Venu. Now I will request the chairpersons to felicitate Dr. Rakesh Lohana. Now I will invite Dr. Janil Gurnani. Come on stage, please. I will invite Dr. I will invite Dr. Sumit Pawar to come on stage, please. Thank you to the chairpersons and the speakers for the session. For the next session, I will invite Dr. Subodh Darbari as a chairperson and Dr. Jitin Bajaj to chair the next session. Dr. Subodh Darbari is a senior neurosurgeon in Jabalpur, and Dr. Jitin Bajaj is associate professor, NSCB Medical College, Jabalpur. Thank you, sir. Over to you for the next session. Thank you.
call Dr. Luis Cachara to speak on his lecture, Cervical Corporectomy.
Thank you, Chairperson, Dr. Darbari sir, and Dr. Jitin. We are from the Dr. Darbari and we are from the same institute. So once again, I thank Dr. Ashish and team for the invitation and including me in this program. My talk is the role of work, maybe not minimal invasive, but I think it's important procedure for the various cervical pathologies which we encounter, and we need to do this. So this is a treatment option for the so many this cervical pathology, particularly spondylotic myelopathy. You encounter OPLL. Sometimes may not be able to release with the simple discectomy. Some infectious diseases like port spine, trauma. It is very safe and effective treatment for all these pathologies. And it is the optimal treatment when the pathology is ventral compression and the patient has got a lordosis. So you can restore the lordosis by this procedure. So this is one study actually was done in the UK, and they have sent questionnaire to various neurosurgeons, about 1,500 or 1,700, but only 302 neurosurgeons responded. And from that, the most neurosurgeons, they perform fewer than 5 anterior cervical corpectomy, about 50%. Only 35% there. So it's a not very common procedure, but it is an important procedure to perform for this pathology. So particularly when patient has got intractable pain and progressing the neurological symptoms, and if you have to document with the various investigation, the compression of the cervical cord or roots. So the pain relief and resolution and reduction of neurological deficit can be expected in the vast majority of the patients. But the prognosis for the myelopathy is most variable. Majority of patients of this pathology, they present with the myelopathy only. Majority of the patients. I'll show the various examples. So in advanced myelopathy, the purpose is to stop the progression of the disease. So, and in long run, they probably improve from very, severely disabled to a significantly independent state. The selection criteria for the patient symptoms and aggressive studies you have to do. The only symptomatic cervical level must be addressed rather than the most abnormal level what you see on the imaging. Not you have to read the imaging, but the patient has symptomatic level you have to treat. So these are the preoperative planning. We have to go for detailed examination, X-rays, CT scan, MRI, and other things. Corpectomy we do. We have used autologous bone without instrumentation. Now we do titanium mesh cage, which is filled with the bone and fixed with the anterior plate. The multi-level multi-level corpectomy and pathologies affecting the bone quality seem to be a risk factor. The anterior decompression provides a good neurological recovery in patients with degenerative cervical myelopathy, and the titanium mesh cage provides a good structural support and solid fusion in these patients. These are some predictors which can have, you can have morbidity and mortality, particularly advanced age, patient with diabetes, smoking, is a grade 3 patient who has come with a very dependency, very, crippled, not able to severe spasticity, not able to walk, wheelchair, bound. These are the patient, not good patient, or a corpectomy more than 3 levels. And similarly, the same, and the spinal canal area, if less than 30 centimeters square, is an adverse factor for the good outcome. So I will show some examples of this various patients we have used. One patient with the severe canal stenosis, load signal changes, OPLL, will show small video of this patient. So what we do initially is the body, we just nibble it out and then with the microscope, initially we do inspecting above and below, then the perfecting. And this is the last part when the bones very much adherent to the PNL, we have to remove gently, dissecting sometimes you remove, you can open the each of the dura may be adherent on this patient, you have to be very, very careful. So this is single level perfecting and this bone and below is removed to decompress the area. Sometimes it is very, very adult, you can leave it an eggshell there, but it is very nice to decompress all around. So decompression of the body and so at the end, everybody is nice to here, both sides foramen and the fight exactly to that foramen. Now to in there. That's how we measure the size of the plate. And what we use is the remove the young chips from the body which we have removed. Then we pack the pad and we put in the space. Like that, and we put it in the plate. So this is the another case. The again OPLL here, 2-level discectomy and 1-level corpectomy. We have the OPLL is and very, very adherent. Second was not mobile, but he was obese patient, a very disabled patient. That's how we initial part I evaluate, then the better part which is more procedure, just in relation to the behavior of the diamond and sometimes then this part is the most difficult part. It is very much different and sometimes different. Another case, they all presented with the severe myelopathy. You can see here the flow signal changes. There's a compression just behind the body, mostly OPLL, small video. These are the significantly osteophyte buzzing that is state. Majority, I did single level corpuscle except for the 4 where there were 2 levels. Otherwise, mostly the single level corpuscle. The nicely supported ELL. Time it is so and it is not coming any of the punches. So by holding with the forceps and then separating with the knife part of the ELL. At the end, you can see the dura also here. So it was so adherent like that. But we have to decompress it. Another patient with the OPLL. So there are so many here. Sometimes this patient is already has got a severe spondylotic changes. There is the spine is due. He has come with a trauma and deteriorated. This patient we had operated. You see this is OPLL, significant canal narrowing, and post surgery he deteriorated also. This was one patient, but gradually he improved. So this patient with the severe canal compromise had a trauma also, and these patients they take a longer time to improve. Another patient with the OPLL significant at this level, I address only this level. And this is the post-op CT. You can see the but the canal defect patient had a good recovery here. This was so much so adherent that I had some neural tear also. There was a leak which we have repaired the fat in the field. Another patient with this is the two-level corpectomy we have done. Significant progressive difficulties he had showed me some 3 4 months back. In that duration, he worsened and then he came immediately that you operate me now next morning. So this is the count. These progresses and the patient they can have increasing difficulty in walking and neurological deficit. So this two level we have done, and this is post-op CT. Shows a good decompression and case and great fixation. Another patient with two levels had a very significant walking difficulty, but they improved very well following decompression. So this another indication I was talking. Patient has got a kyphotic deformity. I mean, not lordosis. So this is an important procedure to restore the lordosis. Here at this level, we have done corpectomy and lordosis is corrected. These are some more examples, pre and post decompression. This is uninstrumented. We use to just fix the graft. So this is a port spine patient, and this is post of program. Post of MRI showed the another patient with the port spine, and these are some trauma patients which we have treated with the corpectomy and another patient with trauma. Since another patient with trauma, I had only one patient with this tumor in the vertebral body. Which was, so it's all finished. 81 patients we have operated. There were 40 patients with the myopathy and traumatic patient with 4 spine, 10 patients. 4 patients had a neurological deterioration. All improved actually after some time. This OPLL patient, he had developed globally weakness, but he improved 4 spine patient also. One patient had a severe spondylotic myopathy following trauma. He deteriorated. These are transient. One mortality. This was a trauma patient who developed shifted to ward, but he developed pulmonary embolism and then succumbed. So mostly single level, only 4 patients, 2 levels. Initially we used fusion with Liagraft, uninstrumented, but now we use titanium mesh cage filled with the bone chips and plate and outcome is according to pathology, severe deficit patients they remain same, rest all improve. Trauma patient with the complete deficit usually has problem improvement, but the partial deficit patient they improve very well. Infection patient, all 4 spine patient, all patient they improve completely, and tumor patient completely improved. So in conclusion, the anterior cervical corpectomy and this conclusion is a safe and effective treatment for the cervical spine disorders with low complication and revision. It's an optimal approach for the ventral compressive myelopathy pathology with low dosage restoration. And it's a treatment of choice for all these conditions. Whenever you encounter, we can treat with this procedure. Thank you very much.
Thank you very much, sir. Such a nice and illustrative presentation. Next, we call upon Professor Y.R. Yadav, sir. He doesn't need any introduction. He is the founder, director of Super Specialty Hospital and School of Excellence in Neurosurgery, and has been considered father of endoscopic and minimally invasive neurosurgery in India.
Thank you. नहीं ठीक है चलेगा नहीं तो बीच में बैठ जाऊंगा. So I will be talking on endoscopic approach for cervical spine disease, that is disc preserving surgery. The commonly used approaches, anti-approaches are anterior ACDF and then artificial disc. So both these procedure, fusion is required, and therefore there may be adjacent segment disease. Usually in ACDF, there is a loss of disc height, pseudoarthrosis, and adjacent segment degeneration is there. A word about anterior versus posterior. So this diagram tells beta wo hai kya koi pointer. So anterior procedures are indicated when the pathology is anterior to the cord. So if the pathology is anterior to the cord, whether it is in front of cord or the root. So disc or osteophyte coming from anterior side, you need anterior approach. But if the lesion is from posterior side, if there's a facet hypertrophy or ligamentum flavum hypertrophy, in that case, the posterior approach will be required. Now the endoscopic procedures have been there for long, including our own experience, and these have been found to be very effective and safe. The advantage of endoscopic procedures are that it preserves most of the natural disc, fusion is not required, preserves motion unit, and the manipulation of the root is not required. There may be soft disc here, so if you come from posterior side, you first have to dissect the root. But if you come from anterior side, then the root manipulation is not required. So that is another advantage. The indications are there has to be anterior compression, not from posterior side. And you can do, we have done up to 2 level, although you can do more levels also. But the operative time is more. So we don't usually go for such case. The contraindications are significant posterior compression, such as ligamentum flavum or facet hypertrophy, canal stenosis, significant disc height reduction, or if the disc migration is too much, cranial or caudal, in which you have to remove part of the body or unstable spine. The relative contraindications are more than 2 level, and most important is that if you have a very dense OPLL or there's a double layer sign, that means as shown here, that means this is the dura. So intradural segment also had ossification. So these patients will have CSF leak. Now regarding the approach, one can go either through the disc So you can go through the disc or you can go through the vertebral body. So in the disc, you can go either from the center or you can go from the peripheral. So if there is a radiculopathy, then you go from the periphery, that is lateral approach. If there is a myelopathy, then you go from center side. If there is a migrated disc, then you can go also through the vertebral body and remove that segment. If you are coming from lateral also, then majority of the part also can be decompressed as shown here. And this is the type of the bone removal is very little and the disc removal is also less. In surgical approach, this is almost same as that of ACDF. The incision is small. So until you approach the disc, it is done under microscope, or you can take VTOM, and after that the surgery is done under the endoscopic vision. Correct site is identified again when you are at that level. The important thing in especially in myelopathy, see rest of the things are same. How to remove with a very small incision, how to remove the compression bilaterally up to the root. So the trick is that you remove a little bit of the anterior part and little bit of posterior part. This is only about 4 millimeter or 5 millimeter window. So if you remove little bit of anterior and the posterior, and if you use an angled instrument, then you can reach bilateral root and the cord can be decompressed. So this is an important aspect. Rest points are same. And another point is that if you are dealing with the caudal pathology, you have to move your tube cranially and angulate it caudally. So if you keep it straight, then the caudal part cannot be removed because your instrument will be obstructed by the tube which you are using. So move your tube, angulate it caudally, and reverse is true when you do cranial part. So this is review. This was C45 disc and this myelopathy. This is endoscopic. So central part of this, along with the adjoining vertebral body drilling and removal of the disc. So central portion is removed, the rest peripheral portion is left behind. And until you come across only a thin part and plate, very small and plate is left. So till then you use the drill. After that you can use very fine curate or Harrison punch. I always remove this posterior longitudinal ligament because there may be subligamental disc. So always remove PLL. This was osteophyte and a hard disc which can be removed. Using fine instruments and Harrison punch. So it's not seen here. So until you find good neural this thing, and dura is very versatile and move positively, that is there. Now this is the preoperative patient, C6, C7, post-operative MRI showing good decompression, and this you can see that the amount of bone removal is very small. So, and the disc also reasonably disc preservation. This is another case, central approach. The previous one was lateral approach only for radiculopathy. This is central, the amount of bone removal. You can make out the posterior portion of the bone removal is more than the anterior portion. You can angulate it. So even if there's an osteophyte, you can take it out and very limited bone removal. The alignment also post-operative, we have not come across any, misalignment in this. The results, we have done more than 1,000 cases in the last 10 years. The complications are minimum. There is a decrease in the disc height, but this does not alter the long-term results. Although there has been settling, but the patient continues to do well. There is a possibility of recurrence because part of the disc you leave, but we have not come across such cases. Maybe they have gone somewhere, but the explanation is because there is a dead space available there. So possibly the recurrence comes in that dead space. There is a difficult learning curve. You can have a hematoma, esophageal injury, and other complications of anti-cervical approach. But if you are careful, then all these things can be avoided. For detail, you can refer to our article published in various journals and chapter in my book, Endoscopic Surgery, a Comprehensive Approach. And the video on YouTube. So to conclude, endoscopic decompression using anti-approach is effective alternative to decompression. 2-level, it is indicated for both radiculo and myelopathy. And for disc, whether it is soft or hard disc and osteophyte. But there are contraindications when the compression is from posterior side or there is a double ring sign. Although difficult, but it can be learned, and once you learn it, then it is quite safe and effective. Thank you.
We are short of time. Thank you, Dr. Yadav. We can discuss it afterwards.
Thank you very much, sir. Next, we invite Dr. Sumit Pawar for his talk on unilateral biportal endoscopic spine surgery.
Thank you, respected chairperson. This is a relatively shorter talk because I have a half-an-hour session in the evening time to show the surgical technique of UBE in video and endoscopy model. This is just the why we are going for UBE when we have an excellent technique like PSLD already in existence. Yeah, we understand that you have to go transforaminal or interlaminar. The indications might be different for both, but if you have an interlaminar approach which is highly successful, a uniportal interlaminar approach, what is the need for going biportal? There is a short answer over here, which is in my mind makes sense to me. we had seen the evolution of endoscopy as a surgeon, in which we had seen that the last stage of evolution would be an endofusion. When you have achieved everything, you must have seen Dr. Sukumar Sudha's talk when he showed that how he was doing the endofusion, in the entire surgery by interlaminar technique. But in the end, when it comes a time to put a cage, he is taking another incision. It again becomes a biportal endofusion. It is very difficult, not impossible, but very difficult to achieve interlaminar fusion to a single port. In that case, I was thinking maybe I should learn the techniques of UV as well. If I want to do fusion, I cannot just start a UV fusion. I again have to go through the same steps again for my own cell so that I can go for a biportal fusion as well. This is the primary reason why I started doing UBE. It is a fantastic technique. It has limitations as well and many benefits. We'll just go through them shortly. Primarily, it is still, I'm an interlaminar surgeon with very few 10% cases being done in biportal fashion. Endoscopic surgery is not a revolution, it's an evolution. It is the next step. It's not something that is a maverick. I have thought of something, let us try to do it. Some people follow me and then the buzz goes off. It's not a revolution. It's an evolution. It is the natural next step. You have gone from open surgery to tubular surgery to fully endoscopic surgery. There could be age limitations, learning limitations. Even if you come to me also, when there is something totally different, evolution comes up and I will not be taking up that. If my results are good with my endoscopes today, I might not change it at the end. It's going to be a very, very significant, drastic change in the outcomes, which till now endoscopic has not proven. There are benefits, certain benefits, but it does not change the outcome really significantly. Please keep that in mind. We have discussed this about the endoscopy assisted surgery using air as a medium, in which we have examples of arthrospine and endospine system. And we have examples of a fully endoscopic underwater medium, which has PSLD and PELD, right? Transluminal interlaminar. UVE is a unique marriage of these two techniques, in which we have separate trajectory for instruments, but a fluid medium. The main difference between the open or microlumbar discectomy versus tubular versus MIS endoscopy is that the retractor system is different. Light source, magnification, and the dissection. The size of incision, of course, goes on getting lower and lower. Like I said in the earlier talk also, the end point of all surgery remains and must remain the same, which is de-roofing the bone, which is attached to the ligamentum flavum. I'm saying it other way around. If the patient is not happy at the end of any of the above surgery, the inadequate decompression is the cause and not the technique. Never the technique. The difference is in the vision, how beautiful you can see a particular thing. When I'm using a very high speed drill close to neural structures and my vision is so close, it gives me more confidence to use it better. I have sheets, we have hooded burrs, we have lateral sleeves, which make the life a bit easier. Have punches. Again, you can actually see very well how you're punching and what you're doing. The quality of vision in both things you can actually measure. Similarly, you can do it in cervical spine as well. The vision is significantly better. Adequacy of decompression can be really, really measured in these techniques. What we are doing in UBE technique is that we are trying to go under the sheath, lifting up the multifidus muscle, and we have to achieve having both the ports above the laminar surface. Very standard technique, GA prone, square disc space. It should be perpendicular to the ground, confirm with the CM. On CM, you have two portals. Suppose this is the target disc space. You have to take one, the upper one as a, and left hand as an endoscopy portal, lower one as a working portal. Means we can be 1 to 1.5 centimeter above it and 1 to 1.5 centimeter below the target difference space. Effectively, both ports should be aligned at least 2 to 3 centimeters away from each other, like you can see over here. Then there is something called, this is your docking point at the laminar spinous junction, spinal laminar junction. Once you're docking over there, the triangulation should be perfect, that both the tips of the instrument should be touching each other. You should check on the CM so that you know what you are doing and how, whether you are over crossing the triangle or under triangulation is such, it has been done. Serial directors are used to create the endoscopy in the working channel. The muscle is lifted of the working channel first so that we create a potential space. And then the endoscopy sheath is inserted, irrigation is started. This kind of a semicircular retractor is used to allow continuous movement of fluid. And a standard, I repeat, decompression under endoscopy vision is done. The unique benefit of this endoscopy technique is the angulation of your endoscope. This is the standard. I'll come to that later on. It is standard 30-degree endoscope. These are the basic instrument sets used for UVE. The cost of investment is exceedingly low. Almost all instruments that you're using right now for open or micronormal spine, same instruments are used for UVE also. Just few extra instruments are required and you can get started with the UVE system. This is the standard arthroscope that is used by most of the orthopedic surgeons in a hospital, maybe yourself as well. And a sinoscope, a 4 by 180 millimeter Hodgkin's endoscope is used for this. The advantage of bipolar endoscopy is that we have more flexibility to use the instrument because we are using bimanual technique. The right hand is only used, you can manually move any way, you don't have a limited by the single port of endoscope, and both hands can be moved independently. Routine instrument using open spine surgery can be used for UVE technique. A regular ENT or endoscope, what I mentioned, a very low investment, about 8 to 10 extra instruments are required, and you can just start the endoscopic surgery. The 30-degree angulation, what I was mentioning earlier, allows you to look, actually you can go inside, it's a very small endoscope as compared to interlaminar work, and you can actually see the foramen much better on both sides. The learning curve is not very steep. The comparative benefits of UV against other techniques. I'm sure if I start giving a talk on transformal, I can have similar papers on that technique, how it is better than others as well. This slide is, I think, very, very important for people who want to learn any endoscopy technique. This is a cumulative summation of about 91 cases that have been done from the first case when someone did endoscopic surgery to the 97th case that did endoscopic surgery. And this is the time taken for surgery and number of complications. Or they have graded the complication, the number that they have assigned for the complications. It keeps on going higher and higher up to 24 cases. After 24th case, the amount of time that it would take to operate significantly drops. The number of complications significantly drops. So 24 is the cutoff, the learning curve that you require to become an expert in UVE technique. And this is very similar to most of the other techniques. Interlaminar is about 21 cases. Transforaminal, some studies are saying 60 to 90 cases, some are saying again in 20s. Depends which study you want to follow. Now, after this 41st case, why do you think is there an increase in the rate of complication and amount of time of surgery? Exactly. Exactly. Your confidence has increased. You are doing more complex cases. You are undertaking some more difficult cases. Maybe you have reached in that flow chart, you have reached narrative. Maybe you have reached the bilateral decompressions. And the amount that time you are taking for a single level has increased. But if you cross that peak, if you cross that hill, it's not a mountain, it's a hill, then life becomes too much. This point, wherever you are in your trajectory of endoscopic spine surgery, any technique, or even MIS, tubular surgery, you have to cross these two hills, one mountain and one hill, to be able to effortlessly reach the value of chance. Thank you so much.
Thank you very much, Dr. Sumit. We can take the questions at the end. We now invite Dr. Umesh Srikantha. for his talk on MIS for primary spinal tumors, extended indications.
Good morning once again. So thank you, dear persons, senior colleagues, dear friends. So I'm going to be talking about some of the extended indications for some difficult primary spinal tumors. Metastasis is not included in this. Let me begin off by telling that the primary objective of the surgery, that is removal of the spinal tumor, is very well achieved by an open surgery. But we always, like in any other open surgery, we were always ignorant of the amount of muscle damage that used to happen. So this is one of our case. Underwent a single level laminectomy a few years back for a intradural extramedullary tumor, and they came back with a degenerative pathology and back pain. So this is the amount of muscle atrophy that was there for a single level laminectomy extended for almost 2 to 3 levels. Our journey in MIS spinal tumor, this is a simple case. Just for an example, I'm showing, started off with these single segment spinal tumors, IDEMs, very easy. You can just open the dura, do a wide laminectomy, wide hemilaminectomy, do an over the top, like open the dura in the midline, and then open the arachnoid. So I'll just fast forward the video. So identify the tumor, identify the nerve going into the tumor. If possible, if the nerve is traversing on the surface of the tumor, you can dissect it and take it out. Otherwise, you can just transect the nerve. You can either do an intratumoral decompression if you want to remove the tumor, or sometimes you can remove the tumor in toto as we are doing here, and then identify the nerve that is going in, remove the tumor in toto. So in this particular case, you can as well do an intratumoral decompression. And then dural closure can be achieved either by intermittent or very rarely we also use continuous sutures through the tube itself using some specialized instruments to achieve a dural closure. So this is the dural closure, and that was the tumor that was resected, and then you can layer a patch. The important thing again, as was mentioned earlier also, is the amount of muscle damage, the small laminar defect, as Rakesh also mentioned, this preservation of the paraspinal muscle is important. So does location pose a challenge? So as we go higher up in the spine, so this is the CV junction tumor like this, or tumors like this, which are large, which are significant large extraforaminal component. Again, we can remove the 22 millimeter retractor. So this is an atlantaxial membrane that is being dissected. Very important to remove this atlantaxial membrane over a wide area in order to access the tumor. And then once that is done, significant amount of intratumoral decompression can be done. The tumor margins can be identified. The C2 nerve going into the tumor can be identified, and then you can remove the tumor. Again, post-operatively, if you see, except for a small pseudomeningocele defect that is there or in that area, the amount of muscle damage that you have caused is significantly less. Usually C2 tumors in these cases, we'll have to extend all the way from the base of the occiput in order to remove the attachments of the C2 nerve in order to expose the tumor as well as go to the lateral extent of the tumor. It's not required anymore. But size is a concern because we are operating through a 22 millimeter tube. So the bigger the tumor, we will be able to access this. For example, like this, a giant paraspinal neurofibroma. So as it is possible, we can just wand the tube. We can change the angulation of the tube in order to access different areas of the tumor. Again, a very short video, you document the transverse process, move your tube into the intercranial ligament, remove all the soft tissue, identify the tumor. You can do an intratumoral decompression. You can identify the nerve going into the tumor. Once you tackle that nerve going into the tumor, the vascularity significantly reduces. You will be able to get more access to the surface of the tumor. So that is the job. And then once that is there, you do a sequential peritumoral dissection as well as intratumoral decompression, like always, in order to do that. Again, that is not the concern. The post-operative MRI, this is a post-operative MRI, you see the complete tumor excision. But more importantly, you can see the paraspinal muscle injury, paraspinal muscle damage, intactness of the paraspinal muscle. The only difference that you'll be able to make out is a thin out psoas where the previous tumor was there. And as long as we are talking about the size, this is again a giant intrathoracic. This guy just went with some chest pain, did a CT, tumor was detected, the CT guided biopsy was done, came as neural sheath tumor. And guess what he was recommended? He was recommended a thoracotomy to remove this tumor, but it's actually not required. So you can actually do a small incision from a posterior paraspinal approach, just to show what is the approach here. So we just make a cut in the transverse process. We don't have to enter the canal. We just make a cut in the transverse process, remove the transverse process, make another cut lateral to the angle of the rib, and then remove the rib along with the rib head there. And then you will have complete access to the tumor. And again, once you are in that area, you can warn the tube in order to access different areas of the tumor. This is the post-operative image, again, complete tumor excision. The only defect that you are seeing is defect that is there at the level of the rib, that is there where we have excised the rib. Otherwise, the paraspinal muscle is again significantly intact. You can use this for bony tumors as well. It's very easy to actually monitor these bony kind of tumors intraoperatively itself using the CR, where you can actually determine the extent of tumor resection with the CM as these are visible. But his size is the really concern. That does it mean that small tumors are always easy? Consider this. This is in a junctional area, a D12L1 level. It is going across the facet joint. There is an intraspinal as well as an extraspinal component. So normally what would we do in these cases? Normally you would sacrifice the facet joint. You will end up, because it's a junctional level, you will end up with a fusion in these particular places. But can we tackle these tumors in a different way? Yes. So you can do 2 incision techniques that we have done for several cases now. You can use one technique for an intraspinal approach, remove the intraspinal portion of the tumor, and use another incision, an extraforaminal approach to remove the extraforaminal technique. Again, this is again a short video. This is the intraspinal approach. This tumor was extradural. So we can actually remove the extradural portion of the tumor. Can remove the extradural portion of the tumor there. You remove the tumor all the way up to the foraminal level, and you just leave that cut portion of the foramen there. You have removed the intraspinal portion. Now that is the cut level that's going into the foraminal area. Then you dock in your tube from the extraforaminal area, and then you can actually remove the tumor from there as well. You can just pull off, that is the portion that is there in the foramen. We are just removing it because that area is ingress free. We have just disconnected it from the intraspinal portion using the right angle and just pull it out from the foramen. So the complete excision was achieved. Again, this is a post-operative MRI. The only defect that you are seeing is a small hemilateral defect. The facet is preserved. The paraspinal muscles are again intact. But do we need to do the same thing for all dumbbell tumors? Now, in a cervical spine, we know that the facets are quite wide apart. They are more flatter. They are more wider. So that will help us to actually access the extraforaminal portion of the tumor under the facet. We don't have to remove the entire facet, or we don't have to come in the extraforaminal area. And that is what can be done for these kind of tumors. This is the intraspinal portion. Again, intraspinal portion. So you're opening up the root sleeve where the tumor is going inside. Along the root, you open the dura, cut it along the root, and then you have access to the intradural component of the tumor. So once that is done, you identify the root and vascular pedicle that's going inside. You can cut the vascular pedicle. You can do a medial tumoral dissections, elevate it from the surface of the spinal cord, avoid any kind of pressure inward that will be transmitted again to the spinal cord, and then angulate the tube laterally. This is the lateral portion you're doing under the facet. You are removing the tumor from under the facet, and as you can see there, so that is the vertical artery. You are just lifting off the tumor sequentially from under the vertical artery, and progressively you can actually remove the entire tumor. So that is the course of the vertical artery. That is the disc base. That is the defect. And this defect will also be closed by using some 2 sutures to anchor the ends of the cut that you have made, and then you can put a graft. Like a dural substitute that is there, and use glue in order to close the defect through which the tumor was coming out. Similar technique can also be used for large multi-compartmental tumors. Again, it's a similar one as I showed last time. I'm just going to skip the video for a lot of time. But what if the extraforaminal component in the cervical spine is also bigger? So can we approach this in a different way? So for example, this case has an intraspinal component as well as a large extraspinal component. There is a large dumbbell component that is going into the scalene muscles there. So in those cases, you need to plan, you can do an intraspinal approach with 1 incision, and the second incision has to come posterior, that is in the posterior border of the sternocleidomastoid, which is going to access that extra foraminal component. So these are the 2 incisions that we had planned. As you can see, the second incision is slightly at a lower level because the tumor is going below inferiorly, and this is the approach that we have taken for that. Again, this is a very short video. So this is the planning, positioning. This is the intraspinal, the first component of the tumor. Just like what we saw in the last time, we are removing the extradural portion. We are creating a space laterally where we can work, we can bring the tumor out, and then opening the dura along the nerve root, we are doing an intratumoral dissection there, and then gradually delivering the tumor out into the canal, avoiding any kind of an intraspinal manipulation, avoiding any kind of an inward pressure that is there on the spinal cord. Because mind you, in all these tumors, the contralateral lamina is intact. Any kind of an inward pressure on the tumor is going to get directly transmitted to the spinal cord, and that has to be avoided. So once that is done, then you again angulate it laterally, because from lateral you are not going to come into the foramen. It's very difficult to identify the vertebral artery there. And just like we did last time, we angulate the tube, remove as much of the tumor as possible under the facet, angulating like that. That is the vertebral artery again. Once that is done, you reconstruct the dural sleeve and then dock in your tube laterally. So when you dock it laterally, the first thing we identify there is the lateral part of the facet joint and the cut end of the tumor. So that is the cut end of the tumor that we have dissected and left behind from the medial portion. And you just remove the few fibers of the scalene muscles that are draping on the tumor, and then you have access to the extraforaminal component of the tumor as well. So that can be complete. So we have a series of around 80 cases so far. Average size is around 3.2. The longest, I think the thoracic one was long. Most of them were IDA, most of them were thoracic in location, most of them were schwannomas, and majority of them were 2 to 4.5 centimeters. We have 12 which were more than 4.5. We had the partial transient neurological deficit. All of them were in thoracic tumors. In 3 cases, fortunately, all of them improved. Otherwise, no major issues. There are some concerns which I have highlighted throughout the discussion. Just to summarize, minimal access resection is feasible, safe and effective. It offers the benefit of complete tumor resection along with the benefits of minimal access spine surgery. Obviously, comparative trials between open as well as minimal access spine removal are still pending. Thank you so much.
Thank you very much. We can have one question from each speaker. First, we invite questions for Dr. Rajesh Kachara, sir. He spoke on corpectomies. Questions for Professor Y.R. Yadav, sir. He spoke on endoscopic anterior cervical discectomy, disc preserve. Yes, please.
So the space which is created when we do limited discectomy and corpectomy, do you use anything to fill that space, or it is just left as it is?
Left as such, except that you put in a little bit of surgery cell or abgel, that's all.
Have you encountered any epidural hematomas? Because
No,
dead
absolute
space.
hemostasis must be close. So, fortunately, I mean, there are possibilities because the dead space is very limited. Plus, you have to go for absolute hemostasis. You cannot close in a oozing this thing.
And do you use drains?
No.
Okay, thank you.
Thank you, sir. Next, we invite question for Dr. Sumit Pawar. He spoke on unilateral biportal endoscopic spine surgery. Yes.
And how do you handle your right versus left confusion in UB? Means there is a lot of discussion that happens because UB is very well favored for a left-sided approach. Your scope is there, your right hand is there. Right-handed surgeon, when doing a excited case, do you change the crane? You still keep the scope cranial?
I prefer to keep the scope cranial only.
And then would you have
I think by that time you should achieve significant ambidextrosity to use the instrument that way. And because see, left hand side, when you're using a drill, especially power instrument you're using, you have adequate support from the tissue to it should not slip inside or it should not plunge. you have the tissue is giving you enough pressure, and then movement becomes easier.
So for people who are not very used to, doing the entire surgery with their left hand, is the learning curve more than what is shown?
Absolutely.
So you mean to say the learning curve for a left-sided pathology and a right-sided pathology is different?
It would be, yes. For interlaminar, not at all. There is no difference in interlaminar unifocal technique for right or left sided technique. For right or left sided approach. But for UV, definitely, even I start to be confused sometimes because I'm used to holding this program in one hand. And it becomes just two punches at nicely.
Why is it that you can't put the scope
You
order?
you can, but so the angulation of the, suppose I put a punch. I have a 45-degree punch or a 90-degree punch. My angulation at which I will hold the span lamina will not be appropriate. You do not have to take the insulin slightly lower. A little bit, once I make that. Only for the angulation.
Thanks.
Thank you. We now invite question for Dr. Umesh Srikanta. He spoke on MIS for primary spinal tumors extended indications.
I have one question. For the extra spinal component, suppose we leave it on thoracic segment. What will be the problem?
I'm sorry, sir. You mean relieve the residual tumor?
Which is extra spine.
The possibility that it is going to grow continuously.
What will be the problem if it grows?
So we have seen large, I know what you're saying, because the even large giant intrathoracic, you see tumors are rarely symptomatic. That's an option that we can.
Dr. Yadav, your comment, please.
Difficult to comment. I have no experience, but I think the larger it become, it can come back to the spine through the same opening.
Remove the spinal component.
No, I understand. But when it becomes large, it can come through the same intervertebral foramen towards.
Unbind.
I had operated one patient like that, intraspinal component. I cleared, decompressed the cord. I left that extra spine. Patient is completely asymptomatic. 2-3 years now, he is coming in regular follow-up. I'm also following. If the tumor grows, then we'll hand over to some other specialty to operate the patient. So probably they remain asymptomatic, even very large tumors. So I don't know whether to tackle the same sitting or I don't know.
Question is that one of the biggest compensation in Indian history has been given to the table tennis player for a similar tumor, and for neurosurgeon was a case in Hyderabad. So why don't we leave it the extra spinal component?
Very frankly speaking, sir, I would not be able to explain any relative why I have left a tumor behind. I don't know what is your opinion. What do you say, Dr. Umesh? If you can, would you leave?
Decompress the spinal canal and leave behind this one. We would have counseled that pre-operatively, and we would have planned that pre-operatively, sir. But of course, if we have decided intraoperatively that, okay, I'm not going to do that, even though we have planned to do that, but I'm not going to do that. Obviously, it needs to be retackled at some point in time, because the patient is always going to think that, array, it was supposed to be removed, but it is not removed. So,
Yes.
No, but these tumor can be symptomatic also. This last month only we operated one extra spinal tumor that was in lumbar region, and patient was presented with lump abdomen. And another one was in dorsal region, and that patient presented with breathlessness. So sometimes the giant tumor can be symptomatic also. It's not like that they are always asymptomatic.
In the interest of time, we will conclude this session. Thank you very much, respected Chairperson Dr. Darbari sir, speakers, Professor Yadav sir, Kachara sir, Dr. Sumit Pawar, Dr. Umesh Srikanta, and all the audience.
Thank you to the chairpersons and the speakers. For the next session, I would like to invite the chairpersons for the next session. Professor Dr. Vijay Parihar and Dr. Harsh Saxena. Professor Vijay Parihar is a professor neurosurgery in Department of Neurosurgery, NSCB Medical College. And Dr. Harsh Saxena is a senior consultant neurosurgeon in Jabalpur. Thank you.
I would like to invite Dr. Vinu Gopal for
Yeah, he's professor, Department of Neurosurgery, Government Medical College, Kottayam. And he's going to speak another interesting topic, which anterior retropharyngeal approach to fixation of atlantoaxial joint.
Good afternoon, respected chairpersons, senior colleagues. I would like to share my limited experience on the right-sided anterior retropharyngeal approach for fixation of bilateral atlantoaxial. Posterior approach is the gold standard, which was popularized by Dr. Abidgo itself, but still there are some problems associated with this. The vertebral artery is very close proximity to the C1, C2 joint, and because of the venous anomalies around the vertebral artery, it's likely to be get injured. The risk for vertebral artery injury is 3% as per literature. And also the disruption of the posterior ligamentous complex and C2 root innervation that can also lead to paraspinal muscle atrophy, which worsens the instability. And the bleeding from the suboccipital venous plexus is difficult to manage in an amateur's hand also. And also there is problem with the prone position, its complications. So we have thought of this anterior technique thanks to Dr. Parker for popularizing these techniques. So the advantage of the anterior approach is that there is no risk to vertebral artery injury, paravertebral venous plexus or the C2 ganglion. The position is supine, which is more physiological, and we can have adequate access to both atlantoaxial joint to the same incision. And the approach is retropharyngeal and intermuscular. So it can even be used in irreducible AADs and basilar invagination. We use a customized wedge-shaped lordotic titanium cages with poly-slotted plates. These are very cost-effective and which has a self-tapping screw. And once we tighten it, it will engage in the next lower slot and provide sufficient compression and protection. These are the implants that we use. And this approach can be used for atlantoaxial instability, basilar invagination, rodontoid fractures, rodontoid decompression, and can even address other subaxial cervical spine pathologies through the same incision. So for a preoperative evaluation, we need a dynamic lateral X-ray, and it should be such a way that we can use this technique only if the angle of mandible is at or above the level of the C2 bone. And the virtual reality axial and sagittal three-dimensional CT images will help you a lot in planning. So coming to the surgical technique, I'd like to use a nasal intubation of the patient This is the position of the patient. The neck can be strapped so as to open up the corridor. And I use a Mayfield clamp for fixing the head also. So this is the operating room setup. The surgeon can comfortably sit on the right side of the patient with the assistant on the other side, the scuffness and the trolley on the caudal end of the patient. Can maneuver the microscope and see a motion. Can use the CM in two planes or you can use a biplanar CM. Coming to the operative steps, as general surgeons, we have all done submandibular silent adenectomy at the same incision, a curved incision 2 centimeters below the mandibular margin, from the midline to the angle of mandible, safeguarding the marginal mandibular nerve. And once you raise the subplatysmal flap, you will be seeing the submandibular gland. And once you open up the fascia, the anatomy is almost constant. Once you open up the fascia, you will see the digastric tendon. Immediately beneath the digastric tendon will be the hypoglossal nerve. And they use a dynamic retraction so as to safeguard the hypoglossal nerve. Once you open the loose areolar tissue between the constrictor muscle, you will be directly getting into the prevertebral space with the C2 body in front of you. So actually it is very easy to approach the contralateral side through the right side. So better to use a dynamic retraction that rather than a fixed retraction. I will go to the video. So let me orient this. This is the right side. The submarinal gland is cranial side. You can see the hyoid bone, thyroid, ligament, carotid and sternomastoid, the right side lateral. Now I am retracting using a Langenbeck retractor. You're directly over the C2 body. The thing is that the longest collar muscle will be very much adherent to the C2 body in the cranial part. So we'll have to dissect it laterally so as to expose the C2 body. Here you can see the longest collar on both sides and use a low current bipolar to dissect out from the C2. These are the longest collar on both sides. You can also see the muscle now. Try a dynamic retraction rather than fixed retraction so as to avoid injury to the hypoglossal nerve. Much adherent, you can even cut the enormous with the monopolar and then you can suture it back in. Lack of time, going to the last one. So here I am cutting the longest on the right side so as to gain access to the right Atlantic axis. This will be the picture once you wear the C2 body. You can see the right plantar axial joint, the joint capsule. You can see the left side also. The suction is directly inside the joint. You can decomplicate the joint using a Tourette. Now the joint is, you can see the joint moving. You can see the C1 lateral mass in the subbicetal region of C2. You can even use a drill so as to contour the subbicetal region, drill inside the joint space. It will aid in the conclusion. So now you can see the joint. Very easy to do the dissection on the left side from the right side. The right side will be a little difficult. You have to give a small action and you will have to angulate the microscope to the right side. So two joints are visible. It's the right one. And removing the joint capsule. Now you can see the joint.
You can see both the joints to the same incision. The left side at adductor exit joint, you can see the sector, see the lateral mass of C1. Here the subplacent region of C2 is filled so that to be able to place the screw easily. Here after correcting the joint, release the joint, which can try with the gauge to that standard joint on the side. Then even use a tool to contour the joint so as to place the gauge. The gauge that is studded with G-bone. I am introducing it to the that can reduce the base level aggregation. So you have a lot in cafeteria approach. You can use an anterior plate and screw, or you can even use transarticular screws. So if you want to use a plate and screw, the C1 screw should be 25 to 30 degree down and out. You can directly see and go. Whereas the C2 screw, use an IP also here, should not be too lateral. You can keep the lower plate immediately so as to get a good bone stock. And the wedge orthotic case can reduce the basilar imagination, and once tightened, will lock in the poly's loaded plate. This is the plate that was angulated medially. I've already put the screw on the C2 body. It's angulated little medially. Don't go ahead with that. Use a 20 mm drill to drill the lateral mass. Screws are self-tapping. You can easily put, you can easily see and put. No need for CM or it's a plate that we are using a gauge. This is the screw. Then actually measure it with the preoperative image. Right. So you can use an anterior transarticular also. You go through the video. Here you can see the right side is being retracted using a Langen web. You can see the joint. Ideally, you should look the subplacent region of C2 also. The adequate bone stock before introducing. Otherwise, that can break. Now you can see the lateral mass and C2 and the joint together in this picture. Use a drill. Drill from a little bodily as not to break the surface. Make sure not to injure the surrounding structures. Carotids and esophagus. Meeting. Try to use the retractors. Safeguard the vital structures. Try and protect the subplacent region. The transarticular screw. So these are my limited experience with these cases. I had a transit hypoglossal weakness in one patient with dysphagia, another patient for liquids in a few days. That transit weakness subsided. There was recurrent aspiration in one patient. These were some of the cases. Bilateral transarticular screw for odontoid fractures, bilateral cage distraction, latent screw for AAD, Shakespeare imagination, the combined odontoid screw with the screw, the LR ligament is damaged. They have also done one extrapyramidal odontoidectomy. with plate and screw fixation. This is the patient being brought into the OP. Post-operative virtual images will also help you seeing the screws and plates. So the limitations, it's a steeper learning curve, the technical difficulty, long-term follow-up regarding fusion need to be addressed. Further research on biomechanical feasibility should be done also. So I have published this in Journal of Spinal Surgery. Time permits, please go through. Thank you. Thank you.
Thank you, Dr. Gopal. We'd like to invite our next speaker, Dr. Prakash Moda, a senior spine and neurosurgeon from Rajkot, the president of NSSA. The chairman of the Gokul Group of Hospitals.
Good afternoon, Chairman and my friends. It's too late today for the lunch, so I'll try to curtail myself because this is the basic lectures, and I wish that there are certain things to learn from this lecture also. So I will not go through the presentation, but I will certainly go through the history. Mixer and bar describe the first surgical lumbar hernia operation. While posterior transmural discectomy. 1937, it was that minimally invasive surgical expansion. In 39, now describe an approach declining the critical step, injecting the tubular cell, and removing the disc earlier. This is a standard discectomy procedure. Ellis invented bipolar forceps and later on the versatile microscope. Thing which we are talking today is was invented in 1957. Basil Nixon was the first person to invent fiber optic endoscope. And Ovila lived the principle of micrometry. Kasper from Germany developed the technique, Yasser and Fisher. They were independently with the modern micrometry. A proof of another thing, which was launched in US and Japan by Orbe in 2007. So this is two things. The technique of micro-lumbar discectomy is very famous and till today it is the gold standard technique, I would say. Procedure of choice for a prolapse intravertibility because minimal dissection can have a direct 3D, magnified vision, excellent illustration, meticulous handling of the nerve roots, and effective decompression of the nerve roots, and less tiresome for the surgeon when gets tired, its hands and everything easily. While this is the procedure where surgeon gets relaxed. There is no age limitation. We have operated youngest 15 years and the oldest 85. Majority between 21 and 50 years of age. Procedure of choice of prolapse intravertibility, lateral recess stenosis, and excision of the osteophytes. The type of disc prolapse everyone knows: lateral, far out lateral, medial, midline, multiple level, and bilateral disc prolapse, where the micro-lumbar discectomy can be used. Usually, time for selection of the patient, we give trial for 6 weeks. And if the patient is young, we can give trial for 4 weeks. And if he improves, we treat him conservatively. If he does not, we go for surgery. Now the surgical procedure, everyone knows, so I will explain. Fenestration of upper 2/3 lamina and lower 1/3 lamina. 1/3 of the medial passage Ligamental cleft was open in window phase. Now it was reflected medially. This was identified as in square shape with number 15 flat. This was removed. Lumbar fascia was sutured. Subcutaneous tissue and skin were sutured layer wise. Now, this is important technique in the theater. What we are doing is we use the anesthesia, we establish that, but we use posture by continuity. Patient is lying prone, and we have a bipolar as well as vascular drill and unilateral micro detectors. Dr. Ramani used very less blood loss. Person time is very less, 1 hour only. Even sometimes less than that in a single level. Antibiotics, vaccine, and after surgery. No shaving, no catheter, no removal train. The important things I am talking to young neurosurgeon is eye protecting device. This is the device where when the patient is prone, when they protect his eye, see the eye. So there were incidents that in a prone position, patient become blind. So that is why this device one should always use in a prone position. And we do IITV marking of the skin incision. It is also 18 to 20 millimeters long only. We do the use microscope in this, cutting the lumbosacral fascia, to see to be cut lumbosacral fascia, then stripping the muscle in a microdiscectomy. We use bone scalpel to cut the lamina nowadays, and you can see the linear, very sharp cut in the lamina, and this is in the facets. So then we close the lumbar fascia, and you can see the incision, only 3 stitches, and it's almost about 20, 18 to 20 millimeter. Then we started using expandable tubular protein. With this, we used to, we can do 1 level or we do 2 level also. This is the procedure where we can remove the teeth by using Medtronic's expandable tube detectors. Then we can be tubular detector. But with the help of microscope, we used to do the detector. And after that, we started using the tubular endoscope. So our post-operative regime was sitting and walking on the same day, other central exercise early, 1 resumption, 2 weeks, hard manual work, riding 2 minutes by 4 weeks, and 4 minutes by 3 weeks. So this is the patient who is sitting, walking. We had almost 98% immediate pain when linked with the microdiscectomy. The complication, you were all aware that infection, neural tear, iatrogenic damaging the nerve roots, stiffness of the back, list of the spine. We do manage the CSF leak by suturing the 6-0-ethylone and thread, or we may put muscle patch on the top of it. We put Ralisil or T-seal. When T-seal and Ralisil was not available, we used to put centrifuge the blood, and the cork of the blood, we used to keep it, which was rich in platelets, and with that also we have having a good result. To diagnose CSF infection or will avoid it. Now, in 12 years, we have done almost 15 research. Out of that, 70% had a follow-up of 10 years, and 25% as follow-up 2 years, 5% lost for the follow-up. Males were predominantly than the females, and commonest this space was involved was L45, then L5S1, and then all others. Most patient resume their duties in 2 weeks' time, hard work by 6 weeks' time. The recurrence rate in Casper series, early period there was no recurrence. Always the surgeon says that I'm fine, I don't have any recurrence. But later on, they came and there was a recurrence in Silver series, almost 3.3%, Wilson series, 4%, Williams, 9%, and Williams later series there was no recurrence. In our series, we had a 2.4% recurrence rate. 36 patients developed recurrence, 12 patients because of the technical fault did not leave the hospital and we reoperate. 8 patients had an opposite side problem and we have to reoperate them. 5% two recurrence, 6 months and 2 years later. 3 patients, there was a symptoms of recurrence, but there was no disc because the adjacents. 3 patients had calcified PLL causing no root irritation, and 5% has lateral resuscitation. 12 patients had higher disc prolapse more than 5 years after surgery, same side, required surgery, but there was no disc prolapse on the opposite side in our series. The incidence of the adjacent segment was 0.7%. So in conclusion, microlumbar discectomy or tubular microdiscectomy is the safest, minimally invasive procedure, providing direct 3D vision, maximum comfort to the patient, and returning him to the original job earlier. We did comparison of tubular discectomy versus microdiscectomy, and we found that tubular retractor discectomy is to split the muscle. There is less pain at the operative site. In tubular retractor, incision was 2 millimeters smaller than the microlumbar discectomy. Can go one level above or below with this procedure and can go to the opposite side. Thank you very much.
Thank you so much, sir.
Any question?
Really considerate from your part. I would like to invite our next speaker, Dr. Chenal Gurnani. He's a consultant neurosurgeon and micro from Surat. So, posterior cervical.
Good morning, all. My today's talk is based on posterior cervical fragmentectomy, a gimmick or a panacea. As we know, the cervical fragmentomy is the extrapolation of the lumbar fragmentomy to cervical spine. Now, what is the general treatment for cervical disc prolapse? So, ACDF with or without fusion is still gold standard. ACD with or without fusion is still gold standard, time tested. It removes disc completely, no recurrence, and can deal with generally all pathologies. But the disadvantage with it is obviously fusion surgery, AST related complications, and the approach related complications. So it generally removes disc and removes the motion too. The solution for that is generally artificial disc replacement. The entire disc is removed, but it preserves motion, and obviously the cost is still very high. So it basically removes disc, preserves motion. Now, what is the solution of all this? So MIS posterior laminoforaminectomy, whether you do it by a tube or whether you do it by an endoscope, it is a motion sparing approach. No instrumentation is done, so instrumentation related complications are less. But the disadvantage is there is limited case selection, venous bleeding, and there is a chance of recurrence. It preserves disc and preserves motion. The position, I generally use a 4-pin retractor with neck inflection. The disadvantage of it in the initial days, you may require a AP image, which is not possible as I don't have a radiolucent one. You can use a gel headrest, but the disadvantage of it is in short neck cases with flexion, adequate flexion is not achieved. And horseshoe, that is the worst. Nor it is radiolucent, nor it achieves good flexion. If there is short neck, you may require to strap the shoulders down too. And this is primarily a video presentation, so I'll show you a short video. As we see, the indications are generally cervical disc herniations or osteophytes that are primarily lateral to the thecal sac, patients presenting with radiculopathy, no myelopathy, no need of implants, a shorter hospital stay, minimal post-operative neck pain. This is basically a video of a 39-year male. He had a right arm pain for 3 months. Conservative therapies were failed. He started developing right shoulder weakness with deltoid wasting, no signs of myelopathy. As I said, the patient is prone under general anesthesia with either a Mayfield or a 4-pin, a 2-centimeter incision, 1 centimeter lateral to the midline, METRX tube dilator. Generally, I started with a 22 mm port. Now I'm finally at an 18 mm port. As you see, there is a disc herniation at C4, C5, primarily on the right side. Now, I would like to stop here and I would like to see, this is the docking point. The docking point of the tube is here at the lamina facet junction, and this much drilling is required. So basically, you need to convert the V into the U. If you go too lateral, you will damage the facet. If you go too medial, you will unnecessarily cause too much of a laminectomy. So here you are standing on the right side. This is the cranial part. This is the caudal part, and this much drilling is generally required. After marking the level on the CM, the skin and the fascias are cut. Now, the difference in docking in cervical and the lumbar is that cervical musculature is very strong and cervical muscle multi-layered. So first I do a blunt dissection either with a penfield or using the posterior part backward point of your knife, or you can even use a mosquito forceps to dissect the muscles and then use a trocar. Make sure you don't plunge the trocar in and feel the bony landmarks or use multiple CM images. Once the positive X-ray, we pass serial dilators over it and pass the 18 mm working port. I generally take 4 shoots. The first shoot is with the needle during the marking of the incision. The first dilator is the second shoot, the final dilator, and the working channel. There is generally a small strip of muscle, so you can use it a monopolar cautery to coagulate the muscle. Now, as I showed you in the previous bony model, I'm standing on the right side. This is the cranial part, the C4 lamina lower border. This is the C5 lamina upper border, and this is the facetal complex. So we need to drill this much of wood. Coming to the drilling, I use a Metronic drill. This is the small cutting burr. You can even use a diamond burr. Now, the main issue with cervical spine, that ligamentum fleum anatomy is slightly different as compared to the lumbar spine. The ligamentum fleum is thinner. It merges quickly below the caudal lamina, and it does not have a foraminal extension, a large foraminal extension like the lumbar spine. So make sure you don't injure the root with your drill, and you can use a diamond drill for a better hemostasis. And while taking punches with the upcut, make sure that the punches don't take the root into it. Now, after you drill the lower lamina of the upper vertebra, you drill the upper lamina of the lower vertebra, drill the inferior articulating facet. After you drill some part of the inferior articulating facet, you can see the medial superior articulating facet and the tip. You can drill that. The caudal pedicle will be visible here. You can even drill it if root mobilization is required. And the caudal pedicle also serves as a identifying landmark. The root is exactly above the caudal pedicle. You can use a penfield or a hook to palpate the caudal pedicle. Generally, venous ooze is encountered at this stage, but you can always bipolar it. You see, this is the caudal pedicle border. This is the inferior articulating facet, and this is the superior articulating facet that continues up below the IAP. Now, this is the point after the phleum. This is the thecal sac. This is the root. Cervical disc herniations are never in the shoulder. They are generally in the axilla or just below the nerve root. You can always use a hook to mobilize it. You can tease out the fragment, or you can even do a small annulotomy with a 15 or 11 number knife. You can clearly see the root here, which is totally inflamed, and this is the lateral border of the thecal sac. The fragment is being teased here. First, a small fragment has come out, and after the space is released, a larger fragment will come out. See the larger fragment which has come out. Now the issue is hemostasis. After achieving good hemostasis, you can withdraw the tube and you can see the muscles coming back to its original position. Now complications, certain complications are MIS related, like K-wire induced injury. I personally don't use a K-wire. The dilator related injuries can be common, so make sure you don't plunge the dilator. If you're too lateral, you may injure the vertebral artery. Wrong level, this is most important. As cervical spine, the lamina footprint is very less. Slight angle of the tube may land you at the wrong level. Now, general procedure related complications are too lateral or too medial drilling, venous ooze, root injuries, and no fragment is found. If no fragment is found, make sure you do a good foraminotomy, check the date, the site, and the CM images again. Summary, it is a safe and effective technique. Case selection is important. Ideal cases are soft lateral disc herniations with only radiculopathy, no myelopathy, a disc osteophyte complex with radiculopathy. It is a great procedure in selective cases, motion sparing, lesser hospital stay, good return to work, and smaller incisions. Thank you.
Thank you, Dr. Gurnami. Friends from Gujarat have been very considerate. And now, invite Ashish, the senior neurosurgeon. To speak on neurosurgeons.
even before I start my lecture, I would like to present my sincere appreciation uh, from my side and from all the neurosurgeons in the town for helping us with this workshop and conference. So extremely thankful for it. Today I'll be speaking on the spine blocks for the neurosurgeon. I think even if the audio is not there, you would remember this scene from Three Idiots. And basically he's talking about the pen and space. And then Amir Khan talks that why can't they use a pencil? And so, you know, we are, as neurosurgeons, we are so uh, involved in lifting heavy that we forget to lift light. And I would urge each one of you to pick up spine blocks. Why should I learn blocks? It's not a steep learning curve. It's easy to pick and helps clinch diagnosis many a times. And it is now part of the algorithm of the treatment algorithm. So if we are not involved in it, there is some part that we are missing. This is a small set of blocks that I use. I already spoke about erector spiny block yesterday. Use transforaminal blocks. I think Mayuresh would be dealing with it. Facet blocks, medial branch blocks, epidural blocks, caudal epidural blocks, SI joint block, ganglion impar block for coccydynia. And the latest I've been taught is serratus anterior block. And I'm using the serratus anterior block left, right, and center. And all of us here have patients of mild, moderate, severe head injury, not severe, mild or moderate head injury, complaining of chest pain because of rib injuries. These serratus anterior blocks are very, very easy, just a bedside procedure, and they give excellent pain relief to your patient. Though not part of our day-to-day neurosurgery, but still they are excellent. So why blocks? See, literature proves that the association between imaging and cause of pain in chronic cases is very big. And we still go by only imaging. And it's only 15% of cases where the source of chronic pain can be picked through imaging alone. So just imagine how many of our patients we are missing the diagnosis. So we have diagnostic as well as therapeutic indications. For diagnostic nerve root block, the only thing is that you give smaller amount of local anesthetic so that it does not spread to other nerve roots. But other than that, it remains the same as a therapeutic block. As far as frequency of blocks is concerned, you can give 3 to 4 per year. And at least there should be a gap of 2 weeks prior to giving another block. These are some contraindications, anticoags, local infections, allergy, etc. Here I've mentioned pregnancy, but with the use of ultrasound and it coming strongly into our OT, even you can give blocks to pregnant ladies. Type of steroid, please do not use particulate steroid. There is ample evidence that Decathlon or dexamethasone, which has been our friend for years together, decades together, is the best. So no need for using triamcinolone or betamethasone or methylprednisolone. These are particulate. If they enter the vessel, they can cause thrombosis. What is the rationale of use of steroid? Well, it has been proven that with local anesthetic mixed steroids, it has a much longer duration of response. Now, you look here at this data, when you're using epidural steroid versus bupivacaine injection in disc prolapse, 23% required surgery. So there's a big number which you can sort of reduce as far as surgery is concerned. Now, I'll skip. This I have already spoken about. Fluoroscopy versus CT, the bottom line right now is that use fluoroscopy. It is available fast, less radiation and real time. Now coming to erector spinal block, I've already spoken about this yesterday. And you just have to take your spinal needle towards the erector, toward the tip of the transverse process, and you have to push almost 20 ml of drug. So it's a planar block. It will spread in the plane, and as it is spreading in the plane, it will block uh, uh, nerves at different levels. So you can easily block 3 or 4 levels through erector spine. Now, it is given through ultrasound, or we can use fluoroscopy. So that's quite easy. And look here, they have shown the spread. So this is the amount of spread that you will have through a erector spinal block. So it's very easy. Now, it's not that, and we have also found in our practice, it's a little erratic block. Some of my patients do not need opioids or reduced amount of opioid. And then there's another group of patients who hardly have benefit to the erector spinal block. So this is also the current literature. We are not very sure why there is so much disparity between the results, but it's an easy block, and a lot of people are using it. The complication rates are extremely low, so you can go ahead with it. The next is epidural block. Now, epidural block, you can give central, you can give paracentral, or you can give transforaminal. Generally, transforaminal is one of the best, but there are indications of other types as well. Now, we had this spine patient outcome research trial, and look what it says. Patients of disc herniation receiving epidural steroid, 20% required surgery versus 57% requiring surgery in non-epidural steroid group. So almost 30 to 40% of our patients, we can, tide away with just blocks, and they may not require surgery. As far as transforaminal versus interlaminar is concerned, transforaminal has better approach, better results, lower complications, and it has better ventral penetration of the drug. So as we are going transforaminal, we are depositing the drug very near to the disc herniation, very near to the thing. Whereas in epidural steroid, we are giving on the posterior side. So that is why transforaminal steroid has excellent results. You can give selective nerve root block, supraneural, or transforaminal epidural steroid blocking 2 nerve roots. So what are the indications? Disc herniation, radiculopathy, even cervical, thoracic, or lumbar spinal stenosis, sympathetic mediated pain, or even some sort of pelvic pain. Now, as far as epidural and anticoagulation is concerned, you have to stop it. Except these days with ecospirin, you can sort of go ahead even if the patient is on ecospirin, but still we stop it for at least 3 days. Now, this is a meta-analysis of 21 randomized controlled trials, fluoroscopic controlled, 6 months, significantly effective level 1 evidence. This is one of the best evidence you can get. So there is level 1 evidence of using these blocks. You have different techniques. We will not go into that. I have already spoken that transforaminal appears to be one of the best techniques. Now, next is cervical epidural block. So again, this is one block which is not just easy, but extremely effective in upper limb radicular pain. So the indications include cervical PIVD with radicular pain, as well as chronic neck pain. So generally what happens is you need to give it at C6-7 interlaminar space or C7D1. The reason is that you have a lot of epidural space in that area. So I have also gone up to C5, C6, but this C6, C7 appears to be the best. We use the common epidural needle, which is done under C-arm. We use dexamethasone dye and buprenorphine. So
This is the position of the patient. You just need to clean drape. You need AP as well as a lateral shot. So you just need to go in between the spinous process and you will get a feel. So you inject air and it's go. And there is not much of a trick in this. Nothing great. You just put in dye and thereafter you put in your drug. So all this is sort of under CM and it's quite safe. However, you can even aspirate and put a little amount, less amount of drug in cervical, but it has even better results vis-a-vis lumbar radiculopathy. So please do take this up. It is an excellent technique. Here I am showing this is the syringe that we attach. And as it penetrates the ligamentum flavum, that resistance is gone and you can inject your drug. So here, if you appreciate, this is the spinolaminar line here, and the epidural needle is gone here. We are injecting the dye, the flow is seen, and thereafter we are pushing in the drug. So here, we have pushed the drug onto mainly the one side, on which side the needle is angled. So you can inject about 1 to 1.5 ml of preservative-free bupivacaine that is available. Your anesthetist will, this preservative-free bupivacaine is used for spinal as well. So less reaction, and you add 2 to 4 milligram of dexamethasone. Lumbar epidural blocks, similar. I've already told you can go various ways, opposite, ipsilateral, even on this side, and it is a very easy procedure to learn. I'll, in the interest of time, I'll skip. Facet mediated blocks, it's very important, and we are missing a lot of patients of facetal pain, especially chronic back pain, wherein you need to start using facetal blocks. And now RF is available, so you can even do medial branch block for facet joints. So one last slide. Yeah. Now, as far as ganglion impar block, I just want to emphasize that this is another very easy block. You can give it with your green colored needle with the syringe. You go between the sacrum and the coccyx. You have or the gap between the sacrum S3, S4, and you just push in the drug. There's a comma shaped shape you will get on injecting the dye, and you push in the drug. Lot of your patients with coccydynia would be relieved. It's like not just diagnostic, but therapeutic. If the patient has recurrence, then go in for RF. Thank you so much.
Thank you, Dr. Ashish. As we are running short of time, we'll allow just one question. The speaker, Dr. Vinu Gopal, spoke on the anterior fixation of ALD. Any questions for sir?
So sometimes you see that C1 is entirely anterior to C2. That C1, C2 joint is entirely vertical. So that how do you deal in such cases with anterior approach?
Can't do this for all procedure or anomalous CV junction anomaly. We need a preoperative X-ray, and will be technically easy. Require some time also. The angle of it should be angle of mandible should be at or above the level of seat. Then only it will be approachable. Otherwise, you will struggle. Once you do more and more cases, it will be easy, I think. And I am not telling that it can be used for all cases. It's an approach that can be used.
Thank you.
Any question for Dr. Moda sir, who spoke on microdiscectomy? Any question for Dr. Gurnani, who spoke on the posterior approach of the cervical disc? There are no questions. And lastly, Dr. Ashish Tandon, who spoke on
there is a needle in needle technique. So what you do is you pass two needles. It's called needle in needle technique. So once the needle goes, and you need a protective sheath for that. So once you've gone in through one needle, you take the other needle in and then the RF probe. So that is why it is not going to get blocked. Okay, so transforaminal root blocks for cervical is not used mainly because of high risk of vertebral artery injury, and cervical epidural blocks give excellent results for radicular pain.
Thank you so much.
Thank you to all the speakers and chairperson. I would request chairpersons to felicitate Dr. Prakash Mora. Request all the faculty and delegates to come for lunch. We will be back for the next session at 2:45. Thank you.
Welcome everyone for the post-lunch session. This is a very interactive session of case discussion. So I would first invite the chairpersons for the next session. Professor Dr. Y.R. Yadav, Dr. Anil Sharma, Dr. Umesh Srikanta, and Dr. Rajnish Kachara. Now I will begin with Dr. Rakesh Lohana. He will be presenting the case and then we will have a discussion over it. Thank you.
Good afternoon, everyone. Now we'll begin our lunch session. 52-year-old gentleman presented with acute back pain for 1 month, radicular right leg pain, right SLR positive, crossed SLR positive, neuro was intact. MRI shows right and right reaction. Some few considered as well, so we
There is no deficit. So we prefer to give for at least 4 to 6 week conservative management. And majority of patients, they respond very well, almost 80 to 85%. They respond very well to conservative. No, usually we do not give.
I have a very low threshold to recommend a root block, especially in these cases, obviously, because we get a lot of these young patients who are either, this is too young, 20 years is too young. So usually we get it in the working group, young IT crowd, they try to do all these exercises, weightlifting, and they come with some small disc prolapses, but they have pain. So root block helps a lot in those cases. So definitely, yes, this will go for conservative management, but I would also recommend a root block if the patient is willing and wants pain relief faster.
1 month is better. Yes. Yeah, severe pain not getting better. Best physio, better balance. Yes, sir. Yes. 1 month, yeah. What would be your, how would you offer?
Yeah, we can wait another maybe 1 or 2 weeks more and then see. If it's not getting relief, then.
The pain was not getting relief. Came later on with me. Primary surgeon did a microdiscectomy, which was fine for another month, 1 month, and acute right leg pain after a month again. Yeah, those would be your thought process now. Post microdiscectomy, 1 month later, he was fine for a month and came back again. Same thing.
It can could be sometime with fibrosis,
Right.
residual
Yeah, exactly. So you have to think of residual slash recurrent and a fibrosis as well. So the repeat MRI was done, which suggested recurrent disc herniation. So what is your protocol, Yadav sir, for recurrent disc herniation? How do you manage recurrent?
I will go in again. Endoscopy. Yeah.
Yeah, if there is recurrent disc and person is not getting relief on conservative management, then plan for resurgery.
Recurrent disc fusion, many people are recommending. What is your thought process?
It depends on whether it's my recurrence or somebody else's recurrence. No, definitely not fusion. At least for the first recurrence in the absence of instability, facets are looking good. So definitely I wouldn't recommend a fusion for the first recurrence. But in case if there is a second recurrence, I'm not sure, probably this patient has a sacralized L5 transitional vertebra. So yeah, probably, and there we already see a small amount of retrolisthesis at L4-5. And these are cases where chances of recurrence are higher. In the presence of small retrolisthesis at L4-5. But even in such cases, we do recommend conservative treatment. Means either conservative treatment or if surgery is required, just a discectomy, decompression, especially in a young 22-year-old male.
What are your indications for fusion if it's primary disc herniation? Anytime you do fusion for primary disc herniation?
Almost no. I know the indications because many people say central large disc prolapses are probably considered best with fusion, but now with so many technology, with endoscopes and all those things, even large central non-calcified, of course, non-calcified central disc prolapses can be tackled with just a discectomy alone.
So, as Dr. Umesh pointed out very well, redo disc herniation in absence of instability or back dominant symptoms should consider discectomy. So the same was done by this patient went to another surgeon, he will redo L4-5 discectomy. Most of the symptoms relieved. 1 month later, patient came with an acute severe low back pain. There was no leg pain. What are your thought process? What is going on? What would you think?
It is again recurrent and recurrent. I have seen a couple of patients. I also had a 1 or 2 patients. But I don't know. We investigated recurrent disc. Whether first time it is not removed or second time not removed, recurrent disc. We have to investigate thoroughly. If it is a significant compression, I think we have to redo, and I think probably fusion. We have to.
This time, there was no leg pain. It's predominantly acute back pain.
Oh, back pain out of first thing, back pain out of proportion to radicular pain, you should suspect unstable spine.
One is
In
unstable
presence
spine.
of, in the beginning itself, I say if there is a back pain which is out of proportion to radicular pain, then also you should, I mean, you can go for this thing, flexion extension. But if the back pain is out of proportion, then I tell my patient that you can have problem. I mean, unstable. The chances of micromotion may be there. So this time possibly it is unstable.
So one instability is one thing. What else?
Discitis also is one possibility.
Discitis, yeah.
Infection is also one possibility.
Yes. So discitis and instability we would think about. So how would you investigate?
Obviously, MRI. First, but yeah.
MRI
With contrast.
MRI with contrast is important here.
Yeah. So, okay. So MRI is probably showing some end plate changes along with a small, residual bar recurrent disc fragment in the lateral recess on the right side. So there is end plate edema more in L4, lower part of L4 vertebral body, more anteriorly. There is also some small erosion at the anterior tip of the vertebral body. So probably, I would strongly consider the possibility of a postoperative discitis.
Postoperative discitis. How is your approach, sir, in your practice? Patient presenting with a discitis, how would you proceed?
Try conservative.
Any role of antibiotics you think?
Antibiotic, usually I don't think it will reach there in the discussions. In any role, anybody has, I don't think antibiotics role. Whether he had any fever or any.
No fevers, no fever, no leg pain, acute severe back pain, unable to any getting worse in mobility, like getting up from sitting, changing posture, very painful, very restricted range of movement.
We'll try conservative.
Yeah, those are what would you think?
Long-term antibiotic, IV antibiotic, rather than 2 to 3 weeks, and sometimes I have seen even if you give antibiotic for some time, antibiotic plus rest. So some of these patients, I think I have 4 or 5 patients who responded with APP. But I think in the present era, you should go for rest. If it doesn't respond, then you can go for transform and take the issue for.
So would you begin with empirical antibiotics or you would look for tissue culture?
I mean, usually in a routine practice, we used to give antibiotic, but now I think it is better that you go transdermal and
Yes, sir.
Actually, needle aspiration, biopsy, and culture. And according to that, initially you start antibiotic empirically, but simultaneously you take the needle aspiration and culture sensitivity, and then switch over to the whatever organism comes according to.
Senior opinion varied. No antibiotics, empirical antibiotics, needle biopsy.
This CT guided, that aspiration can be done.
CT-guided hospital.
And that can be sent for culture. And meanwhile, empirically, linezolid and clindamycin. IV. Yep.
No, I think we need to approach this from a more basic point of view. I think we need to get a baseline CRP, SR. We need to get a blood culture, if there is any in culture, whether there is, yeah.
When you are suspecting infection, CBC, SR, CRP is very important. That's very important. SR 45, now 9,000.
This is not going to help us in the treatment. This is will help us in the to monitor the response to treatment henceforth. But definitely, today, at least in today's practice, there is very little role for empirical antibiotics. And
It's
some
very
sort of
important that
tissue.
any discitis, whether it's post-operative or, I think getting the tissue culture is most important. We have seen time and again, empirical antibiotics considered, you might have considered biogenic turnout tuberculosis, considered typical tuberculosis consumptive fungal or resistant TB. So it's important that you always have a tissue culture before starting it. If your choice of antibiotic, till your result.
Till my results come, obviously, we will start with the broad spectrum antibiotics. So this is an infection that has appeared 1 month later. It is not a very florid infection. So probably this is unlikely to be a surgically induced infection. Probably it is a hematogenous infection to this one. More often in these cases, we consider gram negative rather than gram positive, because immediate post-op within 1 or 2 weeks, it's more likely to be positive. Anything that is delayed is probably, it's just a rough guideline, probably is gram negative. So I would go with the broad spectrum antibiotics. No, I preferably, this is not a very severe infection. CRP is just 29. I think 24 to 48 hours delay in starting antibiotic is not going. Patient is not in a sepsis. Patient is not in a very bad sick condition. No systemic features. So rather than starting a broad spectrum, highly costly antibiotic and changing it after just 48 hours, probably just worsen the antibiotic resistance also for the organism. So if the patient is not very sick, I would probably wait with some mild like ciprofloxacin or some oral antibiotic only. I would wait for 48 hours till I get a tissue culture.
The patient was being treated by another colleague. They treated with empirical 3 weeks of IV antibiotics. After 3 weeks, patient has remained almost same. ESR, CRP, very marginal difference. So the comparison now, 3 weeks of antibiotics, patient is severe pain, not getting better. So how would you treat this guidance?
I love that.
What is your choice of surgery?
I'll open and I'll clear all the infected contents. I think that is the best thing to relieve his pain. Because he is having very severe pain and probably the infected contents remove, you'll get a good amount for the diagnosis also, culture or whatever, and you can clear everything. And once this both heals and quits, I think that is the end point that he will get good relief.
Would you fix or just do a?
This is going to heal otherwise also. Both infects. Once you clear it, everything, you curate it nicely, I think it will be, may not require fixation.
Yeah, those.
think fusion should be avoided now in presence of infection, although there are reports which say that even but this patient is symptomatic, we should consider it's actually infection.
So you agree with Dr. Kachara, sir? Debridement and no future.
No, I completely agree. I think tissue culture has to be obtained, even at this stage, even though
Yes,
patient
sir,
has
tissue
taken
culture.
3 weeks antibiotics. But I would probably, this is a repeat MRI after 3 weeks of antibiotics, or this is the old MRI? So this is the old MRI. So probably I think if it is not, I would get a repeat MRI to see if there is any localization, see if there is any pus pocket that has developed in the last 3 weeks, because antibiotic therapy has also been given. And if there is a identifiable collection localization, I think probably the best thing would just aspirate it, either with a CT guided or endoscopic. In the absence, if it shows similar features, probably maybe we will have a less threshold to go in, do a debridement and take a good and chunky tissue culture, tissue sample with which we can get a culture. No. In the first stage, we wouldn't fuse even in fluoride. This one, we always tell the patients that the absence of an identifiable organism, I don't want to put implants. Though there are, yes, I understand why you are telling that. There is an evidence telling that, okay, implants are safe in the presence of infection. But if our implants by any chance get infected, these are all, very, they are done in Western countries. They are done in European Western countries. The papers that are there where implants are safe. We have also done fusions where we have also used implants in cases where there is an associated instability to begin with. But if there is no instability, if it is just a discitis, I would probably wait and avoid putting in an implant when we don't even know what organism it is.
That's point well taken. If your end plates are not eroded, there is no instability. Then just debridement is fine. But if end plate is eroded, stability, back down and chip. Yes, then one can.
Yeah, same thing. This repeat MRI is indicated and the debridement and dynamic X-ray also should be done to rule out the instability.
Sorry to interrupt,
Yes.
but will the panel agree that once the patient had come back with back pain the second time, is it prudent to again wait for 3 weeks of antibiotics and not jump in immediately? Because the current literature says that if you have infection, go debride, wash, clear as early as possible. So
No,
what is?
No. The basic thing is we don't know if a sensitive antibiotic has been given. And CRP and ESR have not worsened. If the MRI picture also doesn't show severe worsening, probably, it is worthwhile to try it again because the condition, the underlying situation is no worse than what it was 3 weeks back. But if the repeat MRI shows significant progression, there is a large localization, definitely is. And if there is an end plate erosion or a partial vertebral body destruction, definitely surgery is warranted. But if despite 3 weeks of a non-responsive treatment, if the pathology itself has not progressed, we may not be dealing with any kind of a highly virulent organism. So it probably makes there is an option. I'm not saying it is always the rule, but there is an option where we can take tissue culture, give appropriate antibiotics, sensitive antibiotics, see if it heals without a fusion or without any further intervention. If the repeat MRI, definitely, I completely agree. If the repeat MRI shows any epidural compression, the repeat MRI shows intraspinal abscess or a paraspinal collection, end plate erosion, definitely surgery will be the first option.
So at that time we got into it. We did transforaminal endoscopic disc debridement. It's a pretty good option. Right into this, wash it out thoroughly, get material and thoroughly wash it, 3-4 liters of sunlight. The post-op patient had a complete relief in back pain, function improved, function didn't show any growth. And 3 weeks, NDC program, subvectum and dinner were followed by oral symptoms in dinner. Any comments? Yeah, right. Yeah. Right.
Yes. Can you, I'll just take 30 seconds. Can you go to your MRI, the repeat MRI? This is for this specific thing I had presented in our local neuro club. If you can take your laser pointer to the T2 weighted second image, and this is the T2 weighted second, yeah, on second image, this one. Yeah, if you see the hyper intensity, this is typically a claw shape. I'm not talking about this specific case, but this is a typical claw-shaped image that you are getting, which is very, very specific of Modic type 2 changes. Though in this situation, and when you are getting a primary case with such a representation, obviously those are certain cases where you should even primarily you should advise for a contrast if you have a doubt. So this is a very typical Modic type 2 image that you'll get. It's called the claw sign.
And means on the same line, if this was a primary de novo discitis, means there is no prior history, and this is the picture. It's very, very typical of brucellosis. Anterior, inferior vertebral body involvement with that anterior chip and posterior, that end plate erosion. It's seen more common in brucella also. Oh, seeing more and more villi. Yes, now we are getting significant number of cases.
Yeah, recently 3 patients in last 6 months. I think
So now it's a protocol that if our TB gold comes or TB PCR comes negative when we are suspecting TB, and so the next thing we send is IgG IgM for brucella.
maybe
that people are drinking milk, particularly directly from the shepherds and all, and their animals are not vaccinated. So probably that is one of the source that we thought.
now again culture of getting from pastoral field directly to coming back there.
Rakesh sir, is there any role of any local antibiotic? Some people come up with for local antibiotic made from granules and like that, or after transforaminal discectomy, do you put any drain for continuous wash and etc.?
So-
Does it have any role?
Okay, so there are papers who describe continuous wash post surgery. I haven't done this in this case. Just to drain 24-40 minutes. So one can do full laminectomy as well. It depends on how much the complication is, what is the presentation. You can do interlaminar as well. You have done fusions as well. You have done PVP as well. So see, basically, when you're in practice, patient has a lot of back pain, and if admits are irritated, you do just describe this debridement. Patient won't wake up and walk again for minutes, some long time. And it has been a theory that fix it and use it, infection heals better. And interbody fusion has shown effective and safe risks of infection as well. So we have done TLIF in infected cases. We go to next case. In both, sir, biogenic as well as tuberculosis. In both cases, one Sir, with titanium implant, it has been shown that it does not form a biofilm. It's safer to put in the presence of infection.
Put in a
Published it.
put in a cage in a pyogenic discitis, or you just put autologous graft with
I put a
vancomycin
cage.
gentamicin?
You would have bone, at times it might get resolved. So putting a cage is better. That's what I feel. It can happen. So it may collapse to a certain extent. So you have to make sure that your athletes are not so complete template are not eroded. There are some areas where your templates won't be eroded. Put a cage in that area. So that's how when you are when you are doing curating, don't be too aggressive while curating. And put a cage under CM. So the anterior migration are also reported in the presence of infection. Then go on to the next case. 31-year-old lady, overweight, acute onset left leg pain for 3 months, unable to stand or walk without pain, limping while walking, left SLR positive, PHL grade 3, dynamic X-ray done, no instability was noted. Young lady, to back.
Is leg pain actually?
Left side leg pain with left PHL grade.
I'll give conservative management for 3-4 weeks. No bladder symptom.
Is it EHL or foot? Dorsal. EHL. EHL is a minor neurological deficit. It's not considered as a major and it's not an absolute indication for surgical intervention. EHL weakness alone. A progressive EHL weakness, which is worsening gradually, again, the threshold is lower. In those cases, it probably is considered as a indication for an early surgical intervention. But a static EHL weakness alone is considered a minor neurological deficit and is not an absolute. It is definitely yes, but it is not an absolute indication for surgical intervention. But in these cases, especially when there is a small disc prolapse, the amount of compression doesn't explain the nature of a neurological deficit. I think we need to look for alternative if there is anything, if the patient is diabetic, the patient has any coexisting property.
So apart from obesity, nothing. Exactly that's what we thought. The compression is not that much to warrant a deficit. The patient did not get up from the bed. Right pain procedure, left L5 up with the transient relief. Patient went home, came back after 3 months. Again, severe pain, significant foot weakness. How would you do it now? Given a long transient relief, MRI was not showing that significant compression, but we got neurologist involved, we got number cleanses, we got on workup done. Apart from left and five, not that bad discrimination. How would you manage or how would you explain? Yes. 3 months pain, you would block Sunday relief. And during this period when she would relief, she was completely fine. Classical Illinois radiculopathy again, it was completely fine for severe pain, not responding in life and significantly affected. How would you find? Yes, sir. Where video
to say. I think maybe we are missing something. We have to see. But response to the block, we should suspect also that it could be, although the risk is not that much, but still, if there is nothing else which is causing this, then it is better to take it out.
Dynamic.
Dynamic exercise. Going stability number flexor 60% and one factor. Classical and so we went in, we did L4 5 while discectomy, on table we saw that the root was made inclined and compressed by regular disc ratio and could decompress well. No operating remarkable improvement, would drop completely recovered on day one, independent walking on day one, patient went to. 2 months later, again, excruciating pain, unable to stand or walk without support. There's a pain.
And this foot drop burst. It again we need to do MRI endoscopy.
Yeah, so that was MRI done. Plain MRI showing my mastectomy window within the disturbanation. Facet efficiency. Yeah, that is it. What a dynamic X-ray again, ruled out stability. That is into the good. There is no back pain. So basically, severe. There was a lot of on contrast. There was a lot of sedation there. So we did L5 root block, as we suggested, but it failed. No improvement in block. Polymer.
No, you mentioned you found some granular tissue. Did you send for biopsy then?
It always starts as innocuous case in you, huh? And then just a small, simple disc which half of us will consider.
So then we did a redo surgery. MIS left, redo left foramen also. Interestingly, this time the annulus was hit and there was a lot of scar tissue around the root. The root was significantly like there had been fibrosis. Did a complete foraminotomy. The disc was preserved, so we left the disc behind. I thought it may be a redo disc, but it was plastered L5 root. Extensive irrigation, we need replaced perineural steroid. Post surgery again, complete relief of pain, foot drop relieved, went home next day, and she was very obese. So we suggested that you manage obesity. Very obedient patient, underwent obesity surgery, lost 25 kg of weight, did well for 6 months. Again, same symptoms. Bachara, sir. We got MRI, sir. The plain MRI showed well decompressed, nothing much. So again, we gave a block relief for 3 months. It was fine. She has bakery and she's a very good baker. So every time she brings some cake and some new stuff, but again 3 months later, she came with a severe left leg pain. At this time, you MRI. Yellow, sir. How it now? Any experience of this kind of cases? I discussed these cases with around senior guys, but somehow.
Refer to you.
No, sir. So, search literature as well. Somehow, perineal fibrosis literature is very, very scanty. We could not find much information. Any experience with this kind of thing?
So I think patient has a tendency, does she have any bad scars?
She has one scar.
Yeah, so keloid probably, that is why fibrogenic.
So that's what we expect. So, but how would you manage now? Like, again, you can see that plain MRI looks pretty good. In fact, that this was also resolved. Now it's but contrast completely plastered. How would you manage? Happy children? If it is good option, actually walk in the front, then can't walk. You know, we present for this kind of right here. We operated twice, we blocked 3 times. The third time, we started right here. So we went in. We went in again, did a redo foraminotomy. This time also there was significant scar tissue around the root, and we used this silicone patch around the root. White water. This was preserved scarred root around, especially on the lateral aspect and the ventral aspect. So I placed the Need a complete foramen to place the silicone patch covering the groove in the lateral and ventral aspect. Very uncommon, sir. Absolutely, sir. I have not seen this. So post-operatively remarkable recovery, leg pain 0 out of 10, foot drop completely recovered, very happy. And then 3 months follow-up. Fortunately, this time no asymptomatic, but we thought we'll get MRI to see how the silicone patch is working. There is still some scar tissue, but patient is asymptomatic and happy to the cross and may this silicone patch work. Thank you.
In our
Any role?
residency days, our teacher used to tell us that you go for those flexing and leg raising test to prevent fibrosis. From that fat and other. They used to advise one or two teachers that post-operatively they advise patient to some sort of
Nerve stretch
SLR.
exercises.
Yeah,
Nerve stretch exercises. Any role for high is yeah, I don't know. There's literature mentioned there are some papers we mentioned putting fat around it. There are some papers that mention the putting a drain where the blood can cause scar tissue to always put a drain. Place the drain, and there are some reports of putting for fat. My practice infection is very rare. Yeah, no, but sir, yeah, maybe one in maybe 3 years. I do around maybe 600 cases a year, but maybe one in 2 to 3 years. Very rare. I have noticed if you're practicing multi-specialty hospital, your infection rates are higher, where patient is in ICU or multi-specialty hospital. Our is like we have just 2 specialties and my case of nobody else operating elective spine surgery, no emergency, no trauma. Everything ETO. So in my practice, the good infection rate is there.
Thank you very much. It's difficult to present after Dr. Rakesh's interesting cases. So I'll be presenting few simple cases only. So case one is a 19-year-old boy who is right-handed and he complained of.
Can we have the screen?
Visual.
So he's a 19-year-old boy, right-handed, complained of atrophy of both hands. On examination, he had pulse loss and decreased tone in both hands. Power in shoulders and elbow were fine. In wrist, bilaterally, it was 2/5. Grip was reduced to 50% in both hands. Power in both lower limbs was 4/5. So the initial MRI was fine. It didn't show any disc bulges or thing. Then we got a dynamic MRI. So I'll begin with Dr. Anil Sharma.
No, but that weakness was asymmetric or there was symmetrical involvement?
Bilateral symmetric.
Bilateral symmetrical involvement. there is contrast dynamic MRI.
This is T2 MRI.
No, what symptoms you are suggesting, Hirayama is one possibility, but there is usually asymmetric involvement. Like it start usually on one side and then other side is involved. But symptoms the atrophy of both hands. So other possibility,
Maybe it started asymmetrically, but when he presented to us, bilateral equal 2/5.
I'm not neutral image. I'm not seeing any compression. But here, without contrast imaging, we cannot comment on epidural enhancement.
Flexion MRI, we can see compression over the cord. And in extension, the CSF spaces are becoming normal again.
Posterior dural distribution. Yeah, so the posterior dura is completely coming off spinous process in the lamina. And there is a lot of epidural tissue. So
So the here now.
but yeah,
You need, you need Hirayama is a radiological diagnosis. You need to have proper radiological proof for that. So you need to do dynamic MRI with contrast. If that is visible posterior epidural enhancement that is visible, then corroborative with clinical findings, then only we can diagnose the Hirayama disease. Then only we can label it.
Dr. Ramesh, what's your?
no, I would, my first possibility would still be Urayamas in this case, even though there are slightly atypical findings and with provided with a classical finding of a posterior dural separation from the spinous process and as at the posterior dura acting as a constricting ring on flexion at the cord, especially at C5-6 area.
How will you manage?
Well, we know Hirayamas is a self-limiting disease. He's 19-year-old, so probably if the hand weakness, it's did you say it was grade 3?
It was 2/5.
And how what is the rate of progression? When
slowly it was progressing. Slowly progressing. 3 to 4 months.
4 months is still acute for a Hirayama. It is still rapid progression. 3 to 4 months duration. So naturally, a young boy with a reasonably rapid progression, I would offer him surgery. If it is a slow progression, static disease, mild weakness, probably we can just wait and watch these cases. In this case, 3 to 4 months, grade 2/5 and grip becoming 2/5, probably I would recommend some surgical intervention.
What surgery?
ACDF, single level, ACDF, C5-6.
How long is it symptomatic?
Around 4 months.
4 months. So it's very unusual.
Very unusual because
4
so much of
months we-
weakness you told wasting is there.
Symmetrical involvement. That is also very symmetric involvement is, I think is almost it never happened in Hirayama. Symmetrical involvement.
No, obviously we need to do the workup that
Yes.
Ranil also mentioned. So we need to be absolutely sure about the diagnosis. We need to do a nerve conduction study. We need to get a proper neurology workup. Even though we are finding a radiological evidence, we need to rule out other factors because of atypical finding.
Rajneesh, sir. Decompression only. ACT, C5. Sir, the other sir. Yeah.
So there was a lot of debate in earlier times about Hirayama. People have tried just a posterior dural opening, duroplasty. But ultimately, the pathology of Hirayama is related to the movement, and unless you limit the movement, unless we do a fixation, either anterior or posterior,
Just C5-6 fixation, how much limit?
the maximum range of cervical spine at C5-6, and that restriction in the movement is sufficient to relieve or prevent any progression because Hirayama is ultimately a self-limiting disease. So that amount of, because after surgery around for 1.5 to 2 months, there will be restriction of neck movements after a fusion. The adjacent segments will take time to compensate or to recover that kind of movement that originally the neck had. I think, but single level ACDF has proven to be equally efficacious than a multi-level fixation as well.
Any opinion from the audience about halo fixation or simply on Philadelphia? Just conservative management.
About it, but in our institute, Apollo, our one teacher used to do on the anterior plating. Uh, experience the results on the anterior cervical plating.
Plating me without discectomy. No, but
And was there a intention to remove the plates later? Unless there is an intention to remove the plates, because this is a self-limiting disease. You just prevent the means we have never done that. I have not heard about it, but if the intention was to just limit a movement temporarily, like you're discussing about Philadelphia collar, halo fraction, all those things. Unless you are planning to remove the implants later on, there is no point. It's better to go for a solid body fusion than just plating.
Yes, generally surgery or non-surgery, they haven't been proven to be excellent. Though the final word is that if nothing is working, then you go ahead with surgery in Hidayah. But I think the crux in this case lies in formulating the diagnosis. Yes. Like the panel said, more neurological assessment, EMGs, NCBs, if required further study.
So we actually did the NCV EMGs. We took the opinion of neurologist and they confirmed it was Hirayama. So we did, so there are in the literature, we have a lot of options from conservative to just laminectomies to just anterior decompression fixation, only posterior fixation. And so what we did was posterior decompression as well as a lateral mass fixation. And there was good improvement in power. In 1 month of follow-up only, his power was improved from 2 to 4/5, and also in lower limbs, and grip also improved to 75%.
Sorry, sir. What was your needs for decompression?
So it was just to
Did you
prevent the
open
impingement
the
of-
dura or it was just a bony?
No, only bony decompression.
So
and-
as we know, there is no bony stenosis.
Yes.
So the compressive element is the posterior dura. So in Hirayamas, the concept of decompression, is what I understood, is it's a duroplasty. If you really want to decompress, we need to do a lax duroplasty posterior. So without doing a duroplasty, removing a bony element is probably
it's not going to help it.
If you see the literature, even the laminectomy is also mentioned as a. Yeah, so we just combine both things.
Okay.
And one more thing, like if we are putting patient on head cervical collar or Philadelphia, and the patient is showing some degree of improvement on collar, so that's they are most likely to benefit from surgery also.
Next patient is a 55-year-old male, and he complained of post-traumatic neck pain, quadriparesis, and on examination, he had graded weakness in all 4 limbs, ranging from 3 to 4/5. So this is the sagittal MRI, and shows the T2 pars fracture. T2 and 3 are fused. Odontoid is fractured. Little bit of posterior impingement over the pod, and T1, T2 dislocation unilateral. Angio was done. It was the vertebral arteries were both normal closed. And in axial also, you can see the right-sided pars is fractured. The right side in the last picture, you can see the C2 right-sided pars is also fractured.
I would like to see MRI.
He didn't underwent MRI. Rajni sir. Immediately after trauma. Yes. Not done. I think he had some issue with the financial thing. So with this, we thought it is okay, but to get extra money. All right. We actually planned our management according to this. Yes, he had got it. He's got it. 3 to 4 by 5 in all four. Yes. Yes. What surgery? C2, what about sir pars? Right side pars is already fractured.
The C23
C23 is already fused.
C23 is already, there is a clipper theory. So because of the rotational abnormality of C2, there should be a fracture of C3 pedicle as well. Otherwise, the C2, it is a unilateral C2 pars fracture with a rotational instability, rotational of the C2 body, as we can see on the X here. So this rotation can happen only if the C3 pedicle also gets fractured. If the C3 pedicle is intact and C23 clipper field is there, an isolated unilateral C2 pars fracture should not have caused this rotation of C2 body.
Is the rotational anomaly significant?
Yeah, means you can see that the last axial section there, C2, compared to the C1 lateral mass, C1 horizontal axis, the C2 axis seems to be typically changed, isn't it?
Or axial images are available for bone window. See, axial image for CT. Bone window.
The last,
can you run that sagittal sequence again?
it is the only picture.
No, so this one, can you run that
Yes,
sagittal sequence again?
Tell me when to pause.
Yeah, yeah. Go back, please. Yeah, even C3 is.
Okay. So what will you do? What's the plan?
No, see, this will require C1 to C3. As sir already told, this will require. So I just wanted to make a point that.
Where will you put the screw in C3?
No, C3 usually if the pedicle was not fractured, that's why I wanted to. If the pedicle was not fractured, we usually put a pedicle screw. But because pedicle is fractured, we can go with the lateral mass. And on the other side, it is better to put C1 to C3, C1 lateral mass, C2 pedicle.
Posterior, one side C1, C2, and other side C1 to C3.
Okay, what about C2 laminar on this side? I mean, where the C2 little mass is fractured.
But if you are extending to C3, it is very difficult to connect a C1 lateral mass to a C2 translaminar and bring it back to C3 lateral mass. So because here there is a unilateral.
If you see the C3 is fused anteriorly as well as.
Correct. There is a fracture. That is the point I wanted to make. There is already a C3 unilateral fracture with a rotation of C23. Of the entire C23 complex has rotated. So unless we fix bilateral anchors onto C3, the rotation is not going to get corrected.
So what about odontoid? Or odontoid screw in fact?
If we are anyways doing a posterior C1 to C3 odontoid, additional anterior odontoid screw, it may not be.
Any take from audience about, pardon, sir? Yes, either odontoid screw only. Only. Any take from audience?
No, only odontoid will not have because there are other fractures also. no?
Yes.
So either we put C1 lateral mass and this thing, I'm not sure about, I need to see proper axial images for C3 fracture. But as like there is a rotational element, so that also need to be included. If we are planning to put in C3, then C3 and C4, we need to put lateral mass.
Also, I mean, if you're thinking just of odontoid screw, until unless you've got a traction and the odontoid piece has come aligned, with this scan, putting in a C2 screw may not be that easy.
Yes.
With the C2-3 fuse down, the angle that you require to put in a C2 screw, odontoid screw, on these images, it will be extremely difficult.
Yes. 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 What we did was nearly same what the panel is saying. We did C1, C2 on one side, but we did C1 and C2 laminar on the other side. So we could achieve a good correction both in terms of the sagittal and coronal thing. It's in follow. Yes. Yes, we had good graft at time. Here. The patient is doing good at present. He's in under follow. Next patient is a 31-year-old male, and he complained of backache since 5 months, on and off fever since 1 month, gradually progressive paraparesis since 1 month. No history of trauma. On examination, 3/5 power on the right lower lip, 4/5 on left side. Flexors were more weak than extensors, and he had also ankle clonus bilateral. So again, we had only MRI in this case also because of financial constraint. So we can perceive dorsal spine fracture, collapse, and there's some tissue which is impinging inside the canal, which may be the cause of paraparesis. And I'll run the axial TT. So here you can see this tissue is coming inside this spinal canal. And here again, lot of tissue is coming inside the spinal canal. His ESR, CRP were raised, just of course spine.
So CRP is elevated. It's how many of, I mean, again, general question to the audience. How many of you would consider still port spine? CRP elevated. Dr. Rakesh.
Important. It does get elevated in tuberculosis as well, not as high as biologic. Like it's in hundreds or so, one might have to consider biologic. If it's in the range of 20, 30, 40, then maybe tuberculosis. But
Consider
today
5 months history also, I mean, an acute pyogenic.
yeah, so tuberculosis is more on card.
Just
But for a generating discussion. So without MRI on CT, how many people would proceed with intervention? That is an interesting point to see. Really, the courage to proceed this kind of case without MRI. I mean, whole spine screen is important, MRI is important.
It was not done. It was not done. I mean, was sometimes patients do come, sir. They don't have so much of finances, so we had to take decision. And like, suppose I give a hypothesis. MRI would show a localized pathology only. granulation tissue compressing the cord from anterior side, and destruction as shown in the vertebral bodies on the MRI one. And the barring the adjacent segment vertebral bodies, the rest of the vertebral bodies and upper and lower screening is also normal. Suppose I give you the scenario. Now what?
MRI one shows at the baseline evidence, like you don't see on CT how much cord is damaged or how much myelomalacia is there.
Yeah.
So many times patient come like 6 months later with lot of spasticity. They may allege you that, no, I was walking, that, how come I am not in this state? So free of MRI. I think in today's era, however financial constraint is there, you have to have by baseline MRI. So the cost of surgery versus implant would be much higher than the MRI. Just get screening MRI, which may take maybe 2,000, 2,500 in financial constraint. I would get detailed MRI in all my patients, but in case financial constraint, I think we should be, unless you are in government sector, anyone in private sector, whichever city is in, I think one has to take out that financial constraint.
Yes.
Because whenever something backfires, it is you.
Yes.
You. Good.
Optimize the treatment. As you can see. In this case, I think it's very important to investigate.
No, sir, I don't think so. What he is trying to say that he does not want an MRI. Now we have a case scenario. What he's trying to say is that, yes, we do not have an MRI now. And this is all we have because of X, Y, Z, whatever. He also agrees that all patients do require. I
Yes,
think perhaps
yes,
that is
absolutely.
what you want.
Yes, sir.
Now,
No, I gave the scenario of the MRI also. Suppose we get an MRI and I mentioned the finding. Suppose we get that a granulation tissue compressing localized only in the cord from ventral side. And it shows a little bit of contrast enhancement like we see in POTS. So then what to do? What fix it? Okay. And what surgery? I mean, fixation only 360-degree or pedicle screws? Only pedicle screws. We should clear out. Okay. And do you have, sir, in long term any results for kyphosis? Development of kyphosis in this patient. Suppose there is already vertebral body destruction anteriorly. What happens in the long term? Okay. And what about the levels of the pedicle screws? How many levels up and down? Two above and two. Dr. Umesh?
No, I would definitely do an anterior reconstruction in this case. There is a lot of scalloping, there is a lot of destruction anteriorly, a lot of granulation tissue is there, and the pathology or the intraspinal component is also coming from anterior. So probably this will require, may I know what is the level? What
Around
level?
E10. E10.
So probably we'll do a proper costocystectomy kind of an approach. And then probably bilateral, because we don't have an MRI to see one predominant or other, but in the absence of that, it is better to be more aggressive and do a bilateral decompression, bilateral approach, and then do thorough anterior debridement, identify a normal bone above and normal bone below, put a cage anteriorly. In the presence of anterior fixation, if the anterior hold is good, 2 levels above, 2 levels below is good enough. In the absence of an anterior fixation, I would prefer to go 3 levels up. Anterior reconstruction, I would prefer to go 3 up, 3 down.
Dr. Ned?
Yes, same. I think minimum 2 levels are involved. What I can appreciate from these given images. So we can, in view of, there is definite weakness, I think 3/5.
Yeah.
So in view of that, surgery decompressor is required. We can do expendable case, we can put at 2 level normal above and 2 level below. That fixation is required.
Sir, Yadav sir.
I think anterior should be better. Then also you go for posterior fixation, anti-decompression and graft, and then use it from there also. Plus you have to, because that anterior alone is not so strong. So you have to do it from posterior also.
So we did as suggested by the panel. So it was a bilateral costotransectomy. We put a cage and we put, because the screws were, we were not very sure. We put 3 above and 3 below. And we also put the bone graft over the left side, these pieces for enhancing fusion. Rib graft. So the bar improved and he's presently walking with support at follow-up 1. So lastly, we had few slides from the EasyNav navigation company. They are sponsors and they want to show some slides. So as suggested by them, their navigation system can be used from top to bottom. I mean, from CV junction to the sacroiliac spine. And here they have used their navigation in putting C1, C2 screws. Like in this case, very nicely put in axial and coronal images. Again in sagittal images. Then they have also put the pedicle screws, cervical pedicle screws in C6 and C7. And the system can be incorporated along with O-arm, 3D C-arm, as well as normal 2D C-arm also. Again, the accuracy they are telling is around 2 millimeter, depending upon the registration system. And they are used for lateral mass as well as pedicle screw. Then they have used it for iliac screws, like we can see. So it can be a good adjunct to our armamentarium. Very nicely put screws. And then they have also shown their system for scoliosis. This is type 6C, having both lumbar as well as thoracic. And was corrected, the screws were put. And there was, I mean, most of the pedicles which could hold these screws, the screws were put. And there was good sagittal as well as coronal reconstruction. Thank you.
Thank you. Thank you very much.
Thank you very much.
Thank you for the panel. Thank you for audience.
Thank you. Very good case also.
Thank you.
Sir, I will request Dr. Yadav to please be seated, sir, for the next session. Thank you for the wonderful session. For the next session, to chair the next session, I will invite Dr. Prakash Moda, sir, and Dr. Dinesh Patel, sir, to chair the next session. Over to you, sir.
Okay, so good afternoon, respected chairpersons and dear friends. I'm going to speak about something different than the endoscope, that is exoscope in spine surgery. Since we are using the exoscope of Karl Stoss, so we have taken the photographs. We all know the visualization, illumination, magnification is the key for any surgery, and microscope is the device which provide perfect high precision, 3D perception, adjustable focal length, high magnification, and good elevation. But does microscope has got limitation? Yes, it has got a large size. It's need large space in the OT, and it has got high cost also. It has got limited mobility. It provide inline axial vision, and obviously inability to look around the corner is one of the most important limitations. When you do a long surgery, you all face a lot of fatigue, and it decreases the concentration and sometimes leads to suboptimal surgical outcome. Probably these are the some bases of these development of the hybrid tool. Everybody wants to sit comfortably, looking around the monitor, and wants to operate like this. One of the pictures showing the operating, because the target distance from your eyepiece is very high. You need to bend your neck as well as upper body. And while sitting on comfortably looking at the monitor, definitely you feel better and do the long surgery. Recently, it has been talking about the ergonomics during the neurosurgery. A lot of papers has come, and it has been found that around 60% of the neurosurgeon or spine surgeons, they are suffering some form of the back pain or the neck pain. Out of these, 31% has been diagnosed the lumbar disc herniation, and 23% underwent surgery for lumbar disc herniation. So from this, the hybrid concept of exoscopy or endoscopic neurosurgery is evolved, which provide optimum and ergonomically environment for the doing surgery. Simultaneously, there is a development of technology. We have a telescope system, high definition camera to improve the visualization and illumination of the surgical field. We have a good HD 4K monitor, and it has been widely accepted now in cranial and spinal surgery. And the literature has supported that they have got the same clinical outcome with the, if you operate with the operating microscope, as well as they have been found to be reduced blood loss, shorter hospital stay. It's a good tool for minimal invasive or keyhole neurosurgery. So endoscope has also got the limitations. It has got a short focal length, lack of 3D visualization till we develop the 3D endoscope. And there has been a difficulty in instrument handling, and there has been a steep learning curve. So something in between the microscope and endoscope is to be required, and there comes the exoscope. The VTOM is the name for the Karl Stoss exoscope. It is known as Video Integrated Telescoping Operating Monitor. It is one of the advancement of the rigid lens telescope system, which provide a high quality digital image, which is equivalent to the operating microscope. It has got a novel technology regards to optics, ergonomics, and maneuverability. It based on the surgeries, based on the familiar principle of microneurosurgery, because you can use the same instrument under the VTOM. One of the advantages, it has got a focal length of 250. Microscope, if you can take up to 250 mm near to this your target, probably you will got a good visualization, but you have a very less space to accommodate your instrument. So it has got a wide range of focal length, 250 to 650 mm. And even the advanced exoscope is coming with 40x. This is the first generation VTOM. This provides unobstructed operating range, and it has very lightweighted and easy to set up and operate. Portability is very good. You can take it into the small box and do in other peripheral hospitals also. And there are various holders are available. First description was found actually in 2007 about this VTOM in veterinary. Other in 2010, it is the Mamelec who has been described this exoscope. So this is basically comes between the microscope and the endoscope. You have some property of microscope and some properties of the endoscope. So hybrid telescopy can be done with the exoscope. You can understand simply with this video. This is the microscope in a keyhole surgery where you can see an endoscope. There has been a good target area. You can see more than that. You can turn the microscope, take out some more area of the targeted area. But there has been increased light to target distance, which causes decreased light field in the targeted area. And you have to bend your neck also and take pain for that. While in endoscope, you have more area, look around the corner, but you have a limited space because endoscope itself take a space and you have to be adjusted with that. So here comes the exoscope, which has got a good maneuverability. Even you can take out near to the keyhole because it does not have a large head. So you can have a more better area has to be covered with better ergonomics. So we have started using exoscope almost around 10 years back when the first generation has come. And so far, so we have applied exoscope almost all sorts of cranial indications, including supratentorial, infratentorial, and skull base. And we have published our first paper in 2016 with initial cases of 39 cases, 25 I think is cranial, and 14 is the spinal. And that was the first study of an exoscope published from the India. Lumbar also we have applied in from lumbar disc to the craniovertebral junction. So this is the setup of an exoscope of craniovertebral junction. We are using 2D VTOM with a simple mechanical holder. Same camera light source has been used, which can be used in endoscope or any laparoscope. Same holder which has been used. This is a short shaft of around 10 centimeter length with a 10 millimeter diameter for dual light source. You can angulate easily with this mechanical arm. You are very comfortable looking at the monitor and operating with a conventional microscope. As far as vision is concerned, you can see it is very comparable. Even sometimes you feel superior to the operating microscope. This is a 2D VTOM, first generation 2D VTOM. This is recurrent meningioma. All conventional micro instrument and panoramic magnified view. If you focus here in microscope, probably all this get blurred. But here, you are seeing here, doing here, and you also observing simultaneously. So I have been already on yesterday, theory decompression, so I will skip in skip of time. There has been a limitation with the 2D exoscope because of the lack of 3D visualization. And in case of significant intraoperative bleeding, probably this is one of the limitation. And initially it has been said that with the 2D endoscope, you are operating the less technical grade procedure, but now papers has come that all sorts of surgery can be done with the. So they come with the 3D exoscope. They have been also here displaying. You can see there. And the advantage of 3D exoscope is to better depth perceptions. So there has been a limitations also with the exoscopic surgery, whether it has been affect the surgery or not. Inferior depth perception in compared to the conventional microscope. There has been a learning curve, high cost is involved, and some ethical issues are there. We have also have got 3D exoscope, not in the department, but in a workshop. We are both in 3D exoscope as well as in cadaveric dissection. So we have a limited experience. Other exoscopes are coming, even the microscope giant Zeiss is also coming with the exoscope. So probably it has got potential to replace the microscope in the futures. Literature has been supported a lot. Initially, there was very less paper. Now there is a lot of paper has come. These are one of the papers which have been mentioned in our series because our series is one of the initial series of the exoscope. Here the comparison of the exoscope with the operating microscope and endoscope. Here this is a recent which has been showed that exoscope seems to be safe alternative to the microscope. This is another meta-analysis which shows reference has been given to our series also. This is one of the latest paper from AIMS Patna where they have been using the 2D VTOM and they found that spine surgeons can embrace the benefit of exoscope and increase their range of surgery to be performed with a small operation theater in low and middle income developing countries. Many other literatures has comes out. So the future directions, a large scale RCT has to be required. There has been incorporation of tissue recognition technology with the exoscope and training has to be rigorous training has to be required and probably the AI modality can merge with this. So exoscope is not a replacement of microscope or endoscope. It is one of the useful tools for the beginners to learn the principle of neuroendoscopy. It improves the ergonomics, is potentially minimally invasive tool. Field hospital practice people has found to be very useful. Probably it has got potential to replace the microscope. As I said, it is not my only work. We have a department. So I thank my department to tell you that. Thank you.
Any question from audience?
Hello. Yeah, I don't have a question. However, I have a comment that perhaps all of us are watching the person who has the maximum years of experience with exoscope and VTOM. So if there is any question, any doubt, he is the master of exoscope and he has taken this technology to the next level. Thank you.
So in your practice, do you find a need of microscope or it completely exhausted all the surgeries? When you
I only operate aneurysm and vascular surgery with the microscope. Rest of the surgery like CP, ML, everything I used to operate with the VTOM.
Vijay, what will be the cost of the microscope? Exoscope?
If you compare the 2D VTOM which we are using, it is 10 times less to the high-end microscope.
What about 3D?
3D, they have said that it is comparable to the microscope. Because the 3D VTOM has come, 3D exoscope has comes from various companies, from STOS to Olympus to the Esculap. So the cost is quite varied. Probably in very delicate dissection or in chance of bleeding,
you lost stereopsis and you missed the critical step during aneurysm surgery, and probably you may don't know whether even if you clip, you don't know whether if you can clip with the microscope, you probably make patient more better. So, but the people are using aneurysm surgery, AVM surgery. No, sir. There are papers and there are people that they are offering because we don't have 3D in our department. Good afternoon. Invite Dr. Anil Sharma.
Very good afternoon. A lot has been discussed already about minimally invasive surgery for spinal tumor. So minimally MIS surgery for spinal tumor IDM, just extrapolation of minimally invasive surgical technique was what was originally developed for the microdiscectomy. So as compared to conventional techniques like laminectomy and then excision of the tumor, minimally invasive technique has certain advantages and it's equally efficacious and complete removal of the tumor while maintaining the functionality and structural integrity of the spine. So this is one intradural extramedullary tumor at the level of C4, C5 level. And these are the postoperative images. So this is a surgical technique with a tubular retractor. So this is the view of dura is being opened. I'll just show brief videos. So tumor comes into view after opening the dura. This is schwannoma. So basic microsurgical techniques remains the same as for microscopic, whether it's microscopic or tubular surgery with tubular retractor. Lower pole and upper pole of tumor should be visualized. Tumor can be internally decompressed. If tumor is big enough to deliver from the space, then it should be dissected all around. Has to be dissected from the nerve root and can be delivered in total. And this is the view we get after removal of the tumor. And the duragen is being placed and glue is being placed. So most of the time there is no CSF leak from these kind of tumor as potential dead space is already covered by the already muscles take place. So this is the view we get after docking series of dilators and muscle dissection. Bone is being drilled. Dura. Dura is being opened. With tumor comes into view. This meningioma, its basic principle remains the same. The attachment after attachment is being coagulated and attachment is being cut, and then tumor is being dissected circumferentially, lower pole, upper pole, and from the cord. And traction and manipulation has to be on the tumor, not on the core. That we need to take care. Lower pole of tumor is being delivered. This is the view we get after removal of the tumor. This again one meningioma at the D5 level. You can see how severely it's compressing the cord. This patient presented with weakness of both lower leg. So incision is usually paraspinal, nearly 1.5 centimeter of midline and nearly 2.4 to 2.5 centimeter. A series of dilators are placed and docking is being done. Spinal laminar line. Muscle is being dissected. Now bone is being drilled, ligament of flavor. Bone can be thinned with the drill and then it can be removed with the help of cut. The minimum size of cut need to be used in dorsal spine, preferably 1 mm. Minimize the compression and damage to the cord. Tumor is visualized now. And again, the same principles are followed of microsurgical resection. After coagulation of the attachment, both poles visualized and tumor is being dissected from the cord. Tumor is being dissected and is being removed in piecemeal manner. The last piece of tumor is being dissected from the cord. The tumor has been delivered now. This again the view you get after removal of the tumor. So again one brief video. The tumor is being decompressed with the help of ultrasonic aspirator. And again, tumor has been reconstruction with Duragen and fibrin glue. This is the usually scar. Thing is, these minimally invasive surgery for intradural extramedullary tumor, this very well can be done equally efficacious and safe, and less muscle dissection, less postoperative pain, and early discharge. And CSF leak is very, very less due to that potential space, that is already covered by the muscle. Thank you. Thank you very much.
Thank you.
For tumor, I used 22. For disc, I used 20 or 18.
So, on only one side, because in tubular system, I think just little bit or spinal process you will be breathing in, but majority of approach will be from unilateral side or from one side.
Initially, to begin with, actually, we need to choose cases very properly. Usually, to at least to begin with, tumor which are localized on the one side and not very ventral, preferably tumor which are on one side. That should be approached and preferably extending to only one level. To begin with, at least those tumor only should be approached, at least initially. Later on, once one gain experience 2 or 3 level, that also with mobilization of the tubular retractor, that also can be done. But to begin with, it's advisable like we should start with one level. Thank you. Thank you.
Dr. Anil, how many cases you can develop CSF leak?
Sir, CSF leak means my experience is very less actually, nearly 30-35 cases. So in one patient, there was some CSF leak, but that stopped after taking suture. So means there was no CSF leak.
Presentation. Thank you, Dr. Anil.
Thank you. Thank you.
Next presentation by Dr. Shukumar. He's on online.
Can you hear me?
Sukumar.
Yeah. Good morning, good evening, everyone. So, been hearing the discussions, good discussion going on the previous, the Rakesh Luhana discussions. So now today I'll just go through the scope of endoscopy where we can extend the most difficult discs or pathologies in spine, that's thoracic pathologies, can be addressed through endoscopy, especially transforaminal and interlaminar. We can approach both, but most of the anterior pathology, that is disc pathology, is approached by transforaminal approach, be it a disc, be it a calcified disc, or a foraminal pathology, or any osteophyte or OIL can be addressed endoscopically. So for small pathology, we have been doing this radical approaches, either a posterior approach or a posterolateral approach, or transthoracic approach, either retropleural or intra transthoracic approach, to reach the small pathology which is compressing the spinal cord. So either we remove a lamina and a part of facet, or we go transfacetal, or we might do a cautovertebral resection. So for small pathology, we need to do such extensive procedure. So remove a small disc and ending up in doing fusion. So when we see here the lamina of the thoracic spine and the rib, where the biggest challenge is the rib head which inserts into the thoracic spine. So definitely there is a role of endoscopy, thanks to this master who did a first thoracic transforaminal endoscopy. In fact, he used a biportal technique. He did bilateral on a TV anchor way back in 1995. And we visited him and to learn the pearls of thoracic endoscopic spine. And he even published his cases. The cadaveric work done by Dr. Saeed Usman reveals one thing. The upper image, you can see the upper image is one where the thoracic spine, and lower image is the lumbar spine. So the advantage of thoracic spine is you can see the root which is exiting out goes underneath the upper rib in that intercostal space, as a result of which the foramen, the exiting root is away. So when you go transforaminally, the exiting root is away. Rather, in transforaminal approach with lumbar spine, the exiting root is in our way, so causing injury. So here, thoracic spine, you need not worry about the exiting root, and it's a safe corridor. And he published these findings in 2002. But the challenges of a thoracic spine, whenever anyone wants to do an endoscopic spine, the main thing is the rib head, which inserts into the disc space. And the foramen compared to lumbar, it is very narrow. And the intervertebral, interpedicular distance, that is the volume of the canal is small. And disc height compared to lumbar is less. And the PLL, which is often thick or calcified most of the time. And predominantly the thoracic discs are very hard or calcified or ossified. So this is a representation of the rib head inserting into the thoracic spine. You can see the lumbar vertebrae, the rib head goes and inserts into the disc space. So when you want to go there into the foramen, the rib head has to be addressed. But important finding to be noted here is, you see here from T2 till the T8, the rib head inserts into the disc space. As you come down beyond T9, 10, the rib head inserts into the body so that the space of the disc is free. So transforaminal approach D9 below is easy. D9 above, we need to understand, we need to address the rib head also. Here you can see what the yellow mark, arrow mark denotes the rib head, and the upper blue marks denotes the transverse process of the two vertebrae. So whenever you want to enter the foramen here, the rib head is in the way, so you have to drill this to enter the space. This is how, when you want to enter the disc space, you need to drill the rib head. So common use the same armamentarium used for the routine endoscopy, both transforaminal and interlaminar. And to just show the feasibility, I'll just show a case here so that you can understand how different it is from a routine transforaminal disc. And here it's a ossified disc T8-9 and also OIL D10-11. Patient came with a young patient spastic paraparesis. So I did a D8-9 transforaminal approach and D10-11 interlaminar approach. So this patient, we went from the left side because the pathology is on the left side, 8 centimeter from midline after calculating on the MRI on the console. Once we go there, put a needle, enter the space and put a sheet there. So the small technical tips here is, you cannot enter the disc here, so you have to land in the foramen. So this is a small video. I'll just run the video here. So it's a video here to show the cranial is the 9 o'clock, as because we're standing on the left side, 3 o'clock is caudal. So I'm drilling, once we land in the foramen, I'm drilling the facet. Here, one again, technical, surgical, anatomical understanding which should be done is, in lumbar, when we drill the foramen, we drill the superior articular facet first. Here in thoracic, we drill the inferior process first because the facet joint is horizontal here. So when we land obliquely, we are landing on the inferior facet first. So we start drilling the inferior facet and start seeing the joint. You can see here, I'm seeing the joint cartilage, then start drilling the superior facet. Now I'm drilling towards the inferior end, that's the pedicle facet area. So I'm just trying to thin out the bone. This is very important. You need to understand the 3D anatomy here. I am drilling the base of the superior facet, and you see the fat, epidural fat seen there. In this image, we can see the epidural fat in between. Anterior to it is the entirely ossified bone. That's an ossified bone anteriorly. That's a disc which has been ossified. And cranially, that is 12 o'clock, is epidural fat in the thecal side. And that's the facet. So this is how we get a picture, a bone above, bone below. So you keep on drilling till we have a good, clear picture of the anatomical findings. So I'm just drilling the inferior facet, that's a joint. And go deeper, that's the superior facet. So that's the tip of inferior facet there. I'm just drilling that. Once I drill that, I get a bigger picture, a better field of view. Now that's a tip of inferior facet. I just chip it off so that I can have a better view. And you can see the exiting root fat is coming at 9 o'clock. So just be careful there. So that's the joint. That's the facet joint. So I'm just keep on drilling the facet joint again inferiorly towards the inferior pedicle. Now you can see I have a picture here, the epidural fat and the thinned out bone. So I just remove the thinned out bone where I've eggshelled it, the bone towards the lower pedicle. I'm just removing the bone towards the lower pedicle so that I can get more space to see. So once you remove that fat, your thecal sac starts getting visualized. So that's a bone curtain still there. That's the facet bone curtain. And ventral to it is the ossified or ossified disc. So keep on removing the bone. So as I just clear this fat so that easy. Then I remove this part of the curtain. If thecal sac is visualized, you are always safe that you can have a sorry. So you can see here I've thinned out the entire bone there ventrally. That's the osteophyte, that's the disc which has calcified. Now I am trying to chisel it out. That's the entire bone. You can see the entire cake of bone from upper end plate to lower end plate. And here in thoracic spine, you should understand the calcification goes beyond the end plate. So it is a part of the body also has to be drilled to have a good detachment of this end plate osteophyte. So I'm just going inferiorly there, drilling so that I can chisel it out nicely. So I just, and again coming cranially, so you can see that is upper end plate drilling where I'm doing it now. So I'm just drilling on the upper end plate so that this entire bone can be chiseled out. Now I'll just chisel this bone. This is nothing but the calcified or ossified disc. So just chisel it now. Once I chisel it out, I'm thinning it out further. So here I almost cross the midline here. All I need to remove the shell. So just coagulating that's the thecal sac started visualizing now because we are removing the bone. That's the thecal sac seen nicely. That's a osteophyte or ossified disc. So I'm just hitting it. So here we use this all custom-made chisels so that it is safe, and you are always ventral here. The angle always helps you to be more ventral. You can never injure the thecal sac. So though you should be careful. So now I have almost gone to the opposite side. All I have to remove is this bone so that we are entirely decompressed. Just go further forward. This is a shell I'm just removing it. So remember here we are dealing with a D8-9 disc where if this has to be done in open surgery or microscopic surgery, we have to do a big surgery and do fusion. This is a disc which is calcified. I'm just removing it. Once we remove this, so now I have removed and I'm going and drilling the opposite side now. So removing the thinned out epidural calcified or ossified plate. You can see the upper end plate and lower end plate I have drilled more as a trumpet where you can have a wide area of clearance. Because of the rib cage here, we can err on drilling more bone. And I'm removing debulking the disc. The entire disc is removed here, and this is the end point. You can see there nicely. This is almost to the opposite end of the vertebrae. This is opposite side. I'm chiseling it out. So if you follow the principle, thoracic spine is very feasible and it's the best approach. My favorite approach in thoracic spine is the transforaminal, where we can deal any kind of pathology which is lying ventral to the thecal sac. So now I've drilled the entire bone which was causing compression and a part of end plate and vertebral body also, so that you are sure that you remove the entire pathology ventral to the thecal sac. Now thecal sac is free from this end to the opposite end, that's epidural, dorsal epidural space, fat seen nicely. Now ventrally, we have removed the entire calcium. That's ventral epidural space, and we have gone to the opposite end. So this is what can be attained using a transforaminal endoscope. And this is the post-op. You can see here, this is a 3 months post-op. Entire calcium has been removed, and we have given a very good thecal sac decompression here. And I also did the OIL at the same sitting posteriorly, which also you can see nicely decompressed. So this is one more example of a D9, D10. Again, we have gone 8 centimeters from midline, gone transforaminally. Luckily, you can see in the X-ray image, the rib head is not fusing into the space. So I did not drill the rib head here, gone directly inside. And this is the end point. You can see the nicely pulsating thecal sac, and we have removed the offending agent, and this is post-op. One more, this patient again came with spastic paraparesis of 2/5 lower limb. He didn't want a bigger surgery. And you can see here there's a severe canal stenosis, both ventral and dorsal. Because here ventral pathology is more, I went transforaminally 7 centimeters from midline. Remember, this is D5-6, so I have to drill a part of rib head, and you can see the post-op completely. The thecal sac is decompressed, and you can see the image. I have shaved off the rib head a bit, and we have here clearly decompressed, and patient recovered in 2 months. This is one more patient. This is one more patient, D7-8, foraminal disc, and I went 6.8, that is 7 centimeters from midline, and this is what a post-op, a completely decompressed foramen. Patient is doing fine. This one more example, so I just skip here. So because the lack of time, thank you very much. So the take-home message is thoracic spine is feasible through transforaminal approach, and for beginners, I request it's not an initial stage. Once you are familiar with the transforaminal interlaminar approach, the lumbar, then you are doing stenosis and fusions, then you can try thoracic. That should how you graduate in endoscopy. And I thank NSSA and the organizing committee for this opportunity given. Thank you.
Thank you, Sukumar. Dr. Dinesh Patel here. Hi, Kes.
Dinesh, how are you?
I'm fine. Hello.
Hello, yeah, I can hear you.
How are you?
Fine, fine, Dinesh. How are you?
Fine, fine.
So, good evening, Moda sir.
Well done, Sukumar. Thank you. Thank you for your nice presentation. Any question from the audience, please? Yes, Nidhi.
Thank you. Thank you, sir.
Sukumar sir, Nidhi here. Just one question. That one of the case you showed had both ventral and dorsal
Yeah.
compression.
Yes.
So why you left dorsal compression alone? When you went only for one side, just you felt that ventral decompression would be sufficient, or what was the thought process?
Yeah, so because in dorsal spine, whenever you are dealing with a anterior pathology, though there is some posterior pathology, most of the time it is anterior pathology because of the lordosis, because of the kyphotic spine in thorax. Even if you, in this case, if I had done only posterior, patient would have not recovered. So anterior approach is very important. And I thought because doing both ventral and dorsal would be too tedious. Thoracic spine, it will take a lot of time, 3 to 4 hours. Because when you need to drill the rib head, it is a D56. So need to drill the rib head, it takes a lot of time. So I thought I'll do a first ventral decompression. If patient improves, I will not touch the posteriorly. So luckily patient improved completely in 3 months and is doing well now. So I didn't do posterior decompression, though I have warned him that if necessary in future, we might require a posterior decompression. And there is a D67 also, there is small pathology. So he is under follow-up like for the past 2 years now. So yes, definitely, if doing both ventral and dorsal would be ideal. Here, because we are doing endoscopically, and it is a too time-consuming procedure, so I did only ventral procedure in this case.
Any questions to Sukumar? Okay, then Sukumar will invite you for the NSI 2025.
So all are invited
Rajkot.
to NSSI to
We are
happen
waiting
in
for you in
September.
Rajkot.
Yeah, thank you, sir.
Thank you.
Thank you.
We'll invite Dr. Umesh for giving his beautiful presentation. For only L5S1 surgical technique with video.
Yeah, good evening. Thank you, sir. Chairperson, senior colleagues, dear friends. So this is my last talk for the day. It's on Olive, so I've just modified it a little bit rather than directly jumping into a video on L5S1, which is which we have started doing in the last few years. I thought I'll give a brief introduction of the advantages of Olive's technique that we use from L2 to L5, but its applications, and then probably we'll be in a better position to understand why only L5S1 makes sense. So if you go into the evolution, when we migrated from an open T-lift to an MIS T-lift, the only complication that we were able to avoid is a left paraspinal muscle injury. You still end up on the dura, the amount of invasiveness to the area of pathology is still the same amount of peridural dissection, similar incidence of epidural sclerosis, epidural fibrosis, peridural radicalitis, the risk of injury to the nerve root or the dura. So that is where the lateral approaches come in. The lateral approaches are completely outside the canal. You don't enter the spinal canal at all. And through a retroperitoneal route, you try to achieve what we call as an indirect decompression. So the risk of epidural fibrosis, risk of postoperative nerve root, radicalitis, dysesthesia, all those things are completely obviated. And that is the whole idea. But that is not the only advantage of retroperitoneal or lateral approach. So if you see, the apophyseal ring is in the periphery of the vertebral body, and most of the times our cages are all in the center, that is the cancellous portion of the end plate, which is not a very strong area, and especially in osteoporosis, putting a large cage across the apophyseal ring, increases the biomechanical stability of the cage and prevents the rates of subsidence as proven in biomechanical study. Also, let me tell you that Olive is the only surgery which achieves interbody fusion by preserving all the natural structures of the spine. It preserves the posterior elements, the facet, it preserves the ligamentum flavum, it preserves the posterior annulus, PLL, it preserves the ALL. So even the facet capsular ligament, everything, all the ligaments of the spine are preserved only in Olive while achieving an interbody fusion, which is not possible in any other type of interbody fusion. So how does it work? If you're not removing anything, how are we achieving reduction of this or a decompression? So basically by ligamentotaxis. So once you distract the interbody, once you distract the vertebral body, because ALL and PLL are preserved, the vertebral bodies fall back in place. And also the bulging disc and the buccal ligamentum flavum get stretched, thus widening or opening up the intracanalicular space. But where it may make more sense is a degenerative scoliosis, where multi-level asymmetric disc space collapse can be corrected by doing a uniform interbody distraction. By doing this uniform interbody distractions, multiple asymmetric disc space collapse, as well as a lateral listhesis that happens in a degenerative scoliosis, can get corrected by an OLIF surgery. So there are several indications which I'm not going into too much of a detail. It's used in spondylolisthesis, lumbar canal stenosis, adjacent segment disease. But where it makes more sense is a degenerative scoliosis. This is one of the adjacent segment diseases where you can do a standalone anterior approach. You can do it in degenerative scoliosis, pseudoarthrosis after PLF, post-infective cases. In all those cases, you can do an OLIF surgery. Basically, any case where it is suitable and an interbody fusion is required. But what is important to consider is where OLIF is not applicable, where you will not be able to do a retroperitoneal approach. That is basically due to the anatomical constraints of the iliac crest or vascular anatomy, previous retroperitoneal surgery, where OLIF is not efficacious, where you will not be able to distract. See, I told you the OLIF relies on a uniform interbody distraction. Now, if you are not able to distract the segment, obviously OLIF is not effective. Where you will not be able to distract, where there is a large osteophyte, lateral osteophytes, the facetal calcifications, capsular calcifications, disc calcifications, where the segment is collapsed and calcified. So in those cases, you are not able to distract, and their OLIF is not effective. Pathologies where even if you distract, the pathology is not getting treated. Now, listhesis, pseudo bulge, the pathology gets corrected when you distract. Whereas if there is a superior articular process hypertrophy, osteophyte jutting out from the superior articular process, front back foraminal stenosis, severe central canal stenosis. So these are not going to get corrected no matter how much you distract the disease. So the pathology is not getting corrected. So OLIF is not applicable in those cases. So coming to the technique in brief, basically the patient is in a right side down lateral position, right lateral decubitus position. You put an incision around 5 to 8 centimeters anterior to the disc space. In multiple levels, you can go in front of the vertebral body, and you dissect through the abdominal muscle layers and enter the retroperitoneal space to run on the surface of the psoas muscle to identify the anterior border of the psoas and identify the OLIF window that is there between the anterior border of the psoas and the vessels, the abdominal vessels that are there. And that forms your OLIF window. Now, that is the route in which you are approaching. Now, this maneuver is very important. See, if you go directly straight down in the oblique trajectory, you are going into the contralateral foramen. And that is something you should avoid putting a cage in, because the cage may compress the contralateral exiting nerve root. So that is why you need to do what we call as this orthogonal maneuver. That means you have to do that orthogonal maneuver so that you are aligned your cage parallel to the long axis of the disc space. So that is orthogonal maneuver, and this is what happens. So you go in an oblique trajectory, and then you do an orthogonal maneuver in order to align your disc perpendicular to the long axis. So, and this orthogonal maneuver has to be done at each stage of the procedure. So this is again contralateral annular release is important to achieve that uniform interbody distraction. Then you put in an appropriate trial size and then a cage in order to do the distraction. Fix it with a posterior percutaneous. So this is just a case example, single level spondylolisthesis. I'm not going into the details. So nowadays we do it with a 3D navigation system. It can be done even without a navigation, but this is what we are using now. We put in our screws in the lateral position itself. And anteriorly again, we can do it simultaneously front and back. So one person will be doing in the back, one person from the front. And this is what we are dissecting the abdominal layer. So this is the fascia of the external oblique. This is the only one that needs to be dissected, or a sharp dissection needs to be done. You then separate the fibers of the external oblique, the internal oblique, as well as transverse abdominis in the direction of its muscle fibers. And once the transverse abdominis muscle is opened, you find the transverse fascia. The transverse fascia can be incised or can be just punctured, and you find the retroperitoneal fat. Once the retroperitoneal fat is there, then you identify the posterior abdominal wall and sweep all the retroperitoneal fat anteriorly in order to identify the psoas muscle. So that is the psoas muscle. So this video is a compilation to see what are the structures we need to visualize, or sometimes that may come in the way. So this is the genitofemoral nerve, which can be seen on the surface of the psoas muscle, especially at L3-4 or L4-5. It's very rarely you may come across an anomalous ascending lumbar vein Again, it's very important to identify, coagulate and cut this because this directly comes from the common iliac. And sometimes this may lead to catastrophic venous bleeding if not identified. You can see, sometimes confuse the anterior fibers of the psoas tendon with the nerve root, and it's important to identify that. And then you dock your retractor, and then you do a sequential dilatation in order to get the access to the retroperitoneal root. And this is how you're going to visualize. You're seeing the annulus there. You incise the annulus. You do a good interbody work. It's very easy to remove the disc from an olive window because it's a very large area that you get there. You remove the end plate both superiorly, inferiorly, standard principles of end plate preparation. And once that is done, you do your orthogonal maneuver with all these techniques. Release the contralateral annulus as we have seen there. You release the contralateral annulus both superiorly as well as inferiorly. And then you assess your trial size. So this is the trial. You see what is the best fit for that particular display, how much you need to distract, what is the length of the cage, and what is the footprint that you need to have. Usually we fill it with an autograft that we have gotten from a cadaver bone, because only if you are not removing any bone, you don't have any graft with you. You always need to rely on an autologous autograft. So, an allograft, where we get it from our bone lab, the bone bank, and we mix it with the patient's marrow blood that we aspirate while fixing the percutaneous frame for navigation. And once that is done, you put in your cage using the same orthogonal maneuver. And after that is done, so you again do your screw fixation from behind. So this is the one. So if you see the listhesis is corrected, the canal, this is all without entering the canal. So this is basically a canal remodeling technique. It can be used even in collapsed disc spaces, grade 2 listhesis. Even severe cases like this, if you see the standing X-ray there is hardly any displace, bone on bone. But usually what we do in these cases, we do a full extension lateral view. This has been by a Chinese paper, a wonderful technique. You do to see the distractibility of the segment. So that gives a very good impression. Now you see the bones are already aligned over there, and then you just do an OLIF in these particular cases, and that gives a good reduction. But where OLIF, as I already mentioned, makes a huge difference is in degenerative scoliosis. Even difficult case of region scoliosis, which used to require multi-level fixations in the beginning, can be actually done very easily. It's easy to just jump from one disc to the next in an OLIF procedure once you have got into that retroperitoneal trajectory and identify the anterior border of psoas. And even in what you feel like complex deformities where there is a significant imbalance, just doing 2 to 3 levels of OLIF can actually restore the balance in a very significant way rather than going for multi-level fixations in these particular cases. But what about L5S1? Because we know that if you go from a retroperitoneal route, you are directly across the vessel because the vessels have divided. You have the common iliac vein, you have the common iliac artery there. So what do we do for L5S1? And of course, you can always say that you can go anterior and you can do it between the blood vessels there. But again, if you do an anterior, you again need to flip the patient posterior. That becomes a second surgery rather than doing a single stage position. So this is what we do, OLIF, that is we do a L5S1 intervascular between the two vessels, between the two common iliac vessels. We can do interbody fixation at L5S1. And at the same time, in the lateral position, we can fix screws from behind. So this is the OLIF corridor. That is the oblique corridor that is there. So these are the plates that are being positioned, and we are looking into the L5S1 this space over there. So this is again a short video. We have already dissected the abdominal vessels, abdominal muscles. And this is the retroperitoneal route. So you go there, you put in your retractor, you can faintly make out the vein, that is the common iliac vein there. So it's very important to be very meticulous in our dissection at this area. So identify, gently go through the layers, do the retroperitoneal dissection, avoid any kind of traction on these vessels because the vein these are very flimsy walls and sometimes these can easily break. So you dissect that, identify and free the vein over a long period because you need to retract long level because you need to retract the vein under this retractor as you can see there. And once that is done, you go gradually on the disc space, dissect all the small vessels, identify the median sacral vessels, identify and cut them. And then once you have done that, so that those are the median sacral, you need to go beyond the median sacral vessels. And then once you have done that, you can do a bifurcation retractor. You can place a bifurcation retractor. As you can see, the vein is popping out from there. So in these cases, you can use a third retractor that is called a bifurcation retractor that is there. Once that is done, you can do incise your disc space. So here, what we have to do is a reverse orthogonal. So in OLIS 4-5, you are doing like this. In a L5S1, you need to do the other way. So that is what we are doing. As you can see, all our instruments are going down rather than going up over there. Again, you prepare your end plates correctly, identify that thing, and once, again, this is a trial size. So this is a indigenously designed cage that we have developed now. It is not yet available for common sale as of now. So we are still doing that. And the screws go in through the cage itself. So as you can see there, and once the screws are done, then you can fix in your final locking screw. Once you remove the retractor, we should always be very careful about how the venous structures are. Make sure that the pulsations are good. There is no thrombus due to your prolonged retraction. So especially when you're doing multi-level, it's very important to, again, as I told. So this is again for L5S1. So I will not skip the L5S1. Once the L5S1 is completed, I'll show it to you. So once the L5S1 is completed, it is very easy to go to the L4-5 trajectory through the same incision itself. So that is the vessel that is there. Now, we are just going up, moving up on the vessel. This is L5S1 that has been completed. And here, again, we are going into the L4-5 trajectory, L4-5 level where what we were doing. So it's very important, very easy to identify. The vessel was still now pushed laterally. Now we are just retracting the vessel more medially. So that is the sympathetic chain. There is one just branch of the sympathetic chain that is going ventral, that is going posteriorly. You can just transect that, and that makes the chain free, and you can actually retract the sympathetic chain anteriorly. And once that is done, you do that. Again, here the orthogonal maneuver will be in the other way. So again, this was an example for a 2-level spondylolisthesis, a single stage lateral position. You see the guide wires are already there in position from the back as we are doing the anterior work as well. So this is the end point. It can be even done for multi-level fixations, L5 to L, this is a L1 to LS1 fixation. So just a take-home message, OLIF is an outside the canal, outside the muscle approach, preserving all natural structures of the spine. The only structure that you are removing is the disc. It gives superior coronal correction than any other lumbar interbody fusion technique. And it gives a very good lordosis prevention, especially if you include L5S1 in the construct. It's faster, safer, definitely less blood loss than the same extent of disease if you want to do it posteriorly through a open technique or even that be. Thank you so much.
Thank you. Now paper is open for discussion or question, please. Okay.
OLIF or would you do TLIF? So again, depends on the symptomatology. So most of the times, if the pathology, as I already mentioned, if the pathology can be corrected by uniform interbody distraction, then OLIF is always a better option. Now, many times in a degenerative scoliosis, the symptomatology may be unilateral or bilateral radicular pain, either due to compression due to foraminal stenosis or due to a nerve stretch on the convex side. So both of these can be corrected by OLIF alone. We don't need a direct decompression in either of these cases. Now, the other thing is back pain. Most of the time, these back pains are related to either a sagittal imbalance and a global back pain or a mid back pain. Even that also gets relieved once you correct the coronal at a sagittal disorder. So if the pathology is something like an acute disc prolapse, like say, for example, now, despite a degenerative scoliosis, there is a small fragment that is the one that is responsible for the radicular pain of the patient. Or if there is a severe osteophyte, canal stenosis in the absence of rest symptoms, OLIF is a good option. In the presence of rest symptoms, if it is just a claudication pain, even the literature has shown, and even we have some studies where the canal remodeling happens over a period of 6 months to 1 year. You do a severe stenosis where the patient does not have rest pain. Patient has only claudication symptoms. We have an immediate post-operative MRI which shows that the stenosis is still there. If you ask the same MRI to others, they will tell, okay, I still need to do a decompression. But the patient is asymptomatic, and you do a repeat MRI after 1 year, the ligamentum flavum becomes thin, the disc settles down, the canal opens up. So this is more of a remodeling technique than a direct decompression. And as we know, lumbar canal stenosis is a dynamic symptom. It's not like a static symptom.
Yes, Sumit.
Yeah. So you want to ask anything?
So, sir, do you have to put pedicle screws always for olive or?
So there are studies where standalone anterior fixations have been done. And there are studies proving that they are biomechanically not as strong as a posterior. Now, L5S1, if you are not dealing with a spondylolisthesis, if there is no pars defect, and if you are ready to use PMP, a standalone anterior L5S1 can be done. But if there is a pars defect, irrespective of whether you are using PMP or not, an additional posterior fixation is recommended. But there are people who have done standalone anterior even in spondylolisthesis and shown success rates. But it is biomechanically speaking, it is not as strong.
You spoke about contraindication at more than 40-degree corpse angle curvature is a relative contraindication for putting an olive cage. If you have a case of a deformity correction, you have like a L3 hemivertebra, which needs to be excised for a correction of a lumbar scoliosis. In that case, do you think olive will be a good option? Because I've been thinking about whether I should do a person who has crossed 18 years of age, but right now wants a correction. And I was thinking whether remodeling slightly of the end plates at above and below vertebra and olive will be a better option, apart from the pedicle screw fixation.
I have no experience of we have done corpectomies using an olive approach. We have done corpectomies, published it also, but I don't have an experience about hemivertebra excision, how effective that is going to be. But I assume that if we are, in case if it is not at L4, if it is anywhere above L4, L3, L2,
yeah,
probably it could be achieved. It could be achieved. But if I understand the pathology correctly, in a hemivertebra, it is not essential or it is not enough if you just remove the anterior body. You need to remove the posterior one side pedicle as well.
Correct.
So that will not be possible with an olive. You still need to do an additional posterior.
No, so posterior surgery is a given that we need to do that, and we need to do correction as well. But apart from that, from the anterior, what we just remove the bone. I was thinking whether maybe your technique so beautifully done, if it can give a better anchor.
No, if it is disconnected from the posterior element,
yeah.
If the vertebral corpus is disconnected, like what we do in metastasis or like what we do in infection, where it is just a body that. So yes, it is possible to do that, but I don't have any experience.
Last question, Umesh. Can you do lateral fusion by putting some screw and rods?
We have done that, sir. We have done that. I even showed one example, and that is preferentially done for adjacent segment.
So it will be in a single level
Single
incision only.
There are
single incision.
Single incision only from the retroperitoneum. We can put, but we are not biomechanically as strong as the posterior.
Thank you very much, Umesh. Now, I request my co-chairman, Dr. Dinesh Patel, who is a senior consultant at Bhagwati Clinic, Rewa. Rewa is a town, city, I should say, at the border of MP and UP. It is near Allahabad. So, just border area between two states. And he will be presenting
unilateral backward.
yeah. Unipolar endoscopic approach for the lumbar canal stenosis. So that was asked. I'll tell you. Yeah.
Thank you, sir. I have seen that leaflet that is written Dr. Dinesh Patel, Reba and MP. Most of the people don't know where Reba is, but Reba is famous for white tigers. World's first white tiger found in Reba. Thank you, sir. Thank you, NSSA. And organizing team, especially Dr. Ashish Tandon sir, for giving me an opportunity to present this topic today. Today we will discuss about unilateral biportal spinal endoscopy. We will discuss today with history, basic concepts, and advances in UB. Basic concept of MIS and UB or endoscopy is what? From big to small and small to big. Big to small means from big incision to small incision. That leads to less trauma to the tissues and early healing. And from small to big, there is a problem with microscope, even some endoscopes. Vision is the problem. Then we need larger vision, panoramic vision. Both the things will be deal with UV. There is small incisions and panoramic view. Inside the ligamentum flavum, dura, you can see everything. Why UV? It is most innovative method. And its indications are nearly equivalent to open surgeries. Nearly equivalent to open surgeries. And it is developing at a very rapid pace because we all neurosurgeons are well versed with posterior approach. And this is true posterior approach. Historically, it is grossly started in 1990s by Dr. Anthony Abdul Ghaffar, Solomon, Dr. Inju, Jin Hao, and Sang Kyu San. And the term biportal is given by Koreans in 2016. And after that, it developed at a very rapid pace. Basic anatomy for the UB is, it is basically a posterior approach, and we are using atraumatic corridor that is between the multifidus muscles, that is interfascicular space, and another space is fat containing and connective tissue between the lamina and the multifidus. When these two corridors combine, that develops into an atraumatic corridor. We can see the multifidus. Multifidus usually arises from the mammillary body and inserted in the spinous process 1 or 2 level above. The cross-sectional, when we make an incision, then skin and when we are making incisions, then skin, connective tissue, thoracolumbar fascia, and then multifidus, and we directly on the over the lamina. Indications of UV in lumbar region, central, paracentral, foraminal, extraforaminal, recurrent calcified discs, quad Icona syndromes, and stenosis. Even spondylolisthesis. In cervical region, foraminal stenosis, canal stenosis, and paracentral disc. In thoracic region, thoracic canal stenosis, ossified ligamentum flavum, synovial cyst. These are large number of indications. Even some people are doing tumors. Advantage of UV is over the conventional approaches, muscle preservation and bone manipulation. Basic steps of UV, we usually operate these patients under general anesthesia. Some people even preferred in epidural and hypotensive anesthesia. That leads to decreased blood loss. Instruments required are endoscope. You can use 0 degree, 25 degree, even 30 degree, according to your preference and degree of view. Drill system is required, RF or plasma, as your economy will allow. Surgical steps, skin marking, patient lie in a prone position. You can use postures in a horizontal or in a cross-sectional as you wish. One important thing in UV, if a patient is fatty, then you feel happy during operation because your hand almost supported with his back. If patient is thin, you'll be in trouble. You have to hold this way. Heavy patients are good patients for UV. Skin marking, you have to make AP and lateral view, confirm the level, and then initial target point is the spinolaminar junction. First mark the midline, and then mark the mid part of the disc space. It makes a reference point. As you see in this is we are marking midline. Then this is the mid part of this disc level. This type of marking we are preferred. There are two ports, two skin marks. One is for working portal, which is located just medial to the pedicle and lateral to the spinous process. Second is opic portal, that is cranially 2 to 3 centimeters from the instrumental portal. Final, this picture is like this. Working portal makes skin incision, then thoracolumbar fascia at the same level. And put initial dilator, then serial dilators, and make mediocranially direction 2 to 3 times. If you make more, then you will damage the muscle fibers, which will hinder your during surgery. So don't make two and fro more than 2 and 3 movements. Then scopic portal, insert the sheath with the obturator and make a triangulation with the serial dilators and obturator with the sheath. So irrigating saline will come out from the working portal. This is very important. Otherwise, your fluid is going in and not coming out, and that makes bulge of the pad. Check for the output of irrigating saline. One important thing is this is hydrostatic pressure of the saline, which is going inside the bag. How can you measure? Distance between the patient and the saline bag, which is in centimeters, divided by 1.36. That usually roughly comes 2 to 2.5 feet above the body level of the patient. Otherwise, that leads to complication. If there is a blurred vision in the absence of bleeding, you can check for that there is a fluid collection in the space. Then repeat the dilatation and dissection of dissections. Then start with laminectomy. Laminectomy is usually 1 to 2 mm or maximum 3 mm, depending according to the pathology. If there is a canal stenosis, you can drill more. If there is only disc, you can drill minimum amount. Drilling of the lamina, start from the lower margin and gradually come upwards. Start at the spinolaminar junction. If you operating a lumbar canal stenosis, then you can drill the spinous process and go opposite side. Removing of the ligamentum flavum. After that, identify this. the clarity of view, even in transforaminal and even interlaminar. It's a panoramic view. Everything is very clear. Even the blood is going in the vessels is also, we can see this. This is the dura, and there is a disc behind this. Drainage and closure. Surgical drain usually not required. Some people prefer. If you prefer, then 50 to 100 cc drain can be inserted through working portal. If you find that there is a soft tissue water retention, then decrease by repetitive skin compression and around the portals. Complications, bleeding, one of the major complications. Traction through the nerve roots, dural tear. Related complications are headache, nuchal pain, epidural bleeding, seizures, intracranial hematoma, and even blindness. Hypothermia, some patients develop hypothermia, can be prevented by piperacillin and heating pads. Studies on UV med showed that there is no superior results as compared to other discectomy techniques. But advantage are less operative back pain and shorter hospital stay. Take home message for the beginners. Someone is doing UV? Anyone? Yeah. Beginner should start with open surgeries, followed by, if he is confident, then start with the endoscopic spine surgery. Initially choose simpler cases like canal stenosis, in which there is discectomy is not required. Then laminectomy, safe ligamentum phlegm removal, exposure of the nerve root, and then finally start with discectomies. Beginners should, there is a limitation in the UV for the right-sided diseases. Initially, if you are a right-handed person, never go to the right side. It will create problem to the patient and yourself. If you are experienced, then you can go to the opposite side and operate. Even you can operate with left-handed on the right-sided. Then there is no problem. A case 30 years male presented with back pain radiating to right lower limb, MRI L4 5 disc. How we use drill? You can use drill like Medtronics, Striker, anyone, or what you have. The disc removal. After 2 hours of surgery, patient walking. Then after 12 hours, patient is happy. See the difference between 2 hours and 12 hours. Fifty-year male presented with Podykina syndrome. Who is this? Next morning he is walking. with some difficulty. Small incision, small suturing. This 45-year male presented with pain radiating to both lower limb with neurogenic claudication, L5S1 listhesis. See the listhesis. One important thing in for the fixation incision, which is for working portal, that will be at the level of disc. Otherwise, you are not able to put the cage. These are the 4 small incisions. Thank you. Any question?
Any question, please? Ashish. With this, I think we will end the session. And we'll have a tea break. Before we have a tea break,
I would request Dr. Prakash Moda sir to please felicitate Dr. Dinesh Patel sir.
Thank you, all participants. A few announcements. First of all, after the session, for the delegates, we have 3 workstations. The first would be conducted by Professor Vijay. That's at the stores counter. He would be showing on VTOM and his experience. So that's first for 20 minutes. Then the next would be taken up by Dr. Sumit. He would be showing here. So after that, you come back here for UB. He has got certain models which he has created himself for teaching purpose. So please utilize that facility. And then after that, Dr. Rakesh Lohana would demonstrate pedicle screws. If you have certain questions, you can ask. That was the first announcement. The second is today the dinner is we have a banquet dinner at Hotel Satya Ashoka, which is just about 5 minutes from here. Vehicles would be ready between 7:30 and 7:45. You can leave by 7:45. And for those who are fasting, you may have a meal as per the fast schedule. And I think Mayuresh would now help with the workshop. Thank you.
I request everyone to please join the room in front for a first demonstration by Dr. Vijay Parihar for VTOM.
Okay. Check sound. Sound. Check. Check. 1, 2, 3. Check. Check. Check sound. Check. दोनों पर क्या पहले हमारी मेरी पहले से पहले खतरा check sound.
check sound. Oh, bus. Check sound. सही है। परफेक्ट। एक भी वो नहीं, नॉइस नहीं। Sound check. Check sound. 1, 2, 3, check. Check sound. Check. So check. Check sound. Check. Check. Play. Check. Play.
Hello, hello. Hello, check, hello, check, check, check.
Next will be demonstration by Dr. Sumit Pawar for UB. I request everyone to join him.
So what we have done, let's quickly model of spine. Here. Hello. Yeah, this is the basic model of spine. Okay. And then you can punch it. The consistency is very similar to a human bone. So any instrument that you have to try, you don't want to try it on your patient first. You can try it on this bone. Safe sound for us. Then we made this mold, plastic mold, and we have put memory foam inside. So memory foam gives, this is an empty, this is just a bone inside and it's empty so that you don't see what's going on inside, but you have to get it by your feel. In this model, we have put memory foam to get a proper feel of a skin and a turgor. And ऊपर ये skin वाला silicone लगाया. This is just for practice, for your own practice, so that we have made one model in which the nerve roots, if you touch them, light लगता है, आवाज आता है, so that it's very good for transformal. But then I stopped doing TF, so वो model ना के develop किया नहीं. If you want, we can develop that also. So what we are doing in UBE is that, suppose imagine that this is the level that is under discussion. This is a 4 or 5 disk space, and 4 or 5 delineated and marked that this is my target level, just the way we have marked over here. Thank you, sir. And this is the midline. We don't have a CM over here. So this is all we have to imagine. Now we have taken a CM and we see that this is the disk space, a bit too large for our choice. This is the body. And this is the pedicle. So the point of intersection of the medial pedicle line and about 1 to 1.5 centimeter above the mid discal line and over here. This will be your entry point for the UB. Here disc है. Disc का center, the middle line of disc. This is the medial pedicle line. You can see it is a medial pedicle line. Now from this, come 1.5 centimeter, 0.5 above. Come 1 centimeter above and below. Patient agar patla hai, you just need to move 1 centimeter above and below. Patient is very fat, obese. Better that you move, just imagine a triangle. Na? If patient is very obese, then you should go at least 1.5 centimeter above and below the line. So that the distance between these two lines is about 2 to 3 centimeter. Patient is very thin, reduce the distance. Patient is very obese, increase the distance. It really doesn't matter because you have a 30 scope which has a very nice panoramic view. So you can, even if you have taken the incident slightly up or below, you still can manage it. Now remember that although this is a disk space, when you enter, the lamina of this is going to be covering like this, right? The lamina, you can see this is a disk space, but lamina is going to be over covering till here. So don't expect if I'm going to start surgery from here. So initially, although my angle is going to be like this, when I enter, when I start the procedure, my instruments are going to be like this, and then it will move up. At the time of discectomy, again, my angle will be perfect angle. So don't get confused. Second thing, although my entry point is at the medial pedicle line, my docking is going to be over here because यहाँ पे, this is the spinolaminar junction, this. And this is going to be your docking point, starting point. This is the most easiest to feel, most easiest to palpate, and the most standardized position at which you can start comfortably, right? So how do you go about? Imagine there is a Siam. Imagine there is a knife, and we are taking a shoot. तेरा टूट नहीं जाएगा ना ये? मॉडल 2 ज़्यादा अच्छा बन गया. Yeah. You can feel. Now, this is a memory foam, so it is not going to give us as much play as your natural skin is going to give. Initial part of your surgery, you are going to take a bigger incision. The working channel, you are going to dilate that with this instrument. Imagine that you have taken a bigger incision, go inside, rotate it, and remove the memory foam in this case and this muscle from the multifidus muscle. Separate it nicely. Cannot mistake the feel that you're getting. So just try the feel. You know you're on the lamina. Correct? This is the feel that we're all used to. Yeah, correct. Now in this case, I think I already made holes on this model. So I'm doing same thing. Okay, I'm just feeling model गिरा हुआ लग रहा है. ये सर का है, ये जम का है. Let's see on the scope ना, देखते हैं अंदर क्या है. This has come from Mumbai. पर गिरा हुआ है. Yeah, this is the model has fallen down, because of which it has traveled from Mumbai to Jabalpur in Duronto train. So in the meantime, it has fallen. What we do over here is that always we don't never insert the endoscope directly inside. We'll insert with an obturator. Hey, obturator. No, that is for working channel. नहीं endoscope का कहाँ पे है? हाँ, obturator, yes. So love your endoscopes. Don't damage your endoscopes. Remember, we are just being on the field. We are not seeing any Siam. So it is a bit difficult to appreciate where you are exactly lying. Lal Baba. This kind of okay. You can see the beautiful So you have changed the design of this entire scope completely. We don't need such stopcocks over here. Remember Bernoulli's phenomenon in endoscopy. You have a big 3-liter bag, you have a big thick tube, all of you are using same thing, right? Then the fluid is coming over here. There is a very small entry point. There is again even a smaller entry point. The water that you're getting at the distal end is going to be very slow. you have a pipe of water. If you block the hole at the exit, फोर्स से आएगा पानी. आप यहाँ पे पैर रखोगे ट्यूब के ऊपर, पानी स्लो आएगा. So the diameter has to be smallest at the point of exit, which is why we have made a new design for this arthroscope also, the sheath, in which we have removed all these angles. Just a single entry point is there, which is very thick, and only the narrow part is just at the tip, so that the fluid comes with force and it gives you a nice ballooning out of the tissue. So this you can see is a memory foam mixed with all the let us start with the palpation. So these instruments are going to help you whenever you have done that sheath. This will keep the sheath open. This will keep the irrigation fluid that is coming from here. It can be under irrigation pump, it can be under gravity. It keep on coming over here, and the fluid keeps on egressing from this portal. Once you get an egress of fluid, nice, that means system is right now perfect and functional. Now you can put your palpation instruments and everything inside from this portal to see where you are triangulating. These are the steps, times at which you use the Siam normally to check the docking point. Okay. So once you get a hold of it, this is all memory foam. Imagine that you are doing this under nice RF with radio frequency. You can burn this all. The triangulation is the main purpose of over here. If you can see the tip of your instrument, now I can feel the instrument is touching my endoscope. That is the end point. This is the so memory foam के नीचे ये जो है, this is the lamina. Okay, you can see this. This is the spinous process. Let me reorient all of you. This is the spinous process. This is the lamina. This is the spinal canal inside. Okay. And this is the spinal, this is the lamina. The superior edge of it, the inferior edge. Laterally, if I withdraw slightly. Thank you. This is the facet joint. Can you appreciate? Give me a bone punch, please. ये middle ये यहाँ पर. So your laminar spinal junction, because even in your live surgery, you will not see the entire thing because you are going to dissect everything with the, you are going to burn everything with the radio frequency probe. Only then you can see. But the first thing you should be seeing is this. First thing, yeah, this has to be a starting point for everything because you just get a feel of it and you always know this step. Of course, यहाँ पे empty नहीं होता, यहाँ पे अपना spinal ligamentum होता है. There is always ligamentum over here. But this step is what you always distinctly know. and always stay on this step only. This is your indicator because initially in UB, as compared to our interlaminar technique, in UB, it takes a few more minutes to identify the lamina. Actually, based on the palpation, where you are landing, and then you have to meet the palpation over there. So this is the only palpation that you can best feel over there, the lower edge of the lamina, the target level, correct? Just try to feel it if you want. Yes, step. Now imagine that suppose I have done, will you doing, पंच है आपके लेकिन ना उसको दिखाना पड़ेगा ना कोई तो इंस्ट्रूमेंटेशन दिखाना पड़ेगा सर एक मिनट ये निकालेंगे so you can see the hook over here. Now this is the beauty of 30-degree endoscope. If I rotate my endoscope, I am looking at the, of course, this we have not drilled anything over here. But can you see that I am looking at the foramen on that end? So this is the pedicle. Yeah. This is the pedicle. This is the foramen of the opposite side. This is the midline. Midpoint is यहाँ पे hold दिखता है वो midpoint है in this model. समझा क्या? So it is continuously under irrigation. So all the debris that you're collecting keeps on getting self-cleaned. You can see the punch. Now this is bleaching that is occurring. थोड़ा brightness कमी कर जरा. Brightness कम कर दे. Now you can see better. ऐसा लग रहा है struggle है करके. There is no struggle in actual patients. It is easier. You practice on this kind of a model, and then patient actual surgery will become actually easier and a joke for you because यहाँ पे आप बिना RF का बिना CM के practice कर रहे हो. What we normally do is we take these models in the OT. You have entire instrumentation over there. Once the daily list is over, you take these models in the OT. Permission का जरूरत तो है नहीं. It's a standard plastic model. Request sister को request करके पूरा सब set लगा लो and keep on rotating your instrument inside to get a feel. You should be a master of navigation because this navigation is going to show you everything inside. And ये तो basic instruments you just try with the just a palpation number 4 dissector. That's also enough to get a hang. How to use the both hands and how they should come together below properly. No, so that is the beauty of UB that it is very flexible. So what we do is we take the CM. Never ever work in fatigue. We take the CM and CM के ऊपर ये हाथ हमेशा rest करता है. This hand has to be totally mobile. I need to take instruments from this hand. This hand totally, this much movement is required. So you always take the CM, sir. The smaller end of the CM, not a detector, but the intensifier. You keep it over here from below. You can rest your hand on this side. So CM becomes, CM यहाँ पे आएगा आपका. Display ceiling यहाँ पे आएगा. You can comfortably work like this. It's very ergonomically good for you. Your neck should not be twisting and turning at that point then. And this is very good for you to rest. You can please try, come on this side and see how the feel is. अगर ये आपका घूम गया camera, you have to remember to rotate it back. This all debris should have come out by now because of with the grasper. Correct? But ये जो UV set है इसमें grasper नहीं है. क्यों? Because you have grasper in your every single set. This set need not have it. This is only pure UB instruments. 8-10 instruments are there. They're also repetitive and superfluous because like this is the sheath that we have, semicircular sheath. Left we used to keep the sheath open, the semicircular sheath. इससे क्या होता है कि पानी बाहर आते रहता है. अगर पूरा मसल कोलैप्स हो गया एक के ऊपर एक वर्किंग चैनल से, पानी अंदर ही भरता रहेगा. It will increase the CSF, the pressure also. It will just cause swelling on the back also. So this sheath is, इसका एक ही purpose है कि fluid जो अंदर आ रहा है constantly, it should keep on coming out also. The field remains clean. And it is very easy for me to slide my instruments along it. Like, you know, if I don't even need to look every time where I'm putting my instruments. I can just use this to slide and I can keep on doing my thing and my instrument place. Correct? बाकी कुछ भी नहीं है. योर सर्जिकल स्टैंडर्ड हैज टू बी एग्जैक्टली सेम. आपका पूरा IDSS आपको यहाँ पे करना है, फेनेस्ट्रेशन करना है. You can try your hand at it if you want. Sir, absolutely standard technique, sir. अभी ये सब अभी हाँ अभी मैं I'll just remove the bone. हाँ एक ही तो you put 2 instruments. वो nerve retractor कहाँ पे अपना? It's a beautiful instrument. It changes the one advantage that I find over interlaminar. हाँ. So this is a very big instrument. इतना बड़ा, normally we have a much smaller and delicate from this. Suppose I need to remove the disc. I need to use the knife also over there, and I need to use the radio frequency probe. So what we do is we remove this instrument. And, I have already done the bony removal and I've already done the ligamental removal. In that case, I slide this instrument inside and use this to retract the nerve root and the dural sac. Correct. And then you have to, I know where my instrument is, but I'm just because the bone is still over the lamina, we are not removed it till now. इसलिए वो डाल के फायदा नहीं है. You can see this instrument over here. Yeah, this is an instrument. This can be used to retract. But ये lamina के ऊपर है, मतलब it's not serving the purpose that it is made for. बराबर है. ये नीचे डिस्क है सर. If you remove the ये वाला, please everyone help me do the laminectomy. So we had put this plastic sheet जो दिख रहा है आपको. This plastic we had put so that the memory foam does not enter the spinal canal. The manufacturing issue. Drill लाया अपन ना? देखिए ना drill. पर पानी नहीं है ना अपने पास. लाना. Exactly over the ligamentum film. जो ligamentum के ऊपर जो cover कर रहा है उसको पूरा निकाल दीजिए. You need to have the ligamental opening, then you use the curette to separate the ligamentum nicely. You can see the disc space over here. Yeah. So this is the disc space. दिख रहा है आपको फिल हो रहा है, सॉफ्ट वाला है, ये हार्ड है. So this is silicon disc. You can see. The wider we do the laminectomy, of course, the more we can see. Yeah. Now, if you want to change the level from here, it is always that you have to lift entire thing above. You cannot use same two holes for doing the level above. You can't use the same hole like we do in interlaminar. One interlaminar hole we can do at least two levels. Some people do three level if the lordosis is exaggerated. Here you can do only one single level bilaterally with one disentry point. Because see, I can with angulation to my instrument, I can nicely reach below the. You can see where I'm reaching right now. This I'm below the spinous process, and with my angulation, I can properly see on that side. If I have more laminectomy, if I'm able to do more laminectomy over here, I can actually have a very good view. This is a inferior lamina. Yeah, absolutely. Even on the opposite side, significant. If you see the videos, even Dr. Dinesh Patel had shown the videos. Filtering the drill, which will obviate the need for this angle. See, my problem क्यों हो रहा है यहाँ पे? Because I am entering from an imaginary line drawn over here, not under Siam guidance. इसलिए मैं it's not in alignment with the exactly. Yes, sir. यहाँ से बाहर निकल जाएगा पानी. Okay, drill. I usually keep the instrument over there and I can leave it. The turgor of the skin, turgor of the muscle will hold the endoscope in position. Preferably put the water off or slow it down slightly so that you don't have an unnecessary swelling. Water will keep on coming out. Barative. Yeah. No, everyone please come and hold the instrument to get a feel. एक हाथ से feel आपको मजा नहीं आएगा. दोनों हाथ से feel कीजिए. So this is a drill. ये इंडियन मेड ड्रिल है जो हमने बनाया है बिकॉज अंडर वाटर मिडास का काम नहीं करता है एंड एक्सपेंसिव वन वी कैन अफोर्ड. सो ये यहाँ पे यू कैन हैव अ सेक्शन बिकॉज जो बोन आएगा कंटिन्यूसली ऐसे वी कीप ऑन रिमूविंग द पार्टिकल्स. NSK. एक मिनट है, आई जस्ट शो इट. थोड़ा प्लास्टिक भी ऐसे थोड़ा जलने वाला है. Ideally, this is supposed to be done under water. On, please. Since the view is beyond awesome, because I'm having a, just like your exoscope, I'm having a panoramic view of I really wish there was some irrigation over here. We could have flushed and we could have seen even better. But अपन इसमें अपन just पोंछ लेंगे हाथ से. नहीं ठीक है. अरे एकदम 70s की क्या बात. क्यों पानी है एक कप में पानी मिल सकता है. So you observe this older design of the endoscope sheath. इसमें सब holes जो है बाजू में. What used to happen because of this? Sorry, I'll just light. Bollywood. So you can see the 30-degree angulation. The older design has holes over here. What was happening? All the fluid was coming out from here. But at the tip where I wanted the pressure to be built up, वहाँ पे इतना pressure build up नहीं हो रहा था. So we kept on increasing the irrigation gravity और ऊपर किया, फिर pump लगाया. Then we had to use the irrigation pump. We were not getting a clue कि why it is happening. Then we changed the design completely, made it very very narrow, and only one point of exit right in front of the endoscope. यहाँ से. So what happens? Our view suddenly has become so clear, even only with gravity. If I put on with the newer endoscope, if you put it endoscopy sheath, the fluid is crossing the table entirely. If right now I put on the water over here, it will fall just up to here. धार जो है धार अच्छी हो गई है. धार अच्छी हो ना? Yes sir. Prostatectomy कर दिया. Light please. हाँ. अच्छा तो ये निकाल के करिए ना. एक मिनट. Yeah. So newer design also we have removed this completely. ये घुमाने का काम रखा ही नहीं है. Really wish we had some fluid over here. We could have seen a beautiful picture. Number 4. Confident. ये देखिए, you can see. See, we are doing everything is under imaginary Siam. please come and fill the instrument yourself and try for the bidextrous approach using both hands and only try for the triangulation initially. Whether you can see the instrument that is it coming in your view or not? Are you studying for that also? Once you achieve that part where both instruments you can see and you can use those to guide your approach, then you can take the next step, right? Okay, come. Come. Everyone come in line. Disconnect. Huh? Sorry? No, we should be just about the lamina. Yes.
Meanwhile, delegates can join Dr. Rakesh Lohana. He will be demonstrating pedicle screw fixation and tips and tricks.